Наш мир не стоит на месте. Он стремительно развивается и дополняется новыми данными. За 5 лет человечество произвело информации больше, чем за всю предшествующую историю. Прямо сейчас мы становимся свидетелями развития компьютерных технологий, освоения космоса и инновационных открытий в медицине. Современный образовательный процесс требует от специалистов постоянного совершенствования, в том числе и в вопросах научно-практической квалификации. Возникает острая необходимость в независимой площадке, позволяющей специалистам иметь доступ к передовым достижениям в области терапии. Евразийская ассоциация терапевтов – это уникальный глобальный проект объединения специалистов разных стран и различных областей клиники внутренних болезней, направленный на развитие и совершенствование помощи пациентам терапевтического профиля. Это современная площадка, предоставляющая участникам Евразийского медицинского сообщества доступ к уникальной базе данных, а также возможность обмениваться мнениями и делиться опытом.
Мы объединились здесь, чтобы сложить наши усилия в борьбе за долголетие, процветание народов наших стран.
В Ташкенте открылся 4-й съезд Евразийской ассоциации терапевтов.
В Минске открылся 5-й съезд Евразийской ассоциации терапевтов.
И мы всегда с оптимизмом смотрели в будущее. Нас объединяют общие корни, общая история. И я надеюсь, нас объединяет светлое, большое будущее.
Миссия ассоциации – создание международных медицинских, исследовательских и образовательных проектов между странами Европы, Азии и СНГ. Ассоциация проводит образовательные мероприятия с участием ведущих экспертов. Съезды, конференции, телемосты, школы. Научная программа конференций подготовлена с использованием современных образовательных методик и инновационных форматов. Сегодня ассоциация уже объединяет тысячи практикующих врачей и экспертов из России, Европы, Азии и СНГ. Она помогает совершенствовать медицинские знания и опыт каждый день. Для нас важно сделать процесс медицинского образования непрерывным, современным и максимально доступным. Вступив в ассоциацию, вы становитесь частью глобального сообщества специалистов, работающих под научной и практической составляющей современной терапии.
Подагра – очень часто встречающееся заболевание, и ее распространенность растет с тревожной скоростью. Это самый частый вариант воспалительного артрита у человека. Сопровождается мучительными болями. Это то, что вы вряд ли когда-нибудь испытали. Мой первый приступ подагры был очень болезненным. Боль была ужасной. Никому не пожелаю подагрической боли. По шкале от 1 до 10 – это 11. Сначала она поражает суставы, затем почки, затем сердечно-сосудистую систему. Ужасающие мгновения. Ты абсолютно беспомощен. Ты не можешь спать, абсолютно измученный и обессилен. Она смертельна. Мое тело перестало быть прежним с тех пор, как я заболел подагрой. У пациентов с подагрой повышен риск смерти. Но есть и хорошие новости. Подагру можно лечить. Самое главное – держать уровень мочевой кислоты под контролем. В пределах 360 микромоль на 1 литр. 360 микромоль на 1 литр. 360 микромоль на 1 литр. Лично я снова вернулся к жизни. Нам нужно распространить эту информацию. Помогите нам, поддержите нас, поделитесь этим видео, переходите по ссылке, посетите этот сайт. Ваша поддержка может изменить их жизни, нашу жизнь.
Добрый день, уважаемые коллеги, доброе утро. И мы переходим к третьему заключительному дню.
Hello, dear colleagues. Good morning. And this is the third day, final day of our 10th conference, of our International Conference of the European Association of Therapists. We'll have an interesting and fruitful program, just like we had 2 days ago. And if in 2 days we were speaking more about hypertension, anticoagulants, COVID-19, and yesterday we had 2 symposia on this, today we'll have a speedy session today as well, and the focus will be heart failure and diabetes mellitus. We'll speak about the diagnosis of cardiovascular pathology, osteoporosis, gout disease, and I want to announce the 3 symposia that we'll have here in Moscow hall. Will have the gout disease symposium, and the experts will share their opinions, what to do with the patients, how to improve the symptom manifestation and prognosis. In St. Petersburg Hall, there will be a symposium from our Serbian colleagues on thoracic pain, chest pain, and in case patient doesn't want stenting, what are the guidelines, what to do. In parallel to this, in Perm, there will be a symposium on combined drugs in fixed combinations to treat the cardiac patients. We'll speak about thiazide and non-thiazide diuretics and combined drugs. But let me go back to Moscow Hall. Everybody will choose a hall of their interest. But I want to go back and say that gout disease and hyperleukemia is a condition which very often worsens the quality of life of the patient. He normally has concomitant pathologies and his life expectancy is endangered. All the technologies available to us must be used because it improves the forecast and quality of life of our patients. I want to give the floor for the introduction
Передаю слово для вступления. Прошу прощения Елисееву Максиму Сергеевичу, город Москва.
To Maxim Yeliseyev from Moscow.
Добрый день, уважаемые коллеги.
Good afternoon, good morning, dear colleagues. Great pleasure to welcome you at this wonderful Congress. Indeed, this is a unique Congress in terms of the variety of its content. It is extremely informative. Our symposium today will be dedicated to not local, but rather global problems associated with hyperleukemia, gout disease, and the information the information we have today has to be shared. If recently we saw information that some types of cancer are associated with hyperuricemia, and it is considered that the reduction of a level of uric acid can help in these comorbidities.
вступительном клипе показано,
As it was wonderfully shown in the introductory video, gout disease is a disease that can realistically be controlled.
Тех, которые будут предопределять необходимость этого адекватного, этого.
Let's start from the things that will define the need of this aggressive treatment. We'll speak about osteonecrosis, osteoporosis, and gout disease, bone destruction. And these conditions are often encountered in rheumatology, in therapeutic practice.
Как мы можем помочь таким пациентам? Наш сегодняшний доклад.
How to help these patients. This is what my presentation is going to be about. This is the disclosure of the conflict of interest on this slide. Where are the crystals developed? We know that there can be different crystals, organic crystals, main calcium crystals, osteoarthrosis. These are pyrophosphates, deposition of calcium crystals, and gout disease. One of the oldest known diseases associated with the deposition of crystals. Crystals may cause inflammation. Where is this inflammation developed? Where are the crystals formed? In case of gout disease, the crystals of sodium urate are developed in synovial liquid.
Способны потихонечку заполнять это пространство, осаждаясь на
and they are filling gradually the joint fluid and creating the depositions. Okay, so the crystals develop in synovial fluid and they also cause inflammation. Other crystals are developed in other parts of tissues. For example, pyrophosphate, calcium pyrophosphates are inside of the cartilage. So we say that they are developed in a liquid. How are they affecting the bone matter then? So we look at the crystal that deposits on the surface of the cartilage. Some conglomerates can be quite voluminous. We can see parts of really heavy depositions. On the left, you can see a huge size of a deposition. Depending on where exactly the depositions happen, they may look differently. Here are the calcium pyrophosphate, and we can see calcification of the cartilage meniscus. If it's osteoarthritis, we see proliferative processes associated with the deposition of calcium crystals. And when it's gout disease, we see, in fact, the destruction of bone structure, and the cavities are filled with uric acid. And as we know, uric acid cannot be visualized on X-ray, and in fact we see just holes in bone tissue. When we speak about gout disease being the oldest, we remember all our well-known doctors, Paracelsus, Egyptian manuscripts that describe very well the clinical manifestation of gout. But if we take the first living creature, then gout disease was found in Tyrannosaurus. Tyrannosaurus was not eating grass, not at all, and he had an increased level of uric acid, and therefore gout disease. They tried to analyze the toes and see what are the diseases whereby it is possible, and the conclusion was that the dinosaur had a gout disease. In other words, the first living creature and the first disease known to the humanity is this particular disease. The gout disease is around 65, 67 million years old. So what is happening? Why do we have depositions of crystals in the bones? Gradually and gradually,
и постепенно
the
вызывает воспаление уже в хряще.
tophi
Вот
masses
это, собственно,
become
всего
accumulated
воспаления.
in
Если говорить
on the
о
cartilage, and then
процессе
they cause
стадийном,
inflammation
что
in cartilage
называется,
and then in bone.
то
If we
вот этот
talk
вот эрозивный процесс, он
about the
постепенно,
lateral
естественно, развивается, но
process, of
самое
course, it
важное в
develops
этом это
gradually,
то,
but
что
most importantly,
вот воспалительный ареал, он
the
постепенно
inflammatory
начинает уменьшаться.
space is
И
slowly
для
reduced.
вот внутрикостных тосусов характерна
And
такая
for
зона
the
ограничения,
tophi
где
inside
идет
of the
очень
bones, there is a
активный процесс костного
limitation
ремоделирования.
area where there's
В
an active
случае, если
process of
кристаллы
bone
становятся меньше.
remodeling taking place in
Я
case the
это,
crystals become
я
less
это
in number.
всегда
I
сравниваю,
always
например,
compare this
с
with
Великой Отечественной войной. То есть
Great
полчища
Patriotic War.
фашистов наступают на нашу страну, да,
Let's say
но
armies of
сопротивление,
fascists are attacking our
достаточно
country,
мощное и активное
but
противодействие
the
этому процессу
resistance,
заключается
active resistance to the
в данной
process
ситуации
in this
в том, что
case
этот процесс
is
обратим.
in
Дойдя до
the
Москвы,
fact that
в
this
итоге
process is
война закончилась
reversible.
на
So
побежденной
fascists
территории. Так и здесь.
reached Moscow
Тот
and the
процесс
war
костного
ended.
ремоделирования, он может
In the
заполнять
same
и
way, the
отодвигать
process of bone
обратно кристаллы
remodeling
лауреата,
can
если мы
fill
назначим
in
адекватное
the
лечение.
space and
Далее мы
push
вскоре
back the
посмотрим, как это будет.
monourate
Что же мы
crystals
увидим вживую? Да, мы
and
говорим
squeeze
о
them
том,
out
что
in case the proper
кальцинированные
treatment is
тофусы,
given. So what do we see?
мы
We see
говорим о том, что
calcified
так
tophi,
они видны в виде вот этих
and
конгломератов,
they are visualized as
наполненных уже
conglomerates
рентген-позитивными
filled with
структурами
X-ray positive
кальция, да?
structures
А
of calcium.
рентген-негативные
The
выглядят в
X-ray
виде
negative
эрозий,
look like
как бы ничем не
erosion
заполненными, и
and
это
empty
так называемые
cavities.
пробойники.
And these are
Мы
the
можем
so-called
видеть их не только на рентгене тофуса, но и
cavities.
по данным ультразвуковой диагностики в виде
We
тех
can
же
visualize
внутрисуставных объемных конгломератов,
tophi not only on
в виде феномена
X-ray.
двойного контура, когда кристаллы пока еще
There's a
лежат на
double
поверхности
contour
хряща,
phenomenon
вот.
when the crystals are still on the surface of the
Вот эти
cartilage,
тофусные отложения на
while
современных
the
аппаратах мы можем
tophi
видеть уже и
depositions
в
on
области
modern
костных структур.
machines can be visualized
Магнитно-резонансная
in bone
томография.
structures.
Аналогичным образом мы видим огромных отложений
MRI, in the
Т2
same way,
решетки будут и в Т1 лучше видны, чем
you see
по данным
in T1 mode, it will be visualized
тем не менее,
better.
в любых изображениях,
In
любых
all
позициях мы можем
imagings,
видеть
in all
достаточно
positions, we can see
хорошо, если эти отложения крупные,
very
и это
well if
помогает
these
нам
depositions
дифференцировать
are large.
подагру от других заболеваний при
And this
особенно
helps us to differentiate gout disease from other diseases and typical pathologies.
сустава, предполагая повреждение менисков, там тофусное
There
отложение.
were some cases when the surgeons were operating on meniscus and then they would find the tophi depositions and they would treat it medically with medication without any surgical intervention. This is one of our patients with spinal column failure, and this deposition looks like tumorous tissue, and we achieved a good result. We fully eliminated these depositions in the patient. CT scan, just like X-ray, shows us the erosive process. We see the punched out lesions in the bone structure. So when do we anticipate tophi? When are they developed? If we're talking about the steps of the gout disease, normally patients with with Lesch-Nyhan syndrome, the tophi may develop or may not develop, and eventually they can lead to acute arthritis attacks. Every 10th patient with elevated level of uric acid develops gout disease. Nevertheless, it is impossible without crystals. And if we are treating the disease, we see these kind of severe cases of crystal depositions and destruction of bone structure. It turns out that the failure of You may think that the failure of bone structure is a later stage of the disease, but not at all. As I told you, we may have crystal depositions with patients at later stages of Leishman syndrome. Gout disease is not such a rare disease. In US, it falls on 4% of the population. Look at the history of disease of our patient. He is only 27 years old. He got sick in April this year, and 5 months before he visited our clinic, the patient had the following. The entire history of disease lasts for several months. Arthritis of the right toe. He took different drugs without significant effect, and then he cancels the anti-inflammatory drugs. Everything stops, then inflammation again. We administer colagicin. Gout disease is suspected, increased level of uric acid, but crystals are not detected. Disease is not proven. MPVP low dosage is administered. Then non-specific changes are described, so the doctors cannot differentiate what it is. They do the CT scan, X-ray, and they see this terrible picture. The destructive changes are evaluated by osteochondropathy by the surgeons, and then you can see the bone is almost destructed, and then they do the MRI of the right ankle joint. And let me tell you, the patient didn't get sick. He only had 2 attacks of arthritis. And the difference between the study and the first pain attack is only 2-3 months. So they think that it's a septic necrosis, and hypothetically, tophi are already described by us, and we assume that luckily this is not a tumor. We repeat the examination, we follow him up, and despite the low dosage of allopurinol, the sizes of these erosive changes keep growing. Colchicine, the patient continues taking colchicine. The surgeons recommend hirudotherapy, I don't know for what reason, and then they give up and they send the patient to us. We see the uric acid level in the patient is almost 500, despite the 200 mg allopurinol. We do the rescan, and we see his ankle joint bone, and bone is almost full of depositions of unknown etiology. We take the sampling. These are all crystals, and we definitively confirm the gout disease diagnosis. And this is the case when the disease can manifest from acute failures. The target level of treatment is defined for this patient in the same way as for severe patients. Can it be that at the early onset of gout disease, we have Leishman syndrome, and crystals are detected only in quarter of the cases? Gout disease and comorbidity. Let's look how it works on the population level. Osteoarthritis is compared in the groups of patients with gout disease and without gout disease. These crystals that are developed, the 2 cohorts were studied in the UK and in Taiwan, 2 countries where the world leaders of the patients with gout disease. In Taiwan, is the second most frequent rheumatological disease. In the UK, 2.5% of the population is affected. So it turns out that osteoarthritis is almost twice more often detected in the patients with gout disease than the ones that don't have gout disease. In other words, the failure of bone structure and cartilage is more frequent in our patients. We see that 1.5 times more frequently, they take glucocorticoids. We'll speak about them in a minute when we talk about the genesis of bone changes in our patient. This is a patient, male patient, 42 years old. We see the tophi on the surface of the cartilage. On the picture below, we see the almost completely destructed cartilage with erosion. The crystals of uric acid are gradually destroying it. Okay, so arthrosis occurs more frequently in case of gout disease, but in the UK, in Taiwan, the probability of prosthesis, the need of prosthesis is much more higher in the patients with arthrosis and gout disease than in the patients without gout disease. And it's not the knee joint, but it's rather hip joint. You may say that it's rarely affected by gout disease, but not at all. We see that more frequent hip joint prosthesis in the gout plus osteoporosis patients. This is our case, male patient, 41-year-old. It's a severe tophi gout disease. He was referred to us, he came in a wheelchair. It's a standard onset. In 2006, there was an onset of disease. In 10 years, he developed this severe gout disease and he started having hip joint. And this is what we see on the picture. We see huge cavities. We see the completely deformed heads of his hip joints. We see the tophi, huge tophi. We see the huge tophi in his coxal cavity. Patients with gout disease are prone to obesity. This is a mice study. One group of mice was fed excessively to cause obesity, and the other group was fed normally. One group of mice was given febuxostat and the other didn't. The ones that were given febuxostat developed inflammation of joints, and finally they developed osteoarthritis. However, the mice that got excessive food and took febuxostat, they didn't develop osteoarthritis. That is to say, febuxostat was suppressing this crystal-induced disease. In other words, let's switch from mice to our patients. Patients with gout disease. Risk of developing acute necrosis. We could see an acute necrosis of hip joints in this patient. Chondrocalcinosis was detected, and as for osteonecrosis, it was not detected. It seems that we may relax, but not at all. Look at the risk factors for vascular necrosis. These are glucocorticoids, alcohol consumption, hyperlipidemia, very often happens with gout disease, and also Lesch-Nyman syndrome. So these are the risk factors that we shouldn't exclude. 145 years ago, vodka was invented, and until now, our patients unfortunately celebrate the invention of vodka on regular basis. Let's look at how often it happens. Glucocorticoids. Osteonecrosis can develop only if the patients get only one injection of glucocorticoids. But how frequently do we inject our patients betamethasone or opsinolol? The surgeons treat every third patient in this way, specifically, I believe. But osteonecrosis can develop even when this therapy is used one time. Who would think? Let's look at the overall risk factors on our young patients. And we know that patients with gout disease are quite young. Half of them are glucocorticoids. Take glucocorticoids, 11% abuse alcohol.
Бедренная кость в другом исследовании посмотрели.
Hip bone
Треть
was
это
studied in
принимающие
another study.
глюкокортикоиды,
1/3 was
нередко
of the
алкоголики,
patients was
слушай,
taking
уже
glucocorticoids.
поражение
Quite
факторов,
often they took
связанных с
alcohol,
подагрой непосредственно.
and some failures were directly
Вот как
associated with the
клинический
gout
пример
disease.
в достаточно хорошем
This
журнале
is an
опубликованный.
example in a
Подробно
good,
представим
published in
один
a good
раз
medical
случай.
journal.
Пациент 57
We'll
лет, диагноз
also
подагры,
present you
терапия
later a
упомянул,
Russian
уже
case. This is
подчеркнут,
a male
терапия
patient,
упомянул. Тем не менее,
57
вот такая
years old,
ужаснейшая
with
картина.
gout disease
Мышцы будут
diagnosed.
изолированы в суставах полностью.
And this is a
Деструктивный
terrible
процесс,
picture,
и
despite
все
taking
заполнено
Caprinol,
кристаллами
fully destructive
моноура.
process, and
А вот наш пациент,
everything
36
is
лет,
filled
живет 31
with
год, уже за 5
monourate
лет мы видим
crystals. This is our
жуткие
Russian
изменения,
patient,
и в одном
36 years
насекомом
old.
этого
In 1 year,
6
he had
переломов
terrible
запястья. Это потому, что
transformations.
приступы копирования,
And in
опять
the
же,
past, he
положили
had
глюкокортикоиды.
6
Вот отложение
fractures
кристаллов
of
моноурата мы видим на
his
компьютерной графике,
wrist.
как, ну, скажем, полость
You can see the
в
depositions,
виде
you can see
эрозии
the
таких крупных, а на
cavities,
МРТ мы видим, что
like
это полости
large
заполнены
erosions. On
кристаллами моноура.
MRI, we see that these cavities are filled with monourate crystals.
Остеопороз. Казалось бы, тоже исходно
Osteoporosis.
считалось, что
Initially,
гиперлейкемия
it was considered
скорее
that
положительный фактор, и
Leishman syndrome
не
is
должно развиваться
mostly
остеопороз этих пациентов.
a
Ничего
positive
подобного.
factor, and these patients shouldn't develop
Популяционные
osteoporosis,
исследования
but not
опровергают
at
эту
all. The
гипотезу
population
защитной
studies
роли мочевой
reject this
кислоты, и мы говорим, да,
hypothesis
в
of the
четверти
protective
случаев
role of uric
при
acid.
подагре,
And we say
само
that
собой,
yes, in
даже
the
у
quarter
пациентов
of
с асимптоматической
cases,
гипертрофией
in case
могут
of gout
формироваться
disease,
кристаллы
even
и
the
могут
patients with
приводить к изменению
asymptomatic
костных структур.
Leishman syndrome
Итак,
may have
на
changes of bone
20-25%
structures.
риск
So
развития остеопороза у
20-25%
выше, как и
is
частота
the
переломов
risk
у
of
этих пациентов.
developing
Возвращаясь
osteoporosis
к нашим
higher in the
пациентам,
patients with gout disease,
назначаем
and the
фибуксостат
frequency of
120 мг
fractures
в сутки,
is
достигаем целевого
25%
уровня
higher
мочевой
too.
кислоты.
So we reach the target level of uric acid by
И
giving the
добиваемся
patient
стойкой ремиссии
medication,
у этого
and
пациента.
we
Сейчас он
achieve
вернулся
a
полностью
stable
вот,
remission in this
к
patient. Now he fully
работе.
came back to his work.
Сейчас вопрос стоит о снятии с него группы инвалидности. И
And the
полностью
question
практически
is
выздоровел.
to
Это другой
cancel his
пациент.
disability, and
То
he's
же самое, что
almost
вот в
treated.
иностранном
This
журнале
is
мы
another
видим те
patient,
же
the
изменения,
same as
которые
in
вот
the
при
International
бедренных
Medical
костей всего лишь
Journal. We
31
see
год.
transformations of his hip
Инъекции
joints.
дексаметазона проводились внутри
31 years old. He had intermuscular injections of dexamethasone. Apart from gout disease itself, it's a risk factor, and we see huge tophi in his peripheral joints. What do? We administer febuxostat in maximum dosage. We do the titration of the dose. We gradually achieve the target level of uric acid. We sustain it during 1 year, and we see that the level of creatinine is slightly going down as compared with the initial value. So this drug has a number of advantages in comparison with allopurinol, for example. So this is an adenuric drug, 120 mg daily. The target level has been achieved, and look what happened. All the tophi, including the tophi in the joints, can be fully transformed. This is something that was shown on this wonderful video, that the disease can be controlled. And this is an explicit illustration of how this can be done. The sufficient dose of febuxostat 120 mg daily therapy. So this therapy during 1 year led to the regression and control over the disease. This is how it looks in a patient at the onset of the therapy, and we don't see the changes of the bone erosions. We see gradually that these tophi in the bones are fragmented and that they are filled with normal tissue. This is the meta-analysis of the efficacy and comparison of different drugs. What is stronger, what is weaker? Febuxostat is it's more efficient than any other available drugs for the treatment of gout disease today. I mean, available in Russia. This is a wonderful picture of how what we can achieve by this therapy: reduction of arthropathy, full disappearance of monourate crystal depositions, and this is quite achievable. The top picture by Dalbert and co-authors have demonstrated it very explicitly in one of the early works. And I showed you similar pictures of our clinical cases too. So the disease can be controlled in the majority of our patients. Don't be desperate. Despite the deformations of the bone structures, the disease can really regress. And this is the last work. Is it only the serum level of uric acid that we need to consider? On tomography, we try to see how we can treat our patients. We were either, if they didn't have severe gout disease, we administered change of the diet and lifestyle, or allopurinol with a more severe course of disease, and the most severe patients to clostrostat. And we see that even the most severe patients, the tophi were disappearing faster than they got, than in those cases when they got another therapy. We can't do everything, of course, immediately, but I think we are on the right way. And I think that we definitely must and we can affect the lives of our patients if we assess our steps carefully and if we treat them in a quality way. And now there's a next presentation. If you have questions, I'll be happy to take them. And now I would like to give the floor to Ekaterina Valerievna. She will have a presentation on gout disease too.
Максим Сергеевич, огромное спасибо за ваше выступление. Пока подключается Екатерина Валерьевна.
Thank you so much for your presentation, Maxim Sergeyevich. While Ekaterina is getting connected with her presentation, I do want to ask you to follow the timing, because during your presentation, we received more than 15 questions, and to have enough time to cover questions. Well, it's wonderful to have so many questions. Well, but to be able to answer those questions, I do ask you to speak for not more than 20 minutes. Ekaterina Valerievna is our next speaker. She will speak about the treatment of gout disease, different countries, different guidelines. Good afternoon, dear colleagues. Unfortunately, today and in the foreseeable future, not all of us will have will be able to have a cup of coffee in the Parisian boulevards or walk in Manhattan, but we nevertheless have an opportunity to see what our international colleagues think about therapy of gout disease. I'd like to express my gratitude to the companies, to the organizer of our session. Of course, a thank you to our audience for the interest to the therapy of a disease called gout disease. You may ask a fair question: what kind of discussion can there be in case of a disease that is several thousand years old? The first mentioning of gout disease is 1,500 years BC. And Maxim Sergeyevich showed you that the dinosaurs also suffered from gout disease. So in fact, the disease is millions of years old. Hippocrates, he also suffered from this disease in his work. He described the disease as the disease of Sunday evening and Monday morning. Well, nothing special. Mayer had gout disease attack. He was, and this cheerful attitude to gout disease, as it is presented on this cartoon by the British cartoon James Gilray, just like many other wonderful poets, musicians, etc., he also suffered from gout disease. But a patient of gout disease looks much better than his colleagues who have TB, for example. But this disease, during many years, has developed many myths. It is often called the royal disease, royal of abundance, and many can think that this disease makes them look more noble. But even from the UK cartoons, we may see that this is not a cheerful disease at all. If on the left the patient is still happy, on the right you can see that the disease is torturing the patient for quite a long time, and he developed chronic renal failure because his face is gray, he has edema, and energy and happiness are disappearing. Despite the achievements in the diagnostics and therapy of this disease, despite the fact that we know a lot about gout disease, it is still one of the most proliferated inflammatory arthritis out of all the normative arthropathies. This is a trend worldwide. Indeed, the number of patients with gout disease increased by age, of course. It is largely connected to the fact that life expectancy grows. The number of people who have Lesch-Diamond syndrome is growing. The reason might be because the level of obesity and metabolic syndrome failure also expands, and it goes hand in hand with Lesch-Diamond syndrome, as we know. Probably that's why there is still a challenge in the gout disease, and maybe some doctoral mistakes also may contribute to the fact that this disease is not still managed well, although this disease is a curable disease. It's a pity to observe the cases when the opportunities are missed, when the patients come with chronic tophi gout disease at the stages that Maxim showed in his presentation. At the turn of 20th-21st centuries, there happened a renaissance of the interest towards gout disease, and the knowledge was systematized in the guidelines of the European Anti-Rheumatoid League, and it was recommended to look at the non-medication methods of patient treatment, change of nutrition, reduction of alcohol consumption, etc., and cancel diuretics. Of course, without good support, we can't reach these changes. The anti-inflammatory therapy included the colchicine and MPVP, but the side effects are several times lower when the lower dosages are taken. Of course, the urate reducing therapy drugs are recommended, and the development of acute arthritis should be prevented. Urate reduction therapy is indicated to all the patients with tophi arthritis and Lesch-Diamond syndrome. Urate reduction drugs, at that moment, there was allopurinol, and the vector of therapy was changed. If previously the disease was treated when the patient was disturbed by pain, the vector changed to the target level focus, and the target level is minimum 6.8 micromoles per deciliter. The studies show that at this particular concentration, the sodium monourate containing mix is bringing to the crystal deposition. 10 years later, in the European Anti-Rheumatic League, they updated the new recommendations of 2016, and they happened not without a reason, because new drugs were developed, and a lot of attention was paid to normalizing lifestyle of gout disease patients. Medication and non-medication treatment is described. Glucocorticoids, intra-joint or perioral, interleukin blocker 1 was recommended. The efficacy of low doses of colchicine were highlighted. Urate reduction therapy was described, and the target levels of uric acid were expanded, 360 micromoles per liter and 300 micromoles per liter in the patients with severe gout disease. Allopurinol, except for the cases of counterindications. And really a rescue boat in this case was a new drug, febucostat. It's a selective drug produced in tablets. The formulations 80 and 120 mg daily, and as different from allopurinol, it is metabolized through liver, and it can be administered to the patients with failed renal function. The efficacy of febucostat, as different from allopurinol, it inhibits two forms of xanthine oxidase. And many studies show that even 40 mg of febucostat, the norm of sodium monourate is achieved in blood serum. The study that lasted longer during 1 year, and uric acid had to be less than 360 micromoles per liter. In comparison between allopurinol and febucostat, febucostat proved to be more efficient. 80 mg and 120 mg formulations are options that give an opportunity to achieve the target level of uric acid in 60% of the patients with gout disease. In a large study where the patients were enrolled with different levels of hyperleukemia, the high efficacy of febucostat has been proven to achieve the target levels of uric acid, whereas allopurinol has some limit of administration. We can't give high dosages of allopurinol in a patients with compromised renal function. Patients with renal failure, febucostat maintains its efficacy in comparison with allopurinol. Over this time, from 2007 and onwards, there have been issued the national clinical guidelines in Russia for the patients with gout disease. It is shown there that the acute arthritis therapy should start as soon as possible. It gives an opportunity to give relatively lower dosages and rarer frequency of drug taking. Of course, there is a method, tablet in the pocket. We should train the patient to stop the arthritis by taking urate reducing pills. Of course, all the drugs should be administered with the consideration of all indications and counter-indications, as well as drug-to-drug interaction, non-steroid anti-inflammatory drugs, glucocorticoids, in fact, injection and perioral. And we have also IL-1 blockers. They are not broadly used, but it's plan B for inefficacy and side effects that colchicine, glucocorticoids, or non-inflammatory drugs may give. Of course, all these drugs are needed not only to eliminate the acute arthritis, they can be used as preventive drugs. When we administer urate-reducing drugs, irrespective of the type of drug you administer to your patient, in the first months we may anticipate the increase of the number of arthritis in the patient. And of course, administration of anti-inflammatory drugs in low dosages gives a chance for an increased compliance of the patient and reduce the frequency of acute arthritis with gout disease these patients. Who do we administer urate-reducing drugs? All patients with acute hyperuremia and arthritis attacks, patients with tophi, and patients below 40. If they have renal pathology and different comorbidities develop, then after diagnosis, we have a right to initiate the urate reduction therapy. What are our targets? The national guidelines say that it's 360 micromoles per liter for all patients and below 300 for the patients with tophi, gout disease, and chronic gout disease. It is not recommended to reduce the uric acid below 180 micromoles per liter because it may lead to Alzheimer's disease, Parkinson's disease, and amyotrophic sclerosis. All the patients should start from titration of urate-reducing drugs from low dosage. Patients with renal function failure, the drug of choice should be, of course, febuxostat. Allopurinol should be administered with the consideration of renal function and glomerular infiltration speed. Of course, all the patients, their comorbidities should be assessed, such as arterial hypertension, hyperglycemia, etc. And of course, there are drugs that have a drug-specific effect, and they may cause a slight reduction of uric acid when you administer them. Of course, the target level cannot be achieved and maintained by these drugs, but they can be an additional way of managing patients with gout disease. Of course, every patient should be trained to maintain a right lifestyle, and today it's an important factor. However, let me say that diet only, as it has been demonstrated in a small study conducted in our lab, shows that diet only will not lead to a success. It won't lead to the target level of uric acid. Diet can be considered today as an addition to a lengthy, regular, lifetime medication therapy with urate-reducing drugs, because even if the disease is managed well, it's a chronic one and it requires long-term taking of urate drugs. Unfortunately, we have a big collection of amputated phalanx and other parts of the body. Surgery is only good when a tunnel syndrome is developing. When the patient cannot wear shoes or clothes, the surgery can help. As on this slide, the syndrome of carpal channel. When in carpal channel, there are tophi masses, and of course, the cartilages suffer, and finger flexi may develop. But we don't need surgical methods to get the patient rid of tophi. Of course, the effect of febuxostat is longer, but it's less safe, and it leads to the situation when tophi, like in this example, 120 mg of febuxostat, lead to the situation when the patient completely gets rid, and the bone destructions are being healed. As for the guidelines of our colleagues, I want to say that irrespective of the fact whether it's Portuguese, Australian, or New Zealand guidelines or Italian guidelines, the style of managing the gout disease patients is the same everywhere. There are matters that will, of course, make us meet and discuss, and including clinical guidelines, different matters. The question is when to start the urate-reducing therapy. We need to wait until the attack is over and administer it between the attacks. What should be the level of uric acid? What should be the length of preventive therapy when we are giving an initial urate-reducing therapy? Concerning the urate reduction therapy, there are many studies, including the ones of our lab, showing that the expectation of a period leads to a situation when the patient thinks that he doesn't need any other therapy because it was stopped. It also shows that the initiation of urate-reducing therapy doesn't lead to the increased duration of the arthritis per se. These are the new guidelines, the American guidelines of 2020, and they show that urate-reducing drugs can be administered before arthritis, okay? And it always starts from low dosages of titration. And at the initiation of urate-reducing therapy, and the anti-inflammatory therapy should last 3 to 6 months after the initiation of urate-reducing therapy. Please note that non-medication treatment and diet for these patients is important, but it's number two. Number one in this case is medication therapy. There was a study Pierce conducted, and the Americans reconsidered their focus in the therapy because it was shown that cardiovascular diseases may develop when febuxostat is taken. However, the last meta-analysis that was published in the end of August shows that febuxostat use is not associated with cardiac cause and all-cause mortality, and it doesn't depend on the dosage of febuxostat. Another guideline of this year is from the French colleagues. Their guidelines are coherent to ours. All the patients need to have urate reduction therapy. The level should be at least 300 micromoles per liter for all patients. Urate reduction therapy should be administered depending on the glomerular infiltration speed. For the patients with renal kidney renal function failure, febuxostat is a drug of choice. I want to say that in the guidelines of our French colleagues, it is said that if urate reduction therapy is administered with colchicine, it is recommended to use low dosages. They show good effect of anti-inflammatory therapy and non-steroid anti-inflammatory drugs, glucocorticoids, during 3 to 6 months as compared with colchicide. They are as efficient as colchicide is. Thank you so much for your attention. I wish you every success, every health, and I wish to see you online soon. Thank you very much.
Екатерина Валерьевна, огромное спасибо за ваш доклад.
Thank you very much, Ekaterina Valerievna, for your presentation. And our next speaker is Maria Yeleseva. She will be speaking about urate reduction therapy during pain attack or not. I again want to say that we receive a lot of questions. If I group these questions up, they are mainly dedicated to administration and questions on the strategy of treating the patient with no gout disease, but elevated level of uric acid. What should be your actions in this situation? Will you choose allopurinol, febuxostat, or nothing by simply modifying lifestyle? And these are not the only questions. In fact, we have a lot of questions incoming. I'd like to say that managing these patients, well, about pain attack, we'll hear the answer soon. But managing the patient is not always shouldered by narrow specialists. This is a challenge to overcome for all therapists, because therapists, cardiologists will likely see these patients. We know very well that dyslipidemia, elevated body mass, chronic renal disease, kidney disease, they correlate with other diseases. So these patients may be referred to any specialist, nephrologist, cardiologist, etc. So this topic that we are discussing now is of critical importance. So I do ask our audience in the future to share this theme with their colleagues, those who couldn't attend this symposium, because a rational management of the patient with elevated level of uric acid with determined gout disease diagnosis is a significant step forward in improving the quality of life of these patients. It should be kept in mind that there are many diseases, they are all comorbid, but when we at least remove the reason of pain syndrome or additional risk factor of CKD, we already do a lot for the patient. Uric acid is very often not defined. If we take a cohort of the patients who were administered by the therapist, they will most probably have a lipid profile, creatinine, sometimes urate may be assessed, but uric acid very rarely, until the moment the patient himself complains on the pain. So without any doubt, adding uric acid to the test is of great importance. And they tell me that while the next speaker is getting connected, we have time for a question. Maxim Sergeyevich, let me take this opportunity because a question to Maxim Sergeyevich with this heading. We have more than 25 similar questions to Maxim Sergeyevich. So, for the first, when Leishman syndrome is diagnosed for the first time, what is the algorithm of managing this patient? These are the patients that were not diagnosed gout disease yet, but they have Leishman syndrome. What should we do in this situation? Thank you so much for the question. It's an important question indeed. The first thing we should do is to recommend to the patient change his lifestyle and change his diet. In those cases when we can speak about risk factors of cardiovascular diseases in a patient and the risk of developing CKD, we need to discuss the possibility of medication treatment of these patients. As for the absolute recommendations on how to do that, we don't have them yet. Nevertheless, there is a number of consensuses in a number of countries that envisage an opportunity of pharmacological treatment of the patients with the above-mentioned risk factors without gout disease yet. And two continuations of this question. Okay, we changed the lifestyle. Should we examine the patient anymore? Does he need any complex examination of his joints? And should we test uric acid in his daily urine test sample? It depends. If we are limited by the failure of his lung function, well, here we need to differentiate between gout disease and asymptomatic Leishman syndrome. If there were no acute pains and attacks of arthritis, then it's Leishman syndrome. If there was at least one pain attack of arthritis, these patients should be treated by urate-reducing drugs until the uric acid level is reduced to the normal level. If the level of uric acid is extremely high and there are risk factors in place that we must assess, and let me highlight that all of the diseases that can be associated with gout disease are the failures of lipid metabolism, carbon metabolism, for example, diabetes. The same is true for cardiovascular diseases that are first of all associated with atherosclerosis and kidney disease. So all these pathologies must be controlled and treated irrespective of the absence or presence of gout disease. And we need to control the level of uric acid in these patients because it's a particular risk factor to all that I've been mentioning before. Okay, in the continuation of this question, the level of uric acid is slightly elevated or in the upper limit of the norm, while the clinical picture of the gout disease is present. There's a pain syndrome as well. Moreover, in this question, the doctor described several patients that were administered allopurinol. Although the threshold of the uric acid level is on the level of the norm or a bit above. What to do with these patients? And this question is to Ekaterina Valerievna. Thank you so much for this question. Regarding the clinical acute arthritis clinical picture, and of course, this patient must be referred to all the tests that will be helpful. First of all, diagnostic puncture of the joints with a verification of the sodium monourate crystals, and it will help you to differentiate and set the right diagnosis in this case. And of course, you need to know when exactly are you measuring the level of uric acid, because gout patients with acute pain, they will have a normal level of uric acid, but between the pain attacks, you will see the realistic level of uric acid. If we can't do the diagnostics between the pain attacks, we do the instrumental examination, and then we consider the clinical manifestations holistically to diagnose accurately. Thank you so much. You have mentioned, Ekaterina, pain attacks, and we have the third speaker with Maria Evgenievna, and her presentation is: should the urate reducing therapy be administered during pain attack? Good afternoon, dear colleagues. You see the title of my presentation on the screen. I have to say that in recent years, we see the development of new urate-reducing drugs, new opinions on the treatment, new population studies. This is what we're going to discuss here. Gout disease is a disease with a low compliance of treatment. The reasons are several factors: low quality of medical support. Patients with gout disease rarely go to rheumatologists. But we need to consider that it's mostly the therapists who see the patients with gout disease, so they need to know this disease and differentiate it very well. Another false assumption is that the pain attacks in gout disease can be, the period between pain attacks can be quite lengthy, and it gives the patients a false hope that they are healed, so they don't visit the doctor frequently. The patients need to follow the doctoral guidelines, this is for sure, but the guidelines recommendations should be based on clear clinical guidelines where we see a number of disputable questions. For example, when to start the urate reducing therapy. If previously it was said that we shouldn't start the therapy at the pain attack, we need to reduce the pain attack and then start the therapy, and this question was every now and then repeated in different recommended guidelines. In Portuguese guidelines, for example, say that the urate reduction therapy should be started after the pain attack was stopped. In the French guidelines, this matter is not being discussed at all. What about the modern guidelines of the EULAR League? The evidence base is not enough, and there are no specific guidelines about it, then the decisions should be individual. So should we wait or not wait for the acute gout pain attack to stop, to start the urate reduction therapy? The recent recommendation of the American rheumatologist clearly gives an answer to this question, saying that urate reduction therapy can be administered in anticipation of the pain attack to stop. What made them to reconsider their opinion? This is a study, double-blind study of 2015. Of allopurinol compared with placebo-controlled group. Patients during 4 weeks took allopurinol or placebo with a starting dose 100 mg with further increase up to 200 mg per day. There was no frequency discrepancy between two groups, placebo and alloprenol, in terms of side effects. There's another study of 2012, Taylor and co-authors, randomized placebo-controlled trial, follow-up period 10 days. All patients got anti-inflammatory therapy, duvoxetine, colchicine, and pain syndrome was assessed against the VASH scale. During taking alloprenol in acute pain of gout disease, it didn't bring to the attack being more acute and lengthy. It's important that if we go back to gout disease pathogenesis, everybody knows that the crystals of uric acid bring to the inflammational chain of reaction. It eventually leads to the tissue destruction. It doesn't happen overnight. There is a number of factors to play a role gradually, and crystal formation is happening. Crystals are being deposited in organs and they cause clinical inflammation. But we see gout when it is manifested in the form of acute gout arthritis. We cannot have an impact on this disease. We cannot see the underground part of the iceberg. We connect quite late to the treatment, and later we start controlling gout and the level of uric acid, the less the chances are to control it indeed. And I would like to confirm my words with modern methods of visualization and crystals of uric acid. We often see that crystals they are seen on CT. They can often be confused with tumors that, when checked properly, are tophi and crystals of uric acid that stay in the body for a long time. However, there has been no debut gout arthritis yet. The diagnosis is there and the disease is ongoing. What are the general principles of treating the pain attacks? The preferable timeline is the sooner the better. The sooner pain attack is treated, the sooner it is eliminated. Duration, 2-3 days after full disappearance of the attack. Prevention of attack. It's anti-inflammatory low dosages in the first months of treatment, continuation of urate reduction therapy during pain attack, and also we should pay attention to the concomitant diseases. What are the risk factors of early remission and pain attacks? First of all, as it was shown in multivariate regression analysis, it was shown that it is the intensity of inflammatory reactions, C-reactive protein, were registered as triggers of gout inflammation, but not the urate reducing therapy during gout disease pain attack. How can we prevent the gout arthritis? First of all, it's anti-inflammatory therapy. As therapists and GPs, of course, we like more the non-steroid anti-inflammatory drugs. They are efficient, affordable, they have a low rate of side effects. We have, as of today, a large choice of anti-inflammatory drugs. Out of them, I would like to mention Liculin. It gives an anti-inflammatory fever-lowering effect. It is well metabolized and acts quickly. the patients with moderate and light form of renal failure, we don't have any further deterioration with this drug. Acute arthritis pain and urate reducing therapy. The meta-analysis of 6 randomized control studies with a total sum of patients 557 shows that the average difference in the pain score on the 3rd day of the patient attack didn't differ much between the two groups, but the level of uric acid was lower in the patients who got the urate reduction therapy, but there was no difference in the frequency of acute arthritis pain attacks. Why is it important for us? Because after attenuation of pain attack, the patients are not interested in the prevention of the disease, and we lose the control over the disease. Besides, having received the information on the negative impact on the course of arthritis, the patients are prone to cancel urate reducing drugs. What does this mean? It means more expenses on the healthcare system, risk of hospitalization, CKD, and higher expenditures and higher burden on the healthcare system. It's not a problem of the patients only, it's a problem of the larger scale, and it brings to higher economic expenditures. It was proven in the United States and in Europe. Chronic gout disease is associated with comorbidities, and they increase in time and make the condition of the patient worse. What can we say? In this way, how can we help a patient in acute attack of gout disease? How can we prevent it? Well, we need to do the titration of the urate reduction dose, as it was shown in the recent Japanese study of 2018, where 3 groups of patients were compared. Group A, patients got titration of the dosage of febuxostat. It was titrated from 10, 20 to 40 mg daily. Second group of patients was getting preventive dosage, 40 mg of febuxostat daily. And the third group, control group, was taking only febuxostat. It was shown that we have the same efficacy of preventing arthritis attacks when we do titration of urate reducing drug and when we give only the anti-inflammatory therapy. This is a modern proven guideline that we can also use. As a conclusion, I would like to say that urate reducing therapy is a powerful anti-inflammatory therapy too. If we are lucky to have a patient who listens to our guidelines, who follows the regime of dosage, and he timely controls his disease, then we can control his condition and let us say with this quite severe incurable disease, and he will feel practically healthy. I wish you every health, dear colleagues. Thank you for your attention.
Maria
Evgenievna, huge thanks. And I'd like to ask all speakers, we have several minutes left, 3-4 minutes for questions. I'd like to ask you to put all the speakers on the screen, and we will have a time for a brief discussion. So out of the questions that we had, the unanswered or repetitive questions are from what level of uric acid should a practitioner start treatment from? Any existing option of treatment?
Мы можем говорить о разных
We
мнениях
may
в этом
speak about
отношении. Если мы
different
говорим о пациенте
opinions
с подагрой,
in
то
this sense.
любой
If we're
уровень
talking
выше
about
360
patients
микромоль на литр требует назначения медикаментозной
uh,
терапии, и
uh,
поддержание этого
uh,
уровня ниже указанного
medication
показателя на
therapy
протяжении
is
всей жизни.
required
Более того, этот уровень
for
может
the
быть
patients
ниже.
with
Это
the
вопрос,
level of uric
который
acid
уже был
above
задан у
360
пациентов с
micromoles per
тяжелым
liter.
течением
Moreover,
заболевания,
this
частыми
level can
приступами
be
или наличием
lower in case of
топусных
severity of
отложений,
disease
независимо от
and
локализации.
tophi
Что же касается
depositions
пациентов
irrespective
с
of their
повышенным уровнем
localization.
мочевой кислоты,
As for the patients with
споры в
elevated
этом
level
отношении, когда
of
начинать лечение
uric
уровня
acid, the
480
arguments when to
медикаментозно, либо
start the
540,
medication
либо
treatment
600, разные
480,
рекомендации, разные
540
консенсусы
or
говорят о разных цифрах. Тем не
650, different
менее, целевой
consensuses
уровень все
show
равно
us different
360
figures.
у этих
Nevertheless,
пациентов.
the
Другое дело, что
target level
достичь его
is
при назначении
360.
немедикаментозных методов лечения, как правило, не
Another thing
удается.
is,
И еще раз акцентирую
unfortunately, they can't achieve it
на
by
моменте
not
необходимости
administering medication. Let
назначать
me say
медикаментозное,
again that
обсуждать, по
it's
крайней мере,
important
медикаментозное
to
лечение пациентам
discuss the
с
medication
наличием
treatment
сопутствующих
and try to
заболеваний,
administer it to the
ассоциированных,
patients
возможно, с
with
уровнем мочевой
concomitant
кислоты. То
diseases.
есть в этом случае мы можем
In
обсуждать
this
необходимость
case, we
назначения
can discuss the
медикаментозного
need of
лечения, и тогда
administering
уровень должен
medication
быть
treatment, and then the
эти
level should
360
be
микромоль на литр. То есть все, что
360
выше, это
micromoles per
плохо.
liter. Whatever is
То есть
above is
сказать
bad.
однозначно, что существуют какие-либо рекомендации, говорящие о необходимости
So to
старта
say
снижения уровня мочевой
definitely
кислоты
that there are
просто
some
потому, что она выше, чем
recommendations on
360,
the
не
need of
существует. Мы
reducing
не
the
имеем
level of
права
uric
опираться на эту
acid
цифру.
simply because it's
Консенсусов
less than
с
360.
достаточно
There are no
узкими
reasons. Yes,
группами
yes.
специалистов, как
We have
правило, в
consensus
разных
with
странах,
narrow
например,
groups of
Тайване, Индии,
specialists in different
и в нашей
countries, in
стране
Taiwan,
есть
India,
такие
in
работы,
our
но
country as well. We have
они
works
не
on
имеют под
this.
собой
However, they don't have
достаточной доказательной базы, к
enough
сожалению, на
evidence
сегодняшний день, чтобы
behind them
говорить
to
безапелляционно о
say
каких-то конкретных четких строгих
definitely
алгоритмах.
that there must be some
Я
clear and
надеюсь, что
strict
ответ на,
algorithms.
наверное, сотни вопросов на
I
эту тему,
hope
которые были поступили,
that the answer
прозвучал.
to 100 questions
Четкой
on this
доказательной
topic
базы,
has
во-первых, не
been given.
существует. И
There is no
последний,
clear
очень короткий
evidence base
вопрос.
in this
Ряд
case.
междурегрет
And the
препаратов,
last very
тиазидоподобных
brief
диуретиков,
question. A
ряд
number of
препаратов
drugs,
снижающих цифру
thiazide-type
артериального давления, может быть
diuretics,
ассоциировано
and
с
some
ростом уровня
of the
мочевой
drugs that
кислоты
reduce
за счет
arterial
блокады
pressure
ОР1
can be
рецептора. В этой
associated with the
ситуации
growth of
требуется
uric acid
назначение
because they
препаратов,
block
снижающих
the
уровень мочевой кислоты или нет?
AUT1 receptor. In
Тоже
this
от меня
case, do
вопрос.
we
Ну,
need to
что
give
касается
drugs that reduce uric acid level or not?
Что касается пациентов непосредственно с
As
подагрой,
for the
то есть работы,
patients with
которые
gout
показывают,
disease,
что
there are works that
максимум
show
это немного
that
повышается доза этих препаратов
we
снижающих. Что
maximum
касается в целом,
elevate the dose of uric
то
acid
по жизненным показателям,
drug.
если мы не можем отказаться от
But
их приема,
if for life
не влияет
reasons
на
we
наше
can't
решение о
stop
проведении
taking those
снижающей
drugs,
терапии. Иными
we
словами, если мы видим, что у пациента подагра,
if
то
we see
абсолютные
that the
показания. Если
patient
у
has
пациента
a gout disease,
асимптоматический
then he
панихидоз,
must take these drugs.
решается
If he has
индивидуально в зависимости от
asymptomatic
наличия иных факторов риска. Например, есть
Leishman syndrome, then we need
множество
to assess the
доказательств
concomitant risk factors. For example, there are
влияния
lots of
позитивного различных проистекающих
evidences
препаратов,
of the
антистатов,
positive
антисептических
impact
приемов
of
привели
different
к достичь,
urate
что у
reducing
пациентов
drugs,
с наличием
buxostat, and to less extent allopurinol,
хронической сердечной недостаточности, а мы знаем, что все эти
in the
пациенты
patients
вынуждены
with chronic
принимать
heart failure. And we know that all these patients have to
петлевые или
take
тиазидные диуретики.
loop or thiazide
То есть фактически
diuretics.
отношение такое же, как ко всем остальным пациентам.
So
Просто,
the
возможно,
attitude
будет
is the same as
возникать
to other
вопрос о смене
patients. The only
назначенной
thing
терапии
is
не
you may
урат-снижающей, а
think
любой
of
другой. Ну и,
changing
наконец, наверное, последний
the
вопрос, которым
therapy
мне бы
not to
хотелось
urate
попросить
reduction,
завершить
but
этот
something else.
симпозиум,
And the
это, как по
last
вашему
question to
мнению, в
conclude this
ближайшие
session, what do
5-10
you
лет
think?
может ли нас
The
ожидать
coming
такая же
3,
ситуация, как это
5,
происходило в
5-10
сфере
years, are
гиполипидемической
we likely
терапии,
to
когда
face a
вначале
similar
назначалось только
situation as
пациентам
we
с
had in
проявленным
hypolipidemia
заболеванием, а в
therapy,
итоге мы вышли
when
к
it
тому,
was
что сама
indicated
высокая
for the
цифра,
patients
может
with
быть, при
manifested
липопротеиновой
disease,
слепотности, может
but
быть
then
самостоятельным
we
показанием к
found
снижению,
out that
как
the
предвестник
low density
неблагоприятного прогноза?
lipoprotein
Есть ли какие-то
figure
идущие большие
can
исследования,
be
которые
a warning
позволяют
of
сказать,
unfavorable
что
outcome?
возможно такое
Are
будет
there
сделать
any
в 5-10
large-scale
лет
ongoing
касательно уровня
studies
мочевой
that
кислоты? Или таких
will make us
предвестников
say
пока
in
нет?
5-10 years that we're likely to
Спасибо.
face the
Это
same in
очень
case of
мудрый
uric acid
вопрос.
or not yet?
Абсолютно верно. По
Thank you
крайней
very
мере,
much much for your extremely wise question. At least two large ongoing studies are conducted at the moment. Patients with symptomatic Lesch-Nyman syndrome, and they will show how will the prognosis of these patients be outlined, and the cardiac death parameters should be assessed as well. Or will we be able, as we did with statins, to achieve a good result in terms of impacting the forecast and not simply reducing this or that parameter? In other words, will it find a reflection in the forecast or not? That's the biggest question. And what should be the level of uric acid, below 300 or below 360 or on the level of 420? When is the benefit beginning? This is not to say that it's a secondary question, but it's slightly less important. In any case, the level of uric acid is a surrogate marker, just like cholesterol level, which is. I mean, these parameters must be studied in a more quality way, like in Jupiter study. So as we get more and more information, we will be able to speak about the prospect. But the most important thing, let me repeat, is not how big the reduction of uric acid will be, but what will be the prognosis of the patient.
Екатерина Валерьевна, а вы согласны с мнением Максима Сергеевича?
Ekaterina Valeryevna, do you share the opinion of Maxim Sergeyevich, or you have another opinion? No, luckily, I have no objections. And I don't have any other different opinion. I hope that these matters will be tackled in the nearest future, and we will have some guidelines at hand. This is a frequent question, and almost every profession, therapists, cardiologists, endocrinologists, are concerned about it. From which level of uric acid level should we treat it as a hazardous pathogenic phenomenon? I do hope that the upcoming studies will give answers to these questions. Can we conclude by saying that the tools for the reduction of uric acid are at our hand? But there's a small gray area in the studies that need to clearly define the thresholds and borderlines of using these tools. Yes, definitely we can say so. We have urate reducing drug that proves its efficacy, but we know that everything is a drug and everything is a poison. We need to timely start the therapy, not to ruin the patient's health with therapy. And so which level, when, and for what kind of patients? Here we need to get the answers to these questions. Well, I hope that it will happen sooner than in 5-10 years. In 2-3 years, we will have more substantial discussion on this, and not whether or not we should do it. Well, this makes us really optimistic. Then we are not meeting for the last time, hopefully. Thank you, Maxim Sergeyevich, Ekaterina Valeryevna, for this really interesting symposium. You had more than 600 viewers. Let's move on. And now we have a short break, and then we go back here in the Moscow Hall for a unique speedy session. What is the uniqueness of it? There will be raised the problem of diabetes, CKD, and chronic heart failure outcome. Swap CKD with chronic heart failure. But we have never discussed before what we can do to the patient who moves along this pathological path. Diabetes as a locomotive, chronic heart failure as the final of the cardiovascular pathology, and our mission is to answer when and how are we going to treat these patients. See you in 6 minutes, 11:30, and we'll start this unique session. See you very soon.
Irene, are you there?
Добрый день еще раз, уважаемые коллеги. Я приветствую всех, кто присоединился
Good
к нам
afternoon,
сейчас.
distinguished
Я хочу
colleagues. I'd
пригласить
like
вас
to
на совершенно
welcome
уникальной
all of
спортивной
you
сессии. Я
who are
напомню,
present
спортивная
here.
сессия
Today we
резервный
have
формат Евразийской
a
ассоциации
speedy
терапевтов.
session. That's
Он
the format
подразумевает
of the
три
Eurasian
части. Первая
Association
часть
of
короткие,
Therapists. There will be
насыщенные
three
ответы на
parts.
простой
Part number
поставленный
one,
вопрос.
short
Диабет,
answers
КСР,
to
ХБП
simple
и так далее.
questions, diabetes mellitus,
Нетерминии, причем в данной
chronic
скоростной
heart
сессии
failure,
присутствуют
and so on and
эксперты из
so
разных
forth.
стран.
There are
Мы столкнемся и
expert
с опытом мы
opinion
столкнемся с опытом Европы,
that
мы
will be
столкнемся с
expressed
опытом
from different
Великобритании,
countries.
с
Opinion leaders
позицией
are present here,
эндокринологов,
the European
кардиологов и
experience, the UK
нефрологов.
experience,
Мы обсудим
endocrinologists,
критические
cardiologists, and
вопросы, которые
nephrologists
звучат сегодня
will
в
discuss the
области трех
critical
проблем:
issues
диабета,
raised
ХБП и
today
ХСР.
around
Дальше
diabetes
мы
mellitus,
перейдем к дискуссии,
chronic
где будут
kidney
подняты
disease,
вопросы, которые
and
старались также несколько
chronic
месяцев.
heart
Это
failure.
острые
Then we'll
вопросы,
have a
многие из них
discussion,
не имеют
and
прямого
during
ответа,
this
и очень
discussion,
часто
we'll
эксперты
raise
расходятся во
different
мнениях, не
questions.
согласны
Many
друг с
questions
другом.
still do not have
Наконец,
answers, but
результирующая часть скоростной сессии–
finally,
это формат
the third
вопрос-ответ.
part will
Каждый
be the
спикер, которого
Q&A
вы увидите
session.
сегодня на
Each
экране,
speaker you're
перейдет в
going to see
свою
on the screen today
Zoom-комнату
will
для
go to
прямого
his
общения через
own
чат
Zoom
или
room,
голосом,
and
для
he will
прямого
have a
общения и
chance
ответа на
to
вопросы. Можно будет
answer
задать все те
questions
вопросы,
either
которые вы не
using a
успеваем задать в
microphone
ходе
or in
обычных
writing, so you
конференций.
can ask questions
Zoom-комнат будет
right
столько же, сколько
now.
спикеров.
There will
Ссылки на
be
Zoom-комнаты приведены под
several Zoom
YouTube-трансляцией.
rooms
Ссылки
by
на
the number of
Zoom-комнаты приведены
speakers you can see references and links to Zoom rooms. So as soon as our speed session is over, go to the Zoom room and you'll have a chance to ask questions. We also have 10 subscriptions that the participants will get from our association. There is a link to Instagram. It is on the website of the Eurasian Association of Therapists. There is also a hashtag in the right upper corner of your screen. Let's move on to the first presentation. Professor Artyunov will speak on heart failure with reduced low rejection fraction. Okay, so low rejection fraction, before that we called it less than 40%. The interval from 40 to 50 is some kind of intermediate fraction. Now from 40 to 50, that's the onset of the development of poor circulation due to reduced fraction. It looks like it's a play in words, but the treatment changes drastically because in this area, 40 to 50%, we can use drugs that are applicable to patients with low ejection fraction. In Russia, 4.5 million people have circulatory problems. 9 in 10 patients will be hospitalized at least once. Every sixth person like that has the ejection fraction less than 50. That's the first global problem. That's the short life expectancy. The Russian study has shown that when CHF 1 to 2, it's 7.8 years. When it's class 3 or 4, it is twice as less. The second global problem is the huge number of hospitalizations. Every third person discharged from the hospital due to decompensation will be hospitalized again 30 days later. The third global problem is the rehospitalization worsens the prognosis, increases mortality, has a negative impact on quality of life. So low ejection fraction is a tremendous social problem, and we can use other class of drugs. You can see two pillows supporting this particular triangle. That is ARNI and SGLT2 inhibitors. You can see the same is true for antagonists of mineralocorticoid receptors and the beta blockers. You can see that the amplitude of the blue bar is less because in modern world Valsartans are being elbowed out by ARNI. Is there any proof of what I'm saying? In Lancet, there was an interesting article published in May. There are two ideologies of treatment. On the one hand, beta blockers, on the other hand, ARNI and SGLT2 inhibitors and beta blockers and sartans. The red color shows the new scheme of treatment. A person who is 80 years older can have 1.4 additional years of life. Who are 83 years old, who are 55 years old can get additional 8.3 years of life. In this case, ARNI are ahead of other inhibitors in terms of the lesser number of hospitalization and the death rate. ARNI, for example, can have a positive effect. The mitral regurgitation is less manifested. Well, and as you can see in this study, we have a new term, reverse remodulation. The ejection fraction is increased. SGLT2 inhibitors also was a revolution, especially as far as dapagliflozin is concerned. On patients without diabetes mellitus, there were better results, a lesser number of hospitalizations, and for the first time, well, we can use dapagliflozin on patients without diabetes mellitus. Then there was another study, EMPEROR. EMPEROR had different patients included more severe patients with lower ejection fraction, patients when the glomerular filtration rate was less than 20 milliliters per minute, and there was a higher percentage of patients who already was on ARNI. That's a different group of patients, more severe group of patients. And as for the empagliflozin, it reduced the cardiovascular death and the number of hospitalizations due to heart failure. 2 days ago, an interesting sub-analysis was published. The goal was to study such combination indicators as the risk of death and hospitalization or the number of visits due to heart failure. The risk was reduced by 24%, but the devil is in the details. You can see that the lines depart, that's the sub-analysis. Well, the yellow line is placebo, the white line is empagliflozin. You can see right away they depart. The risk dropped by 37%. Here you can see the time to first hospitalization. The yellow line is placebo, the white line is empagliflozin. The risk was reduced by 31%, but that's the most important slide. The effect takes place by the end of the fourth day, on day 28 to be more precise. Well, you can see the curves start to depart, and that's very important. It's a real find for clinicians, and this effect persists during the year. So the socially important patients with low ejection fraction now has a new regimen of treatment based on 4 drugs, which can prolong your active life, reduce mortality and hospitalization. Thank you so much for listening my presentation. That's all there is to it. Okay, the moderator. Yes, I am here. Professor Arutyunov, thanks for your presentation. You raised serious problems related to hospitalization. We'll continue to discuss this issue during the discussion. But let's move on to the next presenter. It's Professor Galstyan, an endocrinologist from Moscow. Diabetes mellitus type 2, does it trigger heart failure? Does it worsen heart failure? That's a very relative question, because some say that diabetes mellitus can be a trigger. In this case, Professor Galstyan, the floor is yours. Thank you so much, Alexander. Let me start with this study, which I think is very important in the context of our today's discussion. That's the onset of diabetes mellitus. And as for the clinical characteristics of these patients, you can see that the onset of the disease, when we're talking about the situation now, about 20% of patients already have heart failure and diabetes mellitus at the same time. You can see that this study analyzed a follow-up period of 20 years. In 1989, you can see the profile of patients. In 2008, you can see this trend continues. We have a younger group of patients around 60 years old with more severe comorbid conditions, which can contribute to the development of heart failure and heart failure that can also contribute to worsening the condition of such patients. Well, I should say that everything starts much earlier. Here is another important study showing that the frequency rate of new cases is higher, of heart failure is higher at the stage of prediabetes. You can see patients with prediabetes, and the number of heart failures in such patients is higher, especially when HbA1c is 6.4 and higher. In this case, there will be a higher risk of heart failure as compared to those patients where glycated hemoglobin is lower. Another important study which analyzed the impact of cardiovascular diseases on patients with diabetes mellitus. Almost 2 million patients with diabetes mellitus were assessed in terms of verifying the complications caused by cardiovascular diseases. You can see that heart failure is one of the most frequent complications in patients with diabetes mellitus. It ranks second right after peripheral artery disease. And of course, I should say that chronic heart failure is also a factor that triggers diabetes. That is why the prevalence rate of diabetes mellitus in patients with chronic heart failure is much higher as compared to other cases. Well, you can see that it's not just the heart failure, but also the severity of heart failure increases the risk of development of diabetes mellitus. The more severe the heart failure is, the higher the risk of the development of diabetes mellitus, and the poorer is glucose tolerance. To what extent diabetes mellitus worsens the prognosis of heart failure treatment? Here is another study assessing the risk of cardiovascular death and hospitalization. So you can see the overall mortality of patients with diabetes mellitus and heart failure. You can see the brown bar, and without diabetes mellitus, that's the green bar. We're talking about the preserved ejection fraction and reduced ejection fraction, and the death and overall mortality is much higher in patients with diabetes mellitus and heart failure as compared to just patients with heart failure without diabetes mellitus. It is not a surprise that diabetes mellitus is one of the predictors of poor prognosis of treatment of heart failure. It's additional risk. Moreover, I'd like to say that heart failure and diabetes mellitus, or to be more precise, its complications exacerbate the course of heart failure. Here you can see the connection between the cardiovascular complications, such as microvascular complications and dilation of cardiomyopathy. You can see the risk is 2.5 times higher of cardiomyopathy in case the patient has diabetes mellitus and microvascular complications. This slide demonstrates the fact that when there are microvessel diseases, multivessel diseases, well, we have the irreversible situation, as the studies have already shown. Patients who have microvascular complications, even if we're talking about quite good glycemic control, well, due to such microvascular complications, have a higher risk in the development of cardiovascular diseases and heart failure in particular. But the most important thing, dear colleagues, is that heart failure goes through several stages. And today we have a real opportunities to have a better understanding of how diabetes mellitus contributes to a higher risk among patients with heart failure. We should change our concept in treating this category of patients. We should start the intervention much earlier, and that's very important today, so that we wouldn't be in a situation when this article is called the frequent, forgotten, and often fatal complication of diabetes mellitus. So in answer to the question, is diabetes mellitus type 2 is the trigger? Does it worsen heart failure? I should say that heart failure may be before diabetes mellitus. Diabetes mellitus, without any doubt, exacerbates heart failure. Thank you so much. Thank you so much, Professor Galstyan. We know that diabetes mellitus type 2 can exacerbate the course of heart failure. Should we pay special attention to who these patients are, what their phenotype is? We know that the major risk factors for the development of diabetes is metabolic syndrome and high BMI. These are patients with obesity. That is why I'd like to give the floor to Professor Salukhov. The theme of the presentation is obesity and heart failure.
Владимир Владимирович, включите звук.
Please unmute yourself. You are muted. Please unmute yourself in Zoom. Professor Salukhov, Unmute yourself in
Владимир
Zoom.
Владимирович, нету звука, к сожалению, у вас.
Professor
Пожалуйста,
Vladimir
проверьте настройки
Salohov,
звука. Вы говорите без
please
звука.
check the
Пока техническая
settings
ситуация
because
исправляется,
you
я
have no
хочу
sound
сказать несколько
right
слов о
now.
том, что мы
Everything
должны
is okay
учитывать
right
здесь.
now.
Без
Everything is okay
сомнения, мы
right
хорошо
now.
знаем результаты исследований.
Okay.
Мы хорошо знаем,
All right,
что
we know
ожирение
the
не только
results of
фактор
the
риска
trials. We
сердечной
know that
недостаточности,
obesity is
но и
not
то,
just
что
a risk
повлияет на ее
factor for
течение.
heart failure, but
Техническая
it can
недостаточность
also have an
исправлена, и
impact
мы
on the
передаем слово
course
Владимиру
of the
Владимировичу.
disease. Now we have no technical glitch anymore. Please, Professor Salohov, the floor is yours. Sorry for these technical difficulties. I agree with you that heart failure today is a galloping disease, a galloping condition in terms of the prevalence rate, and I'll try to show the connection between another non-infectious pandemic, which is obesity and heart failure. I think here we have a situation when two non-infectious epidemics meet each other. Well, you can see the number of people with obesity or excessive weight, and this dramatic growth in the number of people with obesity, first of all, relates to morbid condition, to obesity in general, and you can see that there have been no any changes in the number of such people. There was even some minor growth, and you can see that, in fact, this problem was raised in 2002 in the Framingham study, which lasted for 14 years. Obesity is an important risk factor for the development of heart failure. And in fact, when BMI increases by 1 point, the risk of heart failure also increases by 5% among women and by 7% among among men and by 7% among women. You can see many researchers paid attention to this. This is the Swedish register, and again, the people who were drafted into the army, they were analyzed for a long period of time, for 42 years, and you can see that those draftees who at the age of 18 had some kind of obesity or elevated BMI had more chances of developing heart failure. And again, that was the first case when the Swedish draftee was hospitalized due to heart failure. Those people who didn't have a morbid obesity, well, they had no problem, but those who had some kind of obesity, when BMI was increased, they had more heart failures. Another study, ARIC, and again, more than 13,000 patients during 1989 to 2012. As you can see it here, this study included patients without cardiovascular disease. And again, this study showed that there is a link between obesity and heart failure, but also with the coronary heart disease, with the strokes. And again, if we use a caveat for all risk factors, it turns out that obesity has the strongest impact on chronic heart failure as compared to coronary heart disease and stroke. Well, here you can see that if obesity contributes a lot to the development of other cardiovascular disease, you can see with the increase of BMI, it is quite a correlation, but again, this link is much firmer in case of chronic heart failure, and even when we're talking about the proper food, it can have an impact on this condition. So you can see that obesity has a direct link to heart failure. A RIC study, which has been quoted all too often due to the good design of the study, we can look at the subgroups which were included into this study. You can see here that those patients who were younger had more manifested impact of obesity on the development of heart failure as compared to patients in the older category. The Europeans had the more manifested impact of obesity on heart failure as compared to Afro-Americans. Well, to draw a parallel, and actually Professor Galstan raised this issue with diabetes mellitus, I think this is also important because here you can see, as far as diabetes mellitus is concerned, we can see that BMI, body mass index, obesity are the most powerful factors impacting the development of heart failure as compared even to hypoglycemia. Well, what mechanisms develop chronic heart failure? Well, you can see first and foremost that's structural changes due to hemodynamic changes caused by elevated BMI, also metabolic changes and neurohumoral shifts which take place when the body mass index increases. There is more fat due to toxicity or due to insulin resistance. This leads to cardiomyopathy, and dear colleagues, obesity is a strong risk factor contributing to heart failure, and obviously it leads to higher frequency of heart failure. The higher the BMI, well, the more changes you have, and of course you should control the BMI. Well, this control can be an important aspect of prevention and also to deal with specific aspects such as improving the course of heart failure due to the reduction of BMI, and thus we'll have a better prognosis, and of course this will allow us to deal with this risk factor and to reduce the number of cases of heart failure. Thank you so much. Vladimir, thank you so much for your presentation.
Diabetes could be locomotor.
И состояние предиабета, ассоциированное с избыточной массой тела, точно так же. Мы с совершенно разных сторон взглянули на то, что такое ХСН и какие события, внешние события.
We see what CHF is and what external events like obesity, overweight, diabetes type 2 leads to that. And now let's try to talk about the prognosis of the heart failure patients. And it's my pleasure to give the floor to Professor Gheorghe Andrei Dan from Romania. The floor is yours. You are welcome.
Thank you so much. Good afternoon, everybody. My task is to have a glimpse on the determinants of the heart failure outcome. And these are my conflict of interest. I remember you that heart failure is a totally incurable disease with many relapses. The relapses had different mechanisms in the first part and the last part of the heart failure, and we can intervene on the outcome in two ways. The first way is to improve the quality of life. The second way is to turn back the clock and to give medication which increase survival. Some drugs are acting on both these targets, like ARNI, like ACE inhibitors, like SGLT2 inhibitors. Some are only aimed to improve symptoms, like diuretics. Also, it's very important to remind you that the clinical class, the New York Heart Association class, is the most important determinant predictor for mortality, as demonstrated in consensus and patriarchal studies. And this is because this class is reflecting the systemic nature of the heart failure. Heart failure is increasing in absolute figures, mostly because of the increase in age population, and these are among the last statistic made in Europe in 2019. What is very important to emphasize is that the burden of heart failure remains significant, especially in deprived socioeconomic states. You can see that the age is less in heart failure patients dying in the socio-economic deprived countries, and also the incidence is highest in socio-economic deprived countries. But probably one of the most important things linked to the outcome of heart failure are the comorbidities, because heart failure is never standalone disease. And the comorbidity encountered in heart failure are two ways. First is coincidental, because the age patients accumulate different disease. Second, there are disease with interdetermination with heart failure. What is probably the most important thing, as many the comorbidities as low the survival in patients with heart failure. And if we are looking now in a quite recent meta-analysis published 1 year before, the pattern of the comorbidities influencing the mortality in heart failure per patient has changed in the last year. So the mortality because of the kidney disease or neoplasm decreased in the patient with heart failure, but increased the mortality caused by injuries, especially by falls and infection. And here you have the adjusted ratio, which is the same what I said before, that injuries, mental health, depression, and cognitive function and infection are increasing as comorbidities with increased deaths in heart failure patients. One very important thing to keep in mind with comorbidities is that there are two vulnerable phases in heart failure. One is the last days or month of the patient's heart failure, but the most important is the transition phase for the patient ready to be discharged from the hospital. This is the most important phase, and we should concentrate on this phase. And as you can see, the level of the biomarker NT-proBNP is correlated with the risk of rehospitalization in this vulnerable phase. When dealing with patients with heart failure, we have two different problems. First is the person or the patient hospitalized with acute decompensated heart failure, and in this patient we have a Sherlock Holmes work to do in order to discover the phenotype, the pathophysiologic mechanism, the precipitants, the polymorbidity contribution, the patient harm, and the preferences of the patient. The second is a chronic phase of disease, which is dominated by congestion. But the congestion is a complicated thing. It's not only the clinical congestion manifested by symptoms, but also the organ congestion manifested by weight loss, or hemodynamic congestion, which is manifested only by the increase in biomarker. Hemodynamic congestion is critical for the vulnerable phase. And when we have a patient with discordance between symptoms and biomarker, this points to hemodynamic congestion, that the therapy should be titrated based on this kind of congestion. As you can see here, also in a very recent paper published in more than 1,700 patients, the mortality, especially in advanced phases of heart failure, is mainly determined by congestion and less by the terminal sudden arrhythmic death or vascular death. There are two important comorbidities to take in account in patients with heart failure. One is renal disease, and my friend Dr. Janaka will tell you about this an instant after my talk. And these are very poor studied diseases. But the second is atrial fibrillation. And atrial fibrillation and heart failure is a deadly alliance. Atrial fibrillation is not only a marker of risk for the heart failure, but also a risk factor. And as you can see, both heart failure and atrial fibrillation occurs in patients aged more than 60 years. And practically 40% of heart failure patients have atrial fibrillation, and 55% of patients with atrial fibrillation have heart failure. So this is a comorbidity often encountered together. Atrial fibrillation begets heart failure, and you can see here from the Framingham study that the incidence of atrial fibrillation is tenfold higher in patients with heart failure. And it's the same thing in the same Framingham study published by Santana Krishnan several years before. Incidence rate of heart failure is preserved or the reduced ejection fraction is higher in patients with atrial fibrillation. Even more, the subclinical atrial fibrillation, as recorded by devices or a short episode of atrial fibrillation lasting more than 6 minutes and more than 24 hours, are predictive for development of heart failure. So in patients with subclinical atrial fibrillation progression, which is roughly 8.8% incidence per year, we have an 8.9 annual rate of heart failure hospitalization. So we are in the situation to look actively for the subclinical atrial fibrillation. And this is also demonstrated in a sub-analysis including Paradigm, HF, and Atmosphere study. And you can see that the incidence of new onset atrial fibrillation is an important predictor of decompensated or acute decompensated heart failure, and also on all measured adverse cardiac events in patients with heart failure. In a simplified diagram, we can see that a prevalent atrial fibrillation in a patient with heart failure with preserved ejection fraction increase mortality, but this mortality is increased even more in a patient with heart failure with reduced ejection fraction, in which new atrial fibrillation is recorded. So I am stopping here, thanking you for your attention and waiting for questions.
Professor Dunn, thank you very much for brilliant presentation. And I would like to draw the attention of our audience that in one of the first slides, Professor referred to a very famous publication of Mikhail Georgiadi that changed the world in 2005. So we approached a totally new understanding of the syndrome of acute decompensation. And we know about multiple factors that lead to that. And speaking about decompensation, we should speak about the renal function of the patient and what happens to the kidney. That's why I'm very happy to give the floor to our next speaker, Professor Halimov, who will cover the issue of sodium-hydrogen exchangers and their role in the HF development. Dear Alexander, distinguished colleagues, it's a great honor for me to make a very interesting presentation and to cover this topic, the mechanism of heart failure development and renal dysfunction. At the same time, we will speak also about the patients with diabetes. So let me introduce some general data. What are the sodium-hydrogen exchangers? These exchangers are called sodium-hydrogen pumpers or exchangers, and they are membranous proteins that are transporting sodium into the cell and the protons out of the cell, so antiports. So there are 9 isoforms, and by some data up to 11 isoforms that are prevalent in all organs and tissues. They are responsible for the supporting of the homeostasis, mainly acid-base balance and sodium homeostasis, mainly intracellular. And it can be activated by multiple factors: angiotensin II, noradrenaline, adipocytogens, plus insulin and glycemia, noradrenaline, neurotransmitters, and adipokines. Activation in cardiomyocytes increases level of sodium, calcium, pH, and increases the risk of apoptosis. This activation leads to the reabsorption of sodium and secretion of hydrogen plus. Defects in ANHE can lead to the renal and kidney failure, and transgenic mice with a superexpression of these exchangers have increased reabsorption and sodium retention after the increased salt intake and proneness to arterial hypertension development. Well, specifically, we can say that in the heart, we see isoform 1 of this exchanger, and in the kidneys mainly type 3. But if we appreciate the expression of the gene which is coding these transport proteins, so you can appreciate that in fact all the organs, not just heart and kidney, they all contain very different isoforms of sodium hydrogen exchangers. So how NHEs are working? So here you can appreciate two schemes. With the influence of different factors that I already mentioned before, sodium is coming to the cell and hydrogen ion goes out of the cell, and sodium at the same time facilitates through a number of mechanisms the increase of cytoplasmic calcium. And possibly it's sort of an adaptation mechanism, because in acute stress it helps contractility of myofibril cardiomyocytes, but on the other hand, it helps development of protective factor if we need contractility, and this is hypertrophy. But as Professor Arutyunov said before, that the devil is in the details, and the detail here is that increase of cytoplasmatic calcium is normally associated with the reduction of calcium in mitochondria and in the endoplasmatic reticulum, and the consequence of that, with this chronic calcium increase in the cytoplasmatic increase, are negative with the long course and even catastrophical. Here on the scheme, you can appreciate what puts together HF and diabetes. We see activation of NHEs in the heart, in the kidneys, in the vessels. That happens with the influence of quite common factors, factors that whip progression of arterial hypertension, heart failure, diabetes type 2, and this is retention of sodium by kidneys on the one hand, and on the other hand, hypertrophy of myofibrils and further fibrosis. All that facilitates progression and terminal stage of HF. Hyperinsulinemia, hyperglycemia also activate NHEs, but the activation of NHEs, sodium hydrogen exchangers, facilitates worsening sensitivity to insulin, worsening of glycemia, and the development of micro and macrovascular complications. Therapeutical potential of NHE inhibition was seen already long ago. We first believed that inhibition of this specific mechanism can help improvement of ischemic heart disease, heart failure, especially in patients with type 2 diabetes. That is why even the drugs were designed, so-called NHEs inhibitors, and specifically two of them, cariparib and eniporib, also passed even clinical trials, but at the same time it was shown that it didn't improve the prognosis of the patients, although in some studies they even reported the increased rate of cerebrovascular events. But at the same time, new class of drugs, anti-diabetic drugs, SGLT2 inhibitors, also demonstrated the capacity to inhibit NHEs, but at the same time, they do the opposite. They reduce the event rate, renal and cardiac event rate. Yes, and big interest popped up after the publication of 2017, when we saw that EMPA decreases myocardial cytoplasmic sodium through inhibition of the cardiac sodium hydrogen exchanges in rats and rabbits. So that were preclinical models. If you appreciated here that the most important is that EMPA truly reduced cytoplasmatic sodium, but in presence of cariparotide, that was minimized. But on the right side of the slide, you can appreciate that AMPA, as a mono, effectively inhibits that transporter, reduced cytoplasmatic sodium, even at absence of glycemia. So that completely excluded that effect of AMPA. And we saw that that effect is not influencing SGLT1, that mainly expressed in the heart. So this is how SGLT2 inhibitors working. So they block sodium hydrogen exchanges, they reduce the amount of cytoplasmatic sodium. That leads to the increase of calcium, and not only in the endoplasmatic reticulum, but the most important, in mitochondria. So from here we see the improvement of energy balance and reduced oxidative stress. So wrapping up, I would like to say that definitely our understanding about the new modes of action that we see in this chronic heart failure progression are getting bigger. So we understand more and more, especially when we start using this new class of drugs, SGLT2 inhibitors. And this is how we can reduce activity of NHEs. And this mechanism is one of the better known versus other mechanisms of direct myocardial effects of this class of drugs to the heart. Thank you very much for your attention. Yuri, thank you very much for extremely interesting presentation. And I would like to say that we got the position of endocrinologist, we got the position of cardiologist. We talked about the risks that patients carry on. We said CHF, we said diabetes type 2. So from different sides, we covered the issue of kidney involvement into the pathological process. That's why it's my pleasure to give the floor to Professor Janaka Karalidi from King's College London, nephrologist, expert in the diabetic kidney nephropathy, with his presentation, Kidneys as a part of Cardiorenal Metabolic Syndrome. The floor is yours.
Thank you so much, and it's a great honor and pleasure to be part of this expert panel in this speed session. And what I would like to focus on is the kidneys as a key part of the cardiorenal metabolic syndrome. As many of you know, there is a complex interrelationship between the metabolic, cardiac, and renal systems. And this is multifactorial. You saw and you heard some elegant presentations. And there is a combination of inflammatory pathways, oxidative stress, alterations in fluid dynamics, the sodium hydrogen exchange, as you heard. And this combination of these elegant and complex pathways leads to damage in two organ systems, the heart and the kidney. And even if we look at insulin as a hormone, we know that insulin not only has metabolic effects, but also has vasodilatory effects and has a direct effect on the kidney in terms of salt and water reabsorption. And once you have disease and the combination of heart and kidney, these two organs are symbiotic. They live together in health and disease. And when you have dysfunction and damage in one organ, it translates to dysfunction and damage in the other organ. Activation of the sympathetic nervous system, alteration in salt and water balance, increased mechanisms of water and fluid overload, resulting in underperfusion, damage to the kidneys, damage to the heart. But there's also hope here. There's an opportunity here because what we know is that if we can treat the heart, we can improve the kidney. And similarly, if we treat the kidney, we can improve the heart. So although these organs are connected, we have this opportunity to help the organs in the state of disease, in the opportunity to intervene early. And in the topic of this conversation, what we know, as you heard earlier, is that once the patient has kidney disease, the prognosis is very poor. Many patients die of cardiovascular disease before they end up on dialysis. And what you can see here is as the chronic kidney disease increases in severity, as the GFR drops from 60 down to 45 and 30, you have an increasing rate of heart failure, increasing prevalence. Nearly 50% of patients or more can have heart failure as kidney disease worsens. And what's even more important, as you heard, is that hospitalization for heart failure is nearly 5 times greater in patients with chronic kidney disease. Further, mortality. Once a patient has chronic kidney disease and heart failure, This is a deadly combination. This results in a significant loss of life, with mortality approaching 30 to 40% in patients who have chronic kidney disease and heart failure. This deadly combination resulting in a huge impact on patients' lives and their quality of life. And as you heard earlier, the EMPEROR trial builds on the previous data with DAPA-HF, and we see this remarkable benefit on reduction in the combination of cardiovascular death and hospitalization for heart failure, and this significant benefit in patients with and without diabetes. Empagliflozin significantly reduces the hospitalization for heart failure. And if you look at the kidney, and this is very, very exciting for people like myself, because now we have evidence in patients with heart failure that the use of empagliflozin actually protects not only the heart, but also protects the kidney. Here you can see the data for people with and without diabetes for the primary renal outcome, which is a composite renal outcome of end-stage kidney disease, and a profound decrease in GFR. And you can see this significant reduction in advanced renal disease in people with and without diabetes with the use of empagliflozin. In contrast, in the DAPA-HF study, we did not see the same benefit for the composite renal outcome, but there was some signal for benefits in GFR. But EMPEROR was different. We now see the benefits for a hard renal outcome in patients with heart failure with the use of empagliflozin. And if you look at changes in GFR, and this is so vital, this is something I always tell my junior fellows, is that you must look at the pattern of GFR to predict where the patient is going. And what you can see here is that in people with and without diabetes, the use of empagliflozin in the EMPEROR trial protected the kidney. You see this early drop, which is a hemodynamic drop, very much like you see with ACE inhibitor, and then stabilization, while in the placebo group, you have the continued decline and fall in GFR. And the use of empagliflozin gives you extra GFR. It is protecting the kidney nearly 2.2 mils per minute per year. This is significant because in 5 years, you're saving 10 to 12 mils per minute of GFR. And these benefits are seen in people with and without diabetes, which is really important because now we have drugs that are protecting the heart, but also preserving and maintaining the kidney. And in Russia, the use of Jardiance is way ahead of what we can use in London and in the UK. And at the moment, Jardiance can be used down to an eGFR of 30, which is hugely important because it means that many, many patients with heart failure can get the benefits of this drug when they have chronic kidney disease to really improve their cardiac and renal function and prognosis. And in the reality of the world we live in, this is sadly in London, we have patients who get seen by different specialists. They have heart failure and the focus is on adjusting the diuretics. If they see the kidney doctor, they're worried about acute kidney injury, so they're stopping ACE inhibitors and worrying about hyperkalemia. Then they see a diabetologist and then they focus on just one aspect. But what we know is that patients with diabetes, heart disease, and kidney disease are one patient. This patient with diabetes has a high risk of heart failure, has a very high risk of chronic kidney disease. The patient also has chronic kidney disease with a high risk of heart failure. And there's complications managing their diabetes with hypoglycemia. Patients have ischemic heart disease and have a high risk of early cardiovascular death. They also have huge problems with regarding heart failure. And the title of this session is so important, and I was really thrilled to be part of it because it is about teams. One patient, one disease, one team. Our patients do not only have one disease, they have multiple diseases, and we need to have this joined up approach to really improve things and improve the outcomes rather than just focusing on one aspect. One patient, one disease, one team. And really, my final slide, just to remember this simple message: 4 medications, 5 targets, And remember, these are acting on the heart and the kidney. This is what I love about these treatments. They're acting on the heart and the kidney. ARNIs, beta blockers, mineralocorticoid antagonists, and SGLT2 inhibitors. And the use of this combination gives you 6 extra years of life, as you heard earlier, for a 65-year-old man. 4, 5, 6. Hugely important, hugely impactful. Thank you very much for your attention, and I'm very happy to take questions.
Janaka, thank you very much for your presentation, for including of kidney into this pathological circle. Here we see this is the vicious circle. There is CKD, there is heart failure, and there is ischemic heart disease. So this is the same patient, as you said before. This is the same patient, and this patient cannot come just to endocrinologist, or just to cardiologist, or just to GP, or just to nephrologist. So in Russia, we have 4 specialty: cardiologists, nephrologists, and GPs. No, we have no right to split this patient in between 4 specialties. This patient belongs to each of us, and we need a multidisciplinary approach, and we should jointly measure these patients, multidisciplinary. And now I'm giving the floor on the issues
to give the floor to our next presenter
chronic heart failure and type 2 diabetes.
Mellitus type 2 and
I am giving the mic to Professor
The floor will be
Zhirov.
given to Igor Zhirov, and he will be talking on this issue. Igor, the floor is yours. Distinguished Alexander Grigorievich, thank you for the opportunity to speak in this wonderful audience. And as for the theme of my presentation, well, I would not like to say that I will sum up what has been said, but I will repeat the many things mentioned today by our distinguished colleagues from different countries. Here is the conflict of interest. 4 years ago, Eugene Brunwald at the Rome Congress of Cardiologists said that a high increase in the number of chronic heart failure is what we have to pay for achievements in modern medicine. Yes, we can now treat acute pathologies quite well. When it's acute myocardial infarction, patients do not die all that often. As for other acute conditions, patients get therapy at the early stage, and sooner or later, this acute form turns into chronic. So that means we'll have more patients with chronic heart failure. The time of hospitalization is a very important problem. And here I'd like to draw your attention to the outcomes after hospitalization for this or that reason. Yes, if it's a hospitalization for acute coronary syndrome, is linked to unfavorable outcome, but if we consider cases when patients were hospitalized due to decompensation of heart failure, what Professor Artyunov mentioned at the very beginning, the outcome and the prognosis is much worse as compared to other types of cardiological hospitalizations. So this time when patients develop CHF and the issues of outcome is a serious problem that needs to be solved. Diabetes mellitus and CHF, here you can see the Russian registry. The main reason for death of such patients with diabetes mellitus is heart failure. The risk of development of heart failure in patients with diabetes mellitus increases by 2.5 times. What are the reasons for that? I think we cannot see any changes in internal organs in patients with diabetes that could lead to a higher risk of the development of CHF. Well, hypertension, we can see the systemic inflammatory response, so we can see the endothelial dysfunction, fibrosis, remodeling of the left ventricle, specific changes in the autonomous nervous system. All this leads to the diabetic cardiomyopathy. And what is most interesting is that patients with diabetes mellitus have a significant risk of the development of chronic heart failure. Yes, we believe that as for patients with atherosclerosis, they have more cases of heart failure, and also Professor Galstian mentioned this information. Patients with diabetes mellitus have a higher risk of non-ischemic heart failure, and Professor Galstian showed the three forms, well, with preserved, with reduced and partially reduced ejection fraction, and you can see that diabetes mellitus has a negative impact on the development of chronic heart failure. Another important aspect is the adjustment of risk factors, which is very important for any practicing cardiologist. But I'd like to draw your attention to the results of this large-scale Swedish registry. Dear colleagues, patients with diabetes mellitus type 2 who were compensated on major risk factors, which means that they had the targeted level of glycohemoglobin, the targeted level of blood pressure, and the lipoproteins. These patients stopped smoking. They had no albuminuria. That's a very refined group of patients. Even in this refined group of patients, the risk of hospitalization due to chronic heart failure was higher by 45%. In other words, we have a new hypothesis. The residual risk or additional risks of patients with diabetes mellitus. This hypothesis allows us to say that in our practice, we need the specific and aggressive methods of treatment of chronic heart failure in patients with diabetes. To sum up, the burden of heart failure is very significant on the healthcare system due to an increased number of hospitalizations. Diabetes mellitus type 2 is an ideal model of developing chronic heart failure with preserved or reduced ejection fraction. Diabetes mellitus type 2 worsens the prognosis for the outcome of heart failure. The hospitalization frequency due to chronic heart failure is very high in patients with diabetes mellitus type 2, even if we control the major classical cardiovascular risk factors. Finally, we need new therapeutic models. We need new therapeutic solutions, reducing the residual risk of patients with chronic heart failure and diabetes mellitus. Type 2 SGLT2 inhibitors can achieve quite good results, and they are beyond that neurohumoral paradigm used in the classical model of management of patients with heart failure. Thank you. Igor, thank you so much for your presentation. I'd like to say that those therapeutic models you've been mentioning, that's in fact the use of SGLT2 inhibitors. I would like to sum up of what has been said, and please put on my presentation on the screen. I should say SGLT2 inhibitors are widely used, and SGLT2 inhibitors are interdisciplinary drugs. And we can say that patients with chronic heart failure and chronic kidney disease should be treated by interdisciplinary teams. Let's look into the future. Let's see what the future holds for us. SGLT2 inhibitors epoch started way back in 2002, and we can see that those patients who were on these inhibitors amount to many thousands. SGLT2 are used in different situations to treat diabetes mellitus, and now we treat diabetes mellitus, chronic heart failure, and chronic kidney disease. You can see that empagliflozin, and this is the EMPOWER trial data. Patients with a reduced ejection fraction, patients with diabetes mellitus, patients with heart failure, the impact of SGLT2 inhibitors on myocardial infarction of high risk. You can see that SGLT2 inhibitors are not just used within one niche, but this niche has been expanded. SGLT2 inhibitors are one of the stumbling blocks used to treat heart failure. So they also occupied this niche as well. Well, chronic heart failure is not a disease, it's a syndrome accompanied by many events, diabetes mellitus, chronic kidney disease, atrial fibrillation, and high probability of viral and pneumococcal infections. That's a comorbid patient, and of course there should be universal drugs applicable to such patients. So yes, there will be more and more studies on SGLT2 inhibitors in terms of how they can slow down the progression of chronic kidney diseases so that it could be slowed down to the extent it is possible, which was mentioned by Janaka Karolida. And of course, you can see that there is the study Credence and DAPA-CKD. Well, that's stage 4 of chronic heart disease, and EMPER-Kidney. This study will end in several years, and you can see here we're talking about not just albuminuria, but also A1, A2, A3 areas, because in real life we encounter different patients. If you look at the coverage rate as far as the studies are concerned, well, EMPER-Kidney is still in progress, but as for the studies which have already been finished, you can see that FDA approved dapagliflozin for patients with progressive renal failure, and you can see the studies which have shown very good results. Well, again, dapagliflozin can slow down the progression of the disease, even reverse it, and empagliflozin now can be used on patients after MI, as SGLT2 inhibitors have taken up a new niche in comorbid patients who now have the onset of CHF due to risk factors which unfortunately occur in 2.5 billion patients. These are patients with low quality life, and now we have instruments which can help all these 2.5 billion patients. Thank you so much. And now let's move to the discussion, because during the discussion we'll cover those issues which were not raised during the presentations. I'm going to finish my presentation. Please turn on cameras. All the speakers, please turn on cameras. We would like to see your faces. Dear colleagues, I'd like to start the discussion and not to waste any time. The first question, and actually we got lots of questions here today and during the previous month. The first question is diabetes and chronic heart failure. When should we start the treatment with SGLT2 inhibitors. Well, I would like to ask you to answer this question. SGLT2 inhibitor, should it be after ACE inhibitor, like if it's a naive patient, and should the SGLT2 inhibitor be with ARNI, administered on parallel with ARNI after ACE inhibitor, before, together? What's your view? Who is going to speak first?
Let me start. If the patient has diabetes and this patient comes to the appointment, so me as a cardiologist, I will be easy to administer the drug which is called ARNI, yes, and SGLT2 immediately. I am not going to wait. Aren't you afraid of hypertonia? No, no. I will start with starting dose and I can start titration. And this is our medical art to prevent hypertonia. Don't start with maximum doses. Don't victimize the patients. No, starting dose and titration. But I know that there are two active drugs that reduces the risk of mortality. I'm not going to prolong time. I'm not going to waste my time in the interval in between. If patients with hypertonia, yes, then the choice is more difficult. And if this is sustainable hypertonia, I will think twice what to administer, what to select. But then I will resolve the other question. But for the vast majority of the patients with diabetes and with CHF, oh, I'm not going to be puzzled. I will start dual combination with the minimal doses with a trend to increase the maximum doses, SGLT2 and ARNI. That's my point. I wonder what others think. Well, you mentioned slow titration, so you would start the titration from 50, speaking about ARNI. Am I right? Not from 100, if GFI even allows, but from 50 in any case, right? So that means there are some specificities of combination. No doubt, no doubt. Definitely, both drugs would be influencing. I would be cautious. But if you recollect the design of the study, if you're based on design, then the drugs were administered in already accepted schemes of treatment. I think there could be two options. Based upon the design, you can give baseline treatment and then to add on top. But I think it's wasteful time. It's waste of time. So most important, knowing that this is success treatment, we should start from combination. Combination with good control of BP, with improved control, but still with all of them. We should initiate all of them. So without ACE inhibitors, you start from ARNI and SGLT2. Yes, that's my approach. That's my approach. Because that's what you ask. The patient is coming. That means patient is stable. Patient is coming to me. Because the patient is not stable, hemodynamically not stable, I would wait until patient is stable. But if patient comes, patient is stable, well, I'm not handcuffed. Nothing prevents me from starting of treatment with quadruplet. What do you mean stable patient? What do you mean? What do you mean by stable patient? Well, stable BP, which is not requiring immediate change of the treatment. And actually, it was not needed for the last 2 weeks as a minimum. Stable treatment, stable condition, stable patient, and that's more than enough to start the treatment. So now you are using the criteria of stability needed for ARNI, right? Yes, I'm applying ARNI stability criteria, absolutely. Yes, my second name is Mrs. Kalashnikova. And this criteria of stability were received just in paradigm, but that was criteria of the study. Not just paradigm, it's common sense, it's common sense. Stability criteria tells us patient is okay. BP is not ups and downs, no need to change, no need to switch to IV, doses stable, no need to increase. Patient is okay, patient is okay. Criteria, how I assess the effect. Patient is stable. Come on, stop bullshitting. Let's move on. Professor Dan, your position, please. Unmute, unmute, unmute.
Yeah, difficult after the recital given by Grigory Pavlovich. And sincerely, I agree with a lot of his statement. I will focus on 3 different aspects. So the question is when to start SGLT2 inhibitors in heart failure. First, we do not have evidence in this regard. So we need to wait a little bit to the evidence and to guideline to know exactly how the rule will be. But Grigory Pavlovich is absolutely right. When the law is not clear, we have the common sense to decide the action. And the patients, in my opinion, are divided into the diabetic patient with heart failure is a good indication for the beginning. No way and no reason to wait to introduce this medication on such patients. Doesn't important the HB hemoglobin reduced level at this moment. The second, a little bit more difficult, is a patient with heart failure without diabetes. This is a little bit a moving sound, a moving sand. It's not exactly clear at this moment, but in my opinion, in the patient in the pre-discharge period, in the pre-discharge vulnerable period, it is the best time to initiate both ARNI and SGLT2 inhibitors. It is real that we have evidence in this sense for the ARNI and not yet for the SGLT2 inhibitors, but do not forget that the indication of the gliflozin in heart failure without diabetes is a very young indication, and probably will have more refinement in this period. But on me, I will begin this treatment in the pre-discharge in the patients with still congestion phase. Of course, what I want is not exactly what I can, because even if I want, if the social security, if the regulation in the country do not allow me to give this medication, I remain with what I want, and I cannot do what I may and I have to do.
Professor Dunn, you mentioned the administration of the drug at the pre-discharge. We know very well what happens at pre-discharge. Patient in hospital, patient was decompensated, possibly there is concomitant infection, possibly pneumococcal due to the Thompson antigen and pneumonisine, kidneys damaged. Then, from the standard diuretic doses, he switched now to a high bolus, sometimes infusion, that can provoke peak natriuresis and also can damage the kidney. The patient was getting AB treatment, and that also can provide some nephrotoxic effects. So in fact, we are talking about the administration of SGLT2 inhibitor to a patient at the moment when he just stabilized 5 minutes ago and possibly is having not very severe, but maybe acute kidney injury to a certain extent. Can we be confused? Can it prevent us from this administration? What do you think?
I should clarify very clear concept. It was very often emphasized by Mihai Gheorghiade, the Professor Gheorghiade from Chicago, he's Romanian in origin, that we should not confuse the hospitalized patient with a pre-discharge patient. The pre-discharge patient is a stable patient. I will not advise the introduction of the gliflozin in a not yet stabilized patient.
What criteria of stability could you offer to such patients? Stability criteria. The same like in Paradigm HF or maybe some other? Stability criteria. Maybe the same like in Transition or in Pioneer or maybe some other. Please speak up.
This time your question is quite provocative, but I come back to Grigory Pavlovich, probably also because we have an age which is quite close, and I will say that I am not looking for paradigm criteria, neither for Emperor or other study. I am looking for the pure clinical criteria of the stability, and we know this criteria of stability. And this is the feeling and the symptoms of the patient, and also the criteria shown by biomarkers for congestion. So in a patient, for example, a clear example, in which the dyspnea has improved considerably, in which he has lost some kilos, in whom the BNP lowered at least 30% from the initial state, I consider this patient stable, especially if this state is maintained 1 or 2 days.
Well, BNP level can create some confusion, because if this is administration of sacubitril/valsartan and SGLT2, we see that Vladimir also wants to provide his position. Vladimir, please.
No, I'm sorry, not the BNP, the anti-pro-BNP, which is not altered by the army medication.
Анти-про-БНП, да-да. Спасибо за комментарий, Владимир Владимирович.
Thank you for your comments, Vladimir. Well, Alexander, I think in the situation you draw this picture, we should make one more focus, which is related to the metabolic status of the patient that is in front of the doctor. And here's this deadly combination, diabetes plus HF. I think in this case, we should be properly guided whether the target levels of HbA1c were reached or not, and if yet we are not satisfied with the level of control, then possibly the administration of SGLT2 inhibitor could be very promising from this point, because this is how we can strengthen the anti-diabetic efficacy of that combined treatment that patient is getting. But I think in the frame of current discussion and those new international guidelines that we are guided by, it's much more interesting to look at the situation when we look at a patient who comes to cardiologist, to GP, or to therapist, or to endocrinologist, in this combination of HF and diabetes, with more or less satisfactory glycemic control. And this glycemic control is done by neutral drugs. And in this case, definitely, we need to make the next step. We obviously have to transform anti-diabetic treatment, and removing neutral drugs from there, we have to add on SGLT2 inhibitors without being satisfied with more or less target level of existing HbA1c. We have to replace, we have to switch, we have to switch, and switch. We have to resolve the issue of control to manage CHF. And this resource is now available, as this class of drugs, SGLT2 inhibitors, and specifically Jardiance, will soon be able to have both indications. And I think this is very important accent, and it should be properly understood by those who will deal with such patients in primary chain. Thank you very much. Gagik, Yuri, from the position of endocrinologist, can you agree with Vladimir, or maybe you can make an objection, or maybe reformulate the statement? Well, generally, I'm supporting Vladimir, as always, because I believe that if this is diabetic patients with heart failure, then in any case, we have to add on SGLT2, because it improves the prognosis in terms of heart failure of diabetic patients. But again, in case of the situation when the patient is getting several antidiabetics, like a combination, I would first add on and then possibly make decision what to remove, because I'm afraid if we remove immediately or if we replace, better not to lose the control, because if patient is in the control, if the patient is in the target, so better add on first and then to remove. So in the real practice, it's sometimes difficult to understand what to stop, what should be replaced. Because in the trials, for example, in EMPA-REG outcome and in the further studies on cardiovascular outcomes, SGLT2 inhibitors mainly added. They were added, and patients did not actually were not replaced. So I think it's safer. It's safer to follow this strategy. First, add on, and then you can look at the situation. You can reduce the dose, or you can select something that can be stopped. This is my only comment. This is my only comment to what Vladimir said before, and I totally agree with the rest. Well, thank you very much for your position. So before we give the floor to Yuri, let me narrow the question a little bit. Let me narrow this funnel, because the majority of our audience are from Russia. They're Russian-speaking. We know very well that in Russian Federation, like in many Eurasian countries, for the first time, the diagnosis diagnosis, CHF and diabetes is done when? When there is first decompensation, when they are hospitalized. Because very frequently, for years, these people are rolling around without knowing the diabetes, and they explain their edemas by poor socks or poor shoes. But we still need the criteria of stability, and today we mentioned different criteria of stability, but still, well, does not have the common unified position. We just based upon common sense, as Professor Dan said before. Yuri, from the position of endocrinologist and from the position on how we can identify the stability of this patient, how would you characterize such patient? Well, thank you very much for this opportunity to speak up. I would like to add on the answer of Vladimir and Gagik with a short remark. In those patients where we make the diagnosis CHF plus diabetes, and sometimes this is already advanced stage of CHF, according to the existing algorithms about the target levels of glycemia, we are satisfied with quite democratic levels. We believe if the patient has CHF, let's say class 3 by NIHA or higher, then it's quite okay if HbA1c would be 7.5 or higher, even higher. So I would like to draw your attention to that. So why? Where it comes from, this target levels? Well, all that comes from the results of ACCORD. Remember, many years ago, when for the first time it appeared to be that stringent glycemic control appears to be not useful to everyone, not to everyone. But let's recollect what patients were taking in ACCORD, because there was nothing. GLP-1 agonists, there was very, very small group of patients who got DPP-4 inhibitors, but the rest, mainly there were patients, well, let's forget about SGLT2 or GLP-1 receptor agonist, nothing like that. So frightened by those results, still frightened at aggressive treatment by these treatments, including TZD, insulin. And I remember that every third patient was getting five component combination. That is how we found this criteria of compensation for polymorbid patients with low, very short life expectancy. But now we know about this relation between the metabolic status and this factor like sodium retention. We understand how it is important, and water retention. So all these hemodynamic consequences, definitely we have to reach maximum possible compensation if we use safe options. What are they? Metformin, DPP-4 inhibitors, these are GLP-1 receptor agonists, and SGLT2 inhibitors. And definitely for CHF patient, I would be concentrated on these opportunities, these classes. If we use them and we see that risk of hypo with these drugs is minimal, then we can reach absolutely new targets and not be afraid. Well, Yuri, let me just keep on what you said. Patient, CHF plus diabetes, there is huge risk of coronary death. That is why they MACE, classical MACE, you know, cardiovascular mortalities, non-fatal MI, non-fatal stroke. So I would not extend this list of drugs. I'm not an endocrinologist, but I would say what is the first and foremost important, SGLT2 inhibitors and GLP-1 receptor agonists, and nothing else, and nothing else. Because GLP-1 receptor agonist, well, it's not worsening, it's not getting worse, it's improving MACE, and SGLT2 inhibitors truly improve MACE, but the rest, almost no influence, neutral. Grigory, well, I have to agree with you. Definitely, selecting the drug, we are looking at SGLT2 inhibitors, we are looking at reduction of mortality and hospitalization from EMPA-REG, but no expert in their answers covered kidney issue. That's why let me readdress this question. The moment of pre-discharge, and let's ask our nephrologist expert, Janaka. And once again, Should we take into consideration that fact that at the stage of hospitalization, and this is Russian experience and big registries tell us, these patients are very frequently have acute kidney injury because of pneumococcal infection concomitants, because we have low percentage of vaccination in our country, or overdoses of boluses of diuretics. This is ups and downs of natriuresis that also lead to kidney damage, or maybe some incorrect administrations of AB treatment. So from this point, don't you think it's safer to wait? Or do you think at pre-discharge it's okay to administer? Janaka, please.
Thank you very much. I think I'm really happy you brought the kidney because I felt it was it's such an important assessment. I agree with the comments about clinical stability. With kidney function, I think it's really difficult if you don't have previous values. And I appreciate that often you may not in the real world have previous values of GFR and serum creatinine. However, it's about the trend. So if during the hospitalization there is recovery from the acute kidney injury towards some degree of stabilization, the blood pressure is satisfactory, there are no hypotensive events, the data for SGLT2 inhibitors is actually very good. The data suggests that they actually prevent acute kidney injury in randomized clinical trials and in real-world observational trials in the US. They prevent AKI probably because of arenoprotective energy efficiency, hypoxic damage limitation at the level of the kidney. So in our clinical practice in London, if the GFR is stable and is recovering above 30, we would be initiating an SGLT2 inhibitor. And clearly what's important is education for the patient in terms of managing the doses of diuretics, SGLT2 inhibitors, and other antidiabetic drugs in the setting of acute illness. So something we spend a lot of time with our patients is talking about what to do with medicines if they become acutely unwell. And we call this sick day rules. And this is educating patients if they become acutely unwell and decompensate, what to do with their medicines and when to restart and review the medicines. So in a summary, eGFR, if it's stable and recovering above 30, there's no acute decompensation of blood pressure, and there's no hypotension, we would start the SGLT2 inhibitor. There's very confident data that these drugs protect against AKI, but most importantly, they protect against long-term kidney deterioration. So we are treating the kidney as well with the SGLT2 inhibitor. Not only the heart, but we're also protecting the kidney, which is, as you heard, very closely interconnected with cardiac failure.
Thank you very much for your comments. I can agree with two statements. Administration at pre-discharge, this is very valuable from the point of compliance. We know the earlier, especially at the hospital stage, the earlier the drug is administered, the higher would be compliance after discharge. It's very valuable that SGLT2 inhibitors can prevent the development of AKI. We see how lines are splitting and the probability of AKI after the administration is getting lower. And now we are saying what happens at the moment of discharge, right after the acute kidney injury, in the situation where the patient with a low GFR, with creatinine level, and by the moment of discharge, sometimes it's lower and creatinine even higher. What in such situation, how much to wait? How much to wait until administering SGLT2 inhibitor?
So I think, as I said, our license in the UK allows us to use the SGLT2 inhibitor with the current update with a GFR above 30, but it's stabilization. So we would want to see the trend going with the estimated eGFR above 30. And routinely, these patients will have a follow-up renal blood test in 2 to 4 weeks, because they're also having up titration of their ARNI and background diuretics being adjusted. So we would want to make sure that the GFR is above 30 and is remaining stable. Any decline in GFR of 10 or 20% or more, we would be cautious and look only at also the background therapies and also importantly the potassium. We mustn't forget the potassium. So the potassium level and the trend in the potassium is vital. And it's often if the potassium level is climbing above 5.5, 5.5 towards 6 acutely, we would be concerned about the background RAS inhibition and aldosterone antagonists. But SGLT2 inhibitors have the benefit of being used in this situation, where they do not have an effect on hyperkalemia, so that's why our approach is to use these early.
Thank you very much, Igor. Now I would like to ask you to sum up and wrap up our previous discussion. So please appreciate, our experts provided a little bit different criteria of stability. Possibly we will use something else, maybe the scale, wet, cold, hot, warm, whatever, maybe something else for the stability assessment in the patient. And the other question is, try to sum up, please, the position of the expert. So shall we use them in combination in one day, SGLT2 and ARNI, or maybe just something one? Because nobody preferred any of the classes, both said jointly. So please speak up, like you were speaking up before with the resulting presentation CHF and diabetes. So could you please make up summing position just for the practitioners who are listening to us today, more than 5,000 GPs from all over Russia. So when to administer, what criteria stability to administer as a combination or one after the other? Thank you very much, Alexander. Well, thank you very much for your trust. Thank you very much for your trust to sum up. I would like to add on just a few words to what was said before. First, in Russian Federation, we have recommendation for the management of CHF patient, which is approved by all the regulators. And these recommendations for CHF treatment, SGLT2 inhibitors, are already included. The correct wording is like this. Administration of SGLT2 is indicated to CHF patient if the triple treatment did not lead to the clinical improvement. And this is the double sword question. What is the clinical improvement? How do you interpret it? How do you define it? And when we speak about the patient that is hospitalized with CHF decompensation, we understand that this is Grossmeister chess-playing game, mastery, and all available guidelines for the management of these patients have a pretty moderate level of evidence. And what is important here is to have a differentiated approach in the administration of different drugs. ARNI group, sacubitril valsartan, except those effects that we already covered today. It's just a reminder to the colleagues, because in paradigm HF, we saw that the administration of sacubitril valsartan led to the reduction of HbA1c, almost 0.5%, surprise, surprise. And also, sacubitril valsartan combination reduced the need in the insulin initiation by 30%, 30, in the future. So, if we sum up, or if you let me provide my position, I would say the following. From RAS blockers, well, definitely this is ARNI, this is sacubitril valsartan. Also, we have several very convincing pieces of evidence that confirm that these drugs are effective in the long-term administration. Second, we have crystal clear evidence checked and presented in the available guidelines, in the consensus statements, including, by the way, the statement of European Heart Failure Association, saying that in the hospitalized patients with heart failure decompensation, sacubitril valsartan should be more preferable than ACE inhibitor. More preferable, I repeat it once again. So if we talk about the patient with CHF and diabetes, hospitalized patients with acute decompensation of HF, then it is ARNI as a drug of choice among all RAS blockers is more preferable. It has proper evidence base, which is presented in the guidelines, and also it follows common sense. Next, when to administer SGLT2? This is Interesting question, which probably does not yet have such stringent evidence-based data. But again, from the point of common sense, from the point of advantages for the patients, if we see that the patient is stabilized enough, so I totally agree with Professor Dunn. This is how we can define the stabilization criteria, and I agree with Professor Dunn. This is hemodynamic stabilization. This is favorable dynamics of anti-proBNP. This is euvolemia. This is euvolemia. So why not? Why not to administer this treatment, which will help to prolong life expectancy to our patients, and beside life expectancy, to reduce the symptoms, improve the quality? That means we are not simply increasing life expectancy, miserable life with disease, but we increase life expectancy free from clinical manifestation of CHF, from the episodes of decompensation. Thank you. Well, thank you very much for your summing up. Thank you very much for summing up, for the concentration of the data from the discussion. And I want to totally agree you with this position. We are speaking about the stable patient, stable from the position of hemodynamics, where it's possible, stable from the point of anti-proBNP, if he's getting only is just anti-proBNP, not just BNP, but anti-proBNP, and patient is not requiring dramatic change of diuretics. And I think that would be the optimal solution to administer SGLT2. If by the moment of discharge we don't believe that the patient is stable, then in this situation we should not either discharge the patient or we should not administer SGLT2 inhibitors, and to do it a bit later. Let me move one more step forward. Well, in the indication diabetes, CHF, administration of SGLT2 and the preference of the empagliflozin, in this case, no questions here, but as it is international discussion, we can discuss the data of very recent studies. And I would like to ask questions to the experts. Could you please speak up on the comparison, meta-analysis, AMPEROR reduced and DAPA-HF, because still the population of the studies was pretty different. Yes, we'll look at now that in reduced there were more patients on ARNI, so more heavily pretreated population with more innovative treatments. But on the other hand, in DAPA-HF, there were 19% more patients who had previous hospitalization for the previous 12 months. But in AMPEROR reduced, there were 19% less of these recently hospitalized patients. So they were more compensated, but more implanted devices here. That again speaks for more ischemic genesis of heart failure in AMPEROR reduced. I hope Professor Dunn agree with me that we cannot head-to-head compare population of CHF recently hospitalized and the one who did not have hospitalization for the last 12 months because of CHF decompensation. Do you think it's possible to speak about class effect, or you think the population were strongly different? And I would like Professor Dunn to speak up now, because what we see from what I said before can directly show on different genesis. Professor Dunn?
Thank you so much for inviting me to answer to this tricky question. I should confess that each time I am meeting one representative from the company, from Astra or from Boehringer, they are whistling to me, do you think it's a class effect or is a molecule effect? I should confess my personal opinion. And I hope you all, Professor Giannaka, Grigori Pavlovich, Yuri, Professor Giro will agree with me. I do not believe in class effect. The class effect is a fiction. The molecules, like people, are different. The class effect is like a class in a school. The people are different. But the problem is how different is the action of these molecules in terms of what we are following, so the end points, and in terms of safety. After this philosophical introduction, at this moment, my opinion is that very different from GP1 analogs, the gliflozin effect is a class effect. And I have several arguments for this. One is the impressive similitude of the molecules in blocking, for example, the pore of the natrium hydrogen exchanger. So this is counted by a class effect. But I'm sure in the very near future, several differences between different glyphosine will be noticed. Until this time, my proposal, my opinion, is that we need to apply a class effect for the glyphosine. And if somebody asks us, as I was asked, why the mortality is decreased in the DAPA-HF and not in the Emperor, I have two answers. One is a scientific one. Please look at the population in the both studies, as Milton Baker said. The second is a joke. There are lies, unbelievable lies, and statistics. Thank you.
Thank you very much for brilliant response. And I would like to cover one more question, which is very frequent, and we received it already 20 or 30 times for the periods of this discussion. So SGLT2 inhibitors and COVID-19. Oh my God. Yes, clear. There are guidelines telling us, recommendations trying to identify the criteria of patients, the criteria of severity, where we have to stop or where we can already start, or who should be switched to insulin treatment. But now I would like to ask experts to provide their position. At what moment do we make a decision? If patient is taking SGLT2, when we do make decision to stop and switch to insulin? At what? Or we wait until the end, or we do it as early as possible, or we don't take this risk to initiate SGLT2 inhibitors in pandemic of COVID-19? Gagik. Thank you very much. Well, you mean we are not taking risk in pandemic, in diabetic patients? Oh, God. In pandemics, we continue administering. Come on. And I have to tell you that pandemic actually showed us that our patients are less protected. Speaking about cardiovascular mortality, most vulnerable and less protected. That is why definitely the drugs that improve prognosis are extremely needed in this sense, because also we see kidney injury, which is quite frequent. That's why, no, we continue recommending SGLT2 during pandemic. I do it, my colleagues do it, so we all follow that. Now, severity. Those patients who have respiratory failure, those who need hospitalization with reduced saturation, so patients that had objective indications for the hospitalizations, definitely in these patients, we need to stop. Because with such features like fever, respiratory failure, we can get very high risks related to the ketoacidosis, diabetic ketoacidosis. That was actually described for this class of drugs, even in COVID-free period. So these risks are not high, but still, it can happen, and normally they are related to the period when there is increased need in insulin. Because normally SGLT2, this is the positive phenomenon, by the way, but we understand that this is positive. But if the person is in stress, and this is viral infection or severe infection, and it can be considered like equivalent of the stress situation. But here, the need of the insulin can be significantly higher. But if the patient is insulin-free, and if there is also secretion, insufficiency of endogenic insulin, and also insulin resistance, which is developing during viral infection, severe course, then definitely in this situation, there is high probability of diabetic ketoacidosis. And then definitely, in order to avoid that, we need to stop the drug. Then we administer insulin treatment. Then we monitor more frequently glycemic level. But in fact, it's all recommended in the Ministry of Health guidelines. And this is exactly what is done in non-hospitalized patients. They switch to insulin. Those who hospitalize, those who go to ICU, insulin. If it's a moderate or a mild, well, to my understanding, in this case, there is no need to stop. No, just severe severe course. We never stop both metformin or SGLT2 in mild or moderate. But at the same time, some colleagues are afraid. They try to stop everything, but then we can lose the control and we can worsen the prognosis. I think we should not do that. Only severe, only hospitalized, only ICU. That's my point. Thank you. Well, thank you very much. Let me share my short experience. In our hospital, we followed patients with CT2, CT3. This is CT features of severity of COVID. They got oxygen, but they still were on standard treatment, and we did not see any worsening. Absolutely. Those patients who refused or where the doctor did not stop SGLT2 inhibitors, they just continued. So let me sum up our discussion, and I will ask experts agree or disagree with some statements or questions. First, we say that now the moment of SGLT2 inhibitors that no doubt should be administered to the diabetic and CHF patients, and in the near future there would be extension of the indication, and we will do it in CHF without diabetes. I'm speaking about Russian Federation. So probably we will have some advisory board that will clearly identify the criteria of stability of such patients that is getting at the same time two modern classes of drugs, ARNI and SGLT2 inhibitors, and also all the hurdles of these combinations, risks, and some criteria of monitoring. Do you agree, dear experts, that such advisory board could be very useful? Definitely yes, definitely yes. And in that advisory board, we will have to answer about the issues of phenotypes of the questions, because it makes it simpler, and the algorithm of monitoring. Definitely yes, it will make it easier for us. Yes. Do you all agree? Do you all agree? Yes, agreed, completely agreed. No doubts, no doubts, absolutely. Thank you. Thank you very much. So this advisory board would be called in the near future to identify the criteria. Second, as Professor Dan said before, position of class effect or non-class effect can be considered differently. Can in such situation we say that in patients with diabetes and CHF, like it was shown in EMPA-REG, only one study and only one SGLT2 inhibitor demonstrated a reduction of both mortality and hospitalization. Can we say that? Well, all-cause mortality, cardiovascular mortality, and hospitalization, yes, that was combined endpoint. And please correct me if I'm wrong, but we didn't see that with DAPA, this triple endpoint. We never saw it. Dear experts, do you agree with that? Yes, this is a fact. This is a fact. It is just EMPA in this class of diabetic patients reduced the reduction of cardiovascular and all-cause mortality. This is the very stringent data, and nobody could object that. It's a fact. Yes, that's a medical fact, I would say. Yes, medical fact. For sure, for sure. Yes, right. Can I say two words, please? Yes, we can speak about class effect, definitely, about the influence of the drugs of this class to the course of the CKD and the course of heart failure. But speaking about the cardiovascular and all-cause mortality, we cannot call it class effect. No, no, not yet. It's very difficult to disagree with Professor Dan, and I think his position definitely has the right to be. But we are very cautiously speaking about the class effect, about cardiovascular mortality, although we should not be cautious. Why not? Because as soon as we get differences in any of mode of action in between the molecules, that could be theoretical justification for this differences inside the class, then there will be no questions anymore. And we will clearly understand that, yes, there is some features of class effect, but some not. And we have 6 large trials that are telling us that not drugs of this class are the same. Yes, they are not the same. I totally agree with you, and I think this difference would be found at the moment when we think about the genesis of CHF and patient's phenotype, and possibly it will help us to identify that. And the third statement of our current discussion, kidney of these patients needs protection, full-fledged protection, and SGLT2 inhibitors, this is full-fledged protection, as it was shown both in CREDENCE, in DAPA-CKD, and most probably will be shown in EMPA-KIDNEY, which is about to finish very soon. So, in fact, we have no right to keep kidney without attention. And the fact of reducing GFR up to 13 is basic one, because in real life, there are so many patients with different grade of albuminuria, with different grade of GFR. So it just gives us freedom. Do you agree with me that we can easily and safely administering this treatment, and this is how we protect the kidney? Do you agree? Agreed. Well, thank you very much for the discussion. I have to say that the Blitz session was a little bit prolonged, but it's not the end yet. Now, each of the speakers will go to a dedicated room. So 8 speakers to 8 Zoom dedicated room, and the technical support will help us to do it. The addresses of Zoom rooms are at the bottom of the YouTube page and also on the website of the conference. So you can again speak to our speakers directly and having Q&A. So I'm moving to my own room. See you later. Then we have 15 minutes break, and it will finish at 2:15 Moscow time, and we will continue symposium in dedicated halls. See you in the Q&A sessions and during the break. Thank you.
Bye.
Уважаемые коллеги, мы продолжаем нашу конференцию. После яркой скоростной сессии, которая породила множество
Dear colleagues, we would like to continue our conference. After the speedy session with abundance of questions, and which I guess will bring to some conclusions of the expert session, we now go to our symposia. In Moscow Hall, we'll have a symposium on nephrology. We'll speak about the keto analogs of amino acids and how to preserve the kidney function. We were speaking about it at the speedy session. The symposium will also dwell upon CKD and severe patients. In St. Petersburg Hall, we'll have osteoporosis session. In the 21st century, we have no right to ignore this topic. And in Perm, we'll have a symposium on arterial hypertension, clinical guidelines, or real clinical practice. The same question that we had at the speedy session about 30 minutes ago. There are clinical guidelines, but do they cover all the aspects, or we have gray area somewhere, and there we'd better rely on clinical experience. This is possible even when we have arterial hypertension and it's well managed. I go to the symposium on nephrology. Many countries of the world are represented: Russia, China, Hong Kong, US, and Thailand, Bangkok. Dear colleagues, I would like to give the floor for the introduction to Ashot Movsesovich. Please, the floor is yours, Dr. Yesayan. Thank you very much, Alexander Grigorievich. Great pleasure to see you. Dear colleagues, it's a great pleasure to meet you all again at this very important event. But before I begin my introductory word, I would like to congratulate Aygul Usubaitova. She is working at Fresenius Kabi company. I want to wish her happy birthday and best wishes. And now let's go to our event. It is dedicated to a very important problem of the slowdown or prevention of renal dysfunction and the concomitant cardiovascular complications among the patients with CKD. If you were listening to the speakers and you were watching the program, you have probably noticed that we paid a lot of attention to the problem of comorbidity of the patients, and of course, in this sense, cardiac renal correlation is one of the most important parts of medicine, cardiology, nephrology, and internal medicine in general. So yesterday we had the first international seminar with the participation of leading nephrologists of Asia, America, Europe, and we were talking about cardiac protection of the patients with CKD. We were talking about reduction of protein consumption and cat analogs of amino acids, added or not. Today, this it plays an important role in nephroprotection and management of the renal patients with renal pathology. This seminar is called the use of cat analogs of amino acids and CKD for the sake of preservation of renal function. Why is it important? These days, as we pay more and more attention to CKD, it was found out that a lot of people live with this pathology. And according to the estimates, as of today, we have about 850 million people suffering from different renal dysfunctions. And we may say that 10-12% of the people globally have this or that degree of renal dysfunction. So this is a serious problem indeed. And if previously, about 15, 20 years ago, it was considered that today we'll have high-tech methods of renal substitutive therapy, and then they provide quality assistance and then transplant implant transplantation and dialysis had to be given to everyone. This was a consideration of the past, while today in renal pathology, the specialists are realizing that this is an unbearable load, not only for medicine, but also for healthcare system, but for the economies of the countries. And today the motto is attention to delay, to postpone the start of dialysis, because the later start of dialysis can dramatically change the quality of life of the patients. Many patients have to travel to other regions to be able to get the therapy, not saying of other types of therapy such as kidney transplantation, which unfortunately is not proportional in our country with the rate of transplantations in other countries. In this relation, I would like to suggest us to listen to the presentations of our international colleagues. Let's get started.
Добрый день, коллеги. Приветствую вас из Бухареста, Румынии. Меня зовут Лилиана Гаргате, и я являюсь профессором нефрологии в Университете Карла де Вилла медицины и фармации в Бухаресте.
Hello, colleagues. I would like to welcome you from Romania, Bucharest. I'm a professor at the Carlota Medical University of Bucharest, and I'm the head of the Department of Nephrology in Clinical Hospital of Romania, Bucharest. I'd like to welcome you and tell you about the analogs of amino acids in chronic kidney disease. This meeting is organized by Fresenius Kabi and I'm going to be a speaker at tonight's session. We're going to meet nephrologists from all over the world, and we will discuss the keto analogs in CKD. First of all, we will discuss the personalized approach to CKD, and we will talk about the new clinical guidelines of KDUQI, and Professor Angela Kong will tell us about it. Then we will give the floor to Professor Sahir Kalim, and he will talk about urea levels and carbamylation, benefits of low-protein diet. Then we'll talk about the possibilities to slow down the CKD progression, and we'll discuss the findings of a systemic review presented by Professor Pavina. And in the end, I'll have my own presentation on some ideas, and I will tell you how at late stages of CKD everything can be controlled. So we'll present you some data on patient management with diabetes and without diabetes, and then we'll go to the panel discussion. Allow me to introduce my colleagues. This is a group of experts, participants of our meeting. Professor Angela Wong from Hong Kong. She is the acting president of the International Society of Clinical Nutrition in kidney pathology. And she was also participating in developing key clinical guidelines. Then we have Professor Sahir Kalim with us. He's a therapist in Boston at the university at MIT, and he's in Massachusetts, and he's also lecturing professor in the medical school of Harvard. Professor Pawina from Thailand is a therapist of Memorial Hospital, King Chulalongkorn Memorial Hospital in Thailand. We would like to make this session as interactive as possible. So if you have questions, please do not hesitate to ask them. Below, you can see a special button that you can click and put down your question. The only request is please write down your questions in English, and of course all the questions will be anonymized. Every speaker will also have at least one question to the audience, and the results of the answers to these questions will be considered and discussed during our panel discussion. Let's get started. Let's start from the presentation by Professor Angela Wong, and she will tell us about personalized approach to patient management in CKD, and she will tell us about the guidelines. Thank you very much, Professor Galeata, for introducing me. I'll start my presentation from personalized approach to CKD and new guidelines, clinical guidelines that we got recently. As you know from the previous studies, the use of different cohorts of dialysis shows that in the first 6 months, we have the highest lethal outcome when the patients go on hemodialysis. We see that both CRIC and AASK cohorts show similar results. We see that the IGF goes down from 30 to 10, and of course it is associated with lethal outcome in the further follow-up. But also we see that the reduction of body weight mass as the patient switches to hemodialysis impacts the high figures of lethal outcome. And we know that patients with later stages of CKD in this or that way switches to dialysis. Some patients don't get dialysis at all, they are treated conservatively. Others come to hemodialysis at later stages. Normally they have concomitant pathology, so in this or that way it all impacts and the different timeline of switching to dialysis. Also we know that the patients are suffering from various stresses, and so these patients are metabolically unstable and they can be referred to dialysis at later stages of CKD with different outcomes. Metabolically stressed patients of course entail the risk of excessive protein production in urine of these patients. That's why when managing patients with CKD, we always set priorities for every patient, and we decide when and at which moments to switch the patient to dialysis. We do this so that the patients have an improved quality of life, have them less time at the dialysis, and have them better preserved kidney function. So we suggest to use incremental dialysis until the need to so we know that with temporary approach to the vessels, there is an overall inflammation in the system. Sodium is retained in the body more and more. It's very important, therefore, to adequately manage the status of the patient so that they don't waste the energy. More importantly, our actions need to help us to control better the uric symptoms and allow us to better manage the patients that are on a CKD therapy. We know very well that there are lots of contradictions that we find in different approaches in terms of timing of dialysis initiation. Nevertheless, we see that the non-dialysis management of the patient at late stages of CKD may have a very unambiguous outcome. So KD guidelines say that patients should be carefully selected and dialysis should be initiated carefully depending on the individual profile of the patient, according to the suggested strategy in order to improve the clinics of the patient, reduction, slowdown of CKD progression. If we see that there's an impact on vasodilatation of arterioles, and at the same time we see that this has a positive impact on the figures and hypertension control and glomerular hypertension, we see that intraglomerular pressure reduction reduces the impact on the signal pathways of the cells, and in its turn, it affects the slowdown of CKD progression. The clinical studies over the last 20 years, if we look at the Cochrane analysis results, we'll see that a low protein consumption level diet is very good for patients with late stages of CKD. And apparently, this is a more accurate decision than appointing a low protein or normalized protein diet. And if we look at the results of Professor Garniat's study, we'll see that when IGFR goes down for more than 70%, this gives us a significantly more higher number of patients to transfer to dialysis. There are some other obvious advantages of moving the patients to low protein and no protein diet. We see that many chemical parameters are significantly improving with low protein diet. Apparently, hypertension is better controlled. Accumulation of toxins in blood goes down because of metabolistic acidosis, and inflammation caused by oxidative stress goes down too. Many clinical data were considered when we were making KDOQI recommendations. These guidelines are now telling about patient management in CKD with no diabetes. A low protein diet means 0.55 to 0.60 gram per kilogram of weight, while the
И все это мы видим проводится для того, чтобы, опять же, снизить риски летальности и снизить...
While with additional ketoacidic, we need to meet the daily protein requirement of 0.55 to 0.60. Of course, it improves the quality of life of the patients. And on the other hand, the patients who suffer from diabetes and CKD, they are recommended to have the daily protein intake 0.6, 0.8 grams per kilo to maintain a stable nutritional status. So far, these are only opinions because evidence-based medicine hasn't provided enough evidence to support this. On the other hand, KDOQI recommends to administer to the patients 25-30 kilocalories per day. It all depends, of course, on age, sex, level of physical activity, body composition, weight, status, and CKD condition. Patients in a post-transplantation status also are subject to the relevant decision. As far as the administration or the onset of the low protein diet and strict low protein diet are concerned, we suggest to start from the step-by-step approach to this diet and to gradually move the patients to more strict low-fat diets, low-protein diets, including vegetarian ones. There are a few principles that we suggest to use in your clinical practice. I guess we need to stick to the multi-centered disciplinary approach in prescribing these diets. Of course, there's no size to fit all the patients, so we need to define the personalized goals and understand if there is a metabolistic stress, metabolic stress in that particular patient or not. We need to choose the patients who will benefit the most from these diets. And let's keep in mind that these patients should get enough calories to support the sufficient energy balance. We need to restrict the food choice for these patients, and they won't have much freedom in choosing food products. We need to restrict to 3 uncontrolled food intakes. I'd like to remind you the saying of Hippocrates, who said, "Let food be thy medicine and medicine be thy food." I think this is a very important message for us. We can do a lot for our patients in choosing a suitable diet for them to improve their life and health. So I would like to ask you a question. What dietary protein intake was recommended by KDOQI Nutrition Guidelines of 2020 for non-diabetic CKD subjects to reduce risk of ESKD and death? Please tick one of the right answers. And hereby, I would like to thank the company for their kind invitation to this meeting. Thank you very much, Professor Wong, for telling us about the importance of personalized management of the patients with late stages of CKD. And thank you for telling us once more about KDOQI clinical guidelines. And now I would like to give the floor to Professor Sahir Kalim. He will tell us about urea and protein carbamylation benefits and a level of them in urea. Good afternoon. Thank you very much, Professor Garniata, for the kind words of introduction. I will not repeat what has been reiterated to by the previous speaker, and I will switch to my presentation, urea and protein carbamylation, benefits of a low protein diet. In the coming 10 minutes, I'll try to explain, especially to the young specialists, what is carbamylation of proteins and how does it mechanistically associate with adverse clinical outcomes. This overview will be quite generic. In my presentation, I will show you as well the new data on the correlation between carbamylation process and CKD progression. In the end, we will treat the options of possible treatment, the role of low protein diet, and the role of keto analogs of amino acids. What is protein carbamylation? If you're not familiar with this concept, let's try to imagine this process as a post-translation protein modification, which is similar to glycation in case of diabetes. The only difference is instead of glucose, we have urea, the level of which significantly increases in case of kidney disease, and it leads to carbamylation speed increase. As CKD progresses in blood, urea level goes up because of the reduced level of excretion. It is balanced with cyanate, and this balance is in favor of urea. But when we have a distortion, it shifts towards cyanate, which is a very reactogenic ion. It might interact with M terminals or lateral parts of protein molecules, and below you can see the reactions that take place, and these processes are called carbamylation of protein. They modify the structure of protein, but keep in mind that this is not an enzyme process. So as a result, we get stable, irreversible transformations of protein structure. They change the function of protein too. In its turn, it leads to the development of molecular and cellular dysfunction. On this slide, you can see but a few examples, but it should be mentioned that this topic has been researched thoroughly. Overall, we have more than 200 articles on it. So we talk about a large scope of scientific material dedicated to protein carbamylation. On this slide, you can see a few examples of research. We see that carbamylation causes activation of mesangial cells. It can activate fibrosis, stimulate collagen, develop sensitivity, and in recent years we see more and more research between on the correlation between the initial speed of proteins and levels of kidney dysfunction. In our study, we tried to identify what is the correlation between carbamylation and the pre-dialysis CKD patients. This is one of the studies that will be published in the Medical Journal of Nephrology in the end of this year, by the end of this year. This is a CREEK study. It was a large study conducted in the US. A large cohort of the patients, over 3,000 subjects were enrolled, period of follow-up several years, during which we identified specific biomarkers of CKD progression, and the risks of cardiovascular diseases were identified. Out of this group, we randomly chose 75 patients who had glomerular infiltration speed reduction 55%, and they were moved to dialysis level. And we compared this group with a similar group that had the same level of glomerular infiltration speed and the same parameters, but they were not moved to, they didn't have any worsening of CKD. But I can tell you that between the two cohorts, we didn't have any differences except for the level of urea and prevalence of smoking. That was more in the group with CKD progression. As we can see in this table, in the group with CKD progression, the initial level of carbamylated albumin was higher in the group with CKD progression, which was transferred into the risk level because of the lack of the subjects in the group of CKD progression. We saw that the speed of protein carbamylation is irrespective of other parameters, was higher. Visual data are represented in the right part of the slide in form of terciles. We see that the highest speed of the protein carbamylation was detected in the patients with the higher level of CKD progression all the way to the terminal stage. The speed of carbamylation less than 5, only 30% of these patients achieved the stage of transplantation. But a question arises, what can we do with that? How can we change the speed of carbamylation of proteins and pursue the goal of improving clinical outcome? We remember that the level of urea is balanced with cyanate level, and these matters can be involved in the reaction with proteins, but we also know that it's a sequence of amino acids. And similar reactions can take place with free amino acids. In this table, which was generated based on an analysis of large number of patients on dialysis, we see that the speed of carbamylation correlates with high urea and low amino acids. At the same time, we have reverse correlation with the level of free amino acids of blood. And we thought, what if we reduce the level of urea in blood in parallel? We increase the concentration of free amino acids. This would reduce the carbamylation. We tested this hypothesis on the pilot study on dialysis patients who, between the dialysis sessions, got the solution of acids. And here you can see the blue curve shows the change of amino acids, and the red was control group. Endpoints were not analyzed, but we had the proof of our concept. Important results were also generated by our colleagues who showed similar changes at the pre-dialysis CKD patients. Patients with third, fourth stage of CKD. Patients were allowed to keep the normal diet in 3 months with further shift to VLPD plus Ka during 6 months and free diet or Mediterranean diet, whereas in other group we mainly changed the order of administering these diets. First they had Mediterranean, then they had very low protein diet plus keto. But I want to tell you about the general approach. It's interesting to look at the speed, changing speed of the protein carbamylation at the free diet. It is shown on the right graph. We see that the highest speed of carbamylation was with free diet. It was the lowest in Mediterranean diet, and it was even going lower with alpha and keto analogs of amino acids. And again, the endpoints haven't been analyzed in this study, but nevertheless, the concept on the possibility of reducing the carbamylation speed with strict, very low protein diet plus keto was confirmed. At the next stage, we're going to analyze the primary endpoints of the study. I'm briefly outlining the main things because of the lack of time, but I hope that I managed to confirm that protein carbamylation appears to be a consistent risk factor for adverse outcomes in both ESRD and pre-dialysis CKD with mechanistic underpinnings. Protein carbamylation is an independent predictor of CKD progression, irrespective of glomerular filtration speed or proteinuria. High urea, low amino acid levels correlate to carbamylation burden. And it's not surprising that very low protein diet in combination with keto analogs helps to increase the level of free amino acids and brings to the reduction of carbamylation in CKD patients. In the future, we are going to study correlation between modification of diet, clinical outcome, and carbamylation speed. And now let me ask you the following question. Carbamylation is a post-transnational protein modification associated with CKD progression and mortality. And the question is as follows. Promising intervention to help reduce carbamylation is A, blood urea reduction, B, amino acid supplementation by using keto analogs of amino acids, C, both A and B, D, neither A nor B. I'd like to give you some time to answer this question. And I will hope that most of you gave the right answer. This much from my side. Thank you for your attention. I'd like to thank my colleagues, sponsors, and if you have questions left, I'll take them with pleasure. Thank you so much for your attention. Thank you very much, Professor, for a very interesting lecture on the change in carbamylation and CKD progression.
как это вообще влияет на кровомелирование белка.
Thank you for telling us about this process. Now we have the next speaker. It's Professor Paulina Sisantikapong from Thailand. And she will tell us about how to slow down CKD progression. And the presentation is called "The Time is on Our Side."
Позвольте мне начать с того, что я поблагодарю комитет за то,
First of all, I would like to start by thanking the committee for the kind invitation to speak. Today, I will be speaking about the slowdown of CKD progression. Let me start from my presentation from questions to you. I'm curious to know what you think. Which markers listed below would most likely benefit from using restricted protein with Ka? Food, blood pressure, nutrition status, CKD, MBP, and renal function. If you don't mind, I'll show you the materials, the scope of my presentation. We'll first talk about the risk of high protein intake. Then we'll go to the evidence base of low protein diet and very low protein diet in patients with diabetes, non-diabetic patients, and mixed populations. In the end, I will draw conclusions of the low protein diets plus keto. Let's start from high protein diet. Here on this slide, you can see the survey of the patients with different levels of protein in their food, in their nutrition, and CKD correlation. If they had high level of protein intake, this potentially increased the risk of CKD. The patients who are at risk are the low carbohydrate and high protein diet, which confirms that the consumption of high level of protein develops the risks of CKD progression. This is the result we managed to derive when we saw the patients with low protein consumption. This in its turn helped to reduce the urea toxins, casyl sulfate, oxide, amino acids, phosphates, and acidic load and natrium. This slows down the CKD progression. On this slide, you can see the systemic effect of APF inhibitors and low protein diet, and also the conditions of kidneys and glomerular infiltration rate. Both of them help to prevent glomerular sclerosis of kidneys. We saw that high risk of protein intake means increased risk of CKD. Let's talk about the effect of low protein diet and very low protein diet on the patients with diabetes. On this slide, we see the results of prognostic meta-analysis of the patients with diabetes. The slide represents the value of MBD and low protein diet and very low protein diet in diabetic patients. This slide shows that in proteinuria and GFR, the administration of LPD and VLPD didn't give any positive effect. So we may say that therapeutic use of LPD and VLPD in the patients with diabetes haven't been proven. What about the patients with non-diabetes? Low protein diet. The table compares with a normal protein diet. There's no statistic difference between little outcome and absolute kidney failure of these patients. What can we say about very low protein diet and low protein diet? They are compared on this slide, and we explicitly see that VLPD reduces the risk of absolute CKD, and the risk coefficient will be 0.64. I think administration of a very low protein diet reduces the risk of absolute kidney failure with non-diabetes. Let's go to the discussion of a mixed cohort of the patients that includes patients with and without diabetes. You can see here that the low protein diet reduced the risk of developing absolute and relative CKD. Moreover, the low protein diet can change the GFR. On this slide, you can see that low protein diet can reduce the risk of proteinuria development. This is a mixed cohort of the patients with and without diabetes. On the left, you see that low protein diet can lead to the increase of the level of serum bicarbonates, serum phosphates, and it can lead to deficit of nitrogen. On the other hand, we can see that the very low protein diet intake was associated with greater integration and progression of CKD. So it's fair to say that low protein diet and very low protein diet can improve renal function and decrease the risks of CKD and ESRD in the mixed cohort of the patients. Let's talk about how KAA supplements and low protein diet can change the parameters of some biomarkers. On this slide, you can see the comparison of administration of keto KAs in comparison with LPD and VLPD. And we see that, for example, p-value and GFR are improving. And we can really say that we see that the LPD with Ka reduces the IGFR, SBP, and DBP. As for subgroup of analysis of very low protein diet with Ka and its comparison versus LPD, with the diet, we are improving the EGFR values, SBP, DBP, serum albumin, serum calcium, serum phosphate. The patients enrolled in the study got KAs during 6 months and above. And on this slide, you can see that the effect of KAs, Ka analogs, is proportional in this group. It shows lower figures of EGFR and some others like VP and MBP. And in comparison with the control group, it shows significant improvement. We can say that the effects of Ka supplements restrict protein diet they improve the blood pressure, albumin, phosphate, and it increases the calcium serum if the patients take the Ka analogs for more than 6 months. And it can improve the renal function as well. In the end, I want to say that excessive protein consumption increased the risk of CKD. Ka supplements seem to have more benefits on BP, nutrition, CKD, MBD parameters, and renal dysfunction. However, the compliance with protocol is still challenging for clinical practice. However, I should say that the strict compliance to the protocol is not so easily achievable in clinical practice. If the patient can't follow a low-protein diet, we need to recommend the treatment from that. It's important to stop the progression of CKD into absolute kidney failure. I'd like to close my presentation and thank you again for your kind invitation to speak. I'd like to ask the audience to ask your questions if you have any. Thank you so much, Professor Paulina Sisantipong. We know how important it is to use low protein to control the progression of CKD. Many analyses and meta-analysis and results can be found in publications. And now let's go to the final presentation of our session, and I will present it myself. Well, what can we say about the advanced stages of CKD? We are trying to keep everything under control with these patients. And now I will tell you about the results of the follow-up of our patients with diabetes and without diabetes who have CKD. There are several difficulties that we are facing. The first thing is the diabetic kidney disease. The recent study recommends to administer vegetarian severe hypoproteic diet supplemented with keto analogs. And indeed, patients with DKD who are on vegetarian diet are followed up broadly, but we don't have the results of these studies yet. The changes of diets in CKD have been researched in different studies, and it increases, and the results are conflicting, so it increases our interest to the low-protein diet. And we are following up the patients for a long time, and the survival rate of this group is not high yet. So the first challenge. TBD. One of the first studies, randomized control studies, that was presented by Professor Teplan, compared the low-protein diet with keto analogs. It's the curve in dark. It was controlled with a control group, and it is apparent that the patients who got the keto analogs of amino acids have much better kidney function, and it is preserved throughout the study. If we look at the speed of deterioration of kidney function, we'll see that it was much slower in the patients who had very low protein diet. Within the framework of the group of researchers, we were trying to see how strict low protein diet plus keto analogs together can improve the outcome for the CKD patients, especially at later stages. And this is how the design of the study looks. We had a phase, patient enrollment, when all the patients were assessed and thoroughly qualified, and they were moved to low protein diet. And then we moved the patients to low protein diet when the norm of protein was 0.6 grams per kilo of body mass, plus keto analogs, and the results showed a significant reduction of proteinuria, 3.5 of urea creatinine, which is a really good result indeed. What can we say about kidney function? We see that before enrollment in the study, the patients were at the normal protein diet, and then they switched to the low protein diet, and they significantly improved their parameters. What can we say about hypertension control? The mean arterial pressure during the study didn't go up significantly in these patients. What can we say about the ratio between the low-protein diet and the capacity to control hypertension in these patients? In the sub-analysis of the data, we have discovered that the lower mean arterial pressure is normally associated with low consumption of protein. Then you can see the red curve indicating the mean arterial pressure. The black curve is sodium extraction with urine, and the gray bar is diuretics. The light gray bar is prescription of enzymes. And we see that the figures of arterial hypertension are changing along the follow-up timeline. Sodium extraction too. And again, we see that with low-protein diet, we have less frequent administration of inhibitors of angiotensin system. So here is the second challenge. Can we really keep the patients on this diet, this strict diet for a long time? Another question that worries us even more is what is their long-term outcome? What will give us this very low protein diet and low protein diet? Will it be a benefit for a longer term? Patients who were on the vegetarian very low protein diet were also researched in the study, and we compared this group of patients with a control group, the patients on the normal protein diet. And we see that the patients on vegetarian strict low protein diet had a better SVPLD status, and patients on vegetarian VLPD diet were later moving to dialysis than the patients who didn't have this diet. So here is my question. What do you think is the percentage of patients who are adherent to the SVLPD? Less than 10, 10 to 20, 20 to 50, and above 50%? This is the first question. And now, what can we say about the general results of our follow-up? 200 patients have been enrolled in the study, and we see that 101 patients had SVLPD, and 99% were on a low-protein diet. I understand that the scheme may seem complicated. Nevertheless, 104 patients from SVLPD group were followed up throughout 2009, and we see that 84% of the patient subjects from this group were still alive, whereas in comparison with the LPD group, survival figures there in that second group were much lower. It's important to say that the mean follow-up time was in the group of SVLPD was 129 months, and in comparison with 114 months in the LPD group. I want to say again that the patients were voluntarily following a uniform diet and a uniform monitoring principle. These were the subjects enrolled in our randomized control trial. So approximate survival of these patients is much higher in the group with SVLPD in comparison with LPD group. One more question to you. What do you think are the factors to influence most the survival in patients on SVLPD? Age, gender, modality of RRT, type of nutritional intervention, or index comorbidity score by Davis. I'll skip this slide because it shows the correct answer. Let's take a look at the renal function. Dialysis was indicated to 93% of the patients in the group of LPD, compared with 51% of the patients who were taking SVLPD. At the moment of control, not all the patients were moved to dialysis, and we see that these results have also been supported by another article of our Italian colleagues. They included in their experiment 200 patients. The important thing to say is the lion's share of these patients was above 70 years old. This Italian group in the end of follow-up showed that 40% of the patients were on dialysis, 9% on a low-protein diet, and 8% were still getting conservative treatment, and a small percentage of the patients died, 1%. Italian group shows that there were patients who followed the diet during 7 years. As for our biggest challenges when we move the patients to SVLPD plus keto, we should do it for the reduction of proteinuria, better blood pressure control, and improved EGFR. And in the long term, we improve the quality of life of these patients. From our experience, we can say, and it is confirmed by the study of our Italian colleagues, that the patients on the low-protein diets show better survival and better patency of renal function. I won't mention again the Cinderella guidelines. This is a well-illustrated picture when Cinderella is doing the whole job and her sisters are just telling her what to do. I'm not going to talk about it in the future, no more about Cinderella guidelines. I'd rather use the picture of this flower to highlight that the fact that we have new guidelines in treating the patients with late CKD stages is a result of teamwork. Thank you so much for your attention. And we're now moving to the discussion with our experts. All the experts are online. Thank you very much. For participation in this meeting. Let's thank you very much for taking part, and let's start from the answers to your questions. Let's start from Professor Angela's question. What are the answers to your interactive question? So, thank you very much to the colleagues for their participation and responses. Let me remind you that the question was, what protein intake is recommended by GDOC guidelines for non-diabetic CKD to reduce risk of ESKD? Unfortunately, I can't see very well the responses. Well, it looks like the majority of responders chose the last option. And the first two options got 20% of answers each. Yes, indeed. 0.28 to 0.43 grams of proteins per day per body weight plus keto supplements, or 0.55 to 0.60 grams of protein per kilo of weight. Second option of response is an example of low protein diet. The recent study shows an absolutely positive effect of low protein diet. It significantly reduces lethal outcomes with CKD. We have evidence based to prove this theory. This diet improves the quality of life of our patients. What can we say about 0.25 to 0.35 grams per kilo? This diet requires Ka supplements to maintain the nutritive status. Thank you very much, Professor Wong. And now we go to the next question of Professor Sahih Khalid. Can you please comment on the answer to your questions? Well, we were asking you about potential interventions. What are the interventions that can help to reduce carbamylation that has a negative effect on the course of CKD? And the majority chose C response, which in fact included both points, A and B. The reduction of urea and plus amino acids. Yes, this is the correct answer indeed. We know that carbamylation process, especially in CKD context, are associated with urea level. Urea is the metabolite that is binded with proteins and leads to carbamylation. In this way, this leads to negative effects. But also, urea can either be binded with proteins or with free circulating amino acids. And at eCKD, in this way, we have a deficit of the free circulating amino acids. It is also associated with renal failure. If we could normalize the balance between urea cyanate and free circulating amino acids, this would help us to reduce the progression of CKD and reduce the level of amino acids. In this case, the analogs of keto amino acids keto supplements can be of help. Thank you very much, Professor. And let's continue and go to the question of Paulina Isisantipong. Well, I can see the results, and I absolutely agree with the response that we got. Indeed, it significantly improves the renal function, and this is that very function that we're trying to preserve in our patients, especially with the late stage of CKD that they have. Of course, it's fair to say that the use of keto analogs and amino acids also has a positive impact on arterial pressure, nutritive status, and bone failures. Thank you, Paulina. And my question to the audience, the first question that I asked was this: what percentage of patients do you consider to have proved adherent to a CVLPD? I don't think you have been reading the publication of randomized control study that I mean here, but I'm really happy to see your responses. The majority of the audience, about 40%, believe that 10 to 20% of our patients will indeed be capable of following and maintaining SVLPD. At the moment of enrollment in our study, back then, we selected 200 patients, and only 14% out of them could strictly follow could follow the SVLPD. And we included in this study both subjects from Asia and from Europe, and a similar percentage of compliance was observed in these patients, in all of them. Less than 10%. We have never seen less than 10% in the patient cohort. But again, I think it all depends on the local nutrition habits of our patients. Some of our participants are very optimistic. They believe that more than 50% of the patients will be compliant and they will follow SVLPD. But I think that you are of a too high opinion about our patients. Well, I had one more question for our audience. Which factors could influence the most the survival advantage in patients on SVLPD? Well, I see that indeed advantages in terms of survival for the patients on SVLPD. Here we included various models in our study, and we included different parameters, and our data showed that indeed not only the type of nutritive support and administration of SVLPD had a positive impact on the overall survival of our patients. So I am happy to see the correct response of the audience. Thank you very much. And now I think we can go to the Q&A session. And first of all, we have a question to Professor Wong. It's a question from India. What do you think? What is the most important factor for the patient in postponing or late administration of dialysis? Thank you very much, Liliana, for your question, and thank you to the audience for the question from India. I think that this is not an easy question at all. Apparently, we have lots of aspects of this kind that matter a lot, and they help us to postpone the onset of dialysis. From the perspective of the patient, we understand that dialysis is probably that very factor can transform the condition and quality of life of the patient significantly. So we believe that indeed the change of diet matters a lot to control CKD. And not only diet, of course, a lot of components help us to significantly postpone the onset of dialysis. We know that patients with CKD are having active and massive accumulation of blood metabolite products in blood and in urine. So we need to set the mode of our patients and tell them that it's in their hands. And diet is something that can help them to improve their health. A low level of phosphates, a low level of protein diet is very important for them. In this way, we make this diet part of a healthy component of their life. And perhaps I would start from that approach first of all. That's the most important thing for our patients. When they feel empowered to impact the progression of CKD. Thank you very much. The next question is from Zimbabwe for Professor Sahir Kaleb. Tests to define carbamylated protein. What test would you recommend to CKD patients? Thank you so much for this question, and I would like to welcome our colleagues from Zimbabwe. How can I briefly respond to this question? In fact, the purpose of our study was to show the relevance of tests. Unfortunately, they are not available in clinical practice, and they are on the level of experiments. Of course, some of them are ongoing at the moment, But I want to say that if you look at the speed of protein carbamylation, we'll get more and more information thanks to conducted clinical studies. I do urge you not to lose your interest to this topic. You can keep watching our studies and their progress. So far, we don't know the answer to this question yet. And the next question we got from Indonesia, a question to Professor Paulina Sisantipong. Which parameter
МКН, ХБП, артериальное давление, нутритивный статус, и фильтрационная функция почек были бы
IGF, nutritive status, etc., which part of your presentation can be controlled the most by the patient? Thank you very much for this question. I think that independent control is very important for our patients. The most important thing, perhaps, is to preserve the filtration, kidney filtration function. And our patients should probably try to improve overall nutrition, not to suffer from malnutrition. And as we know, there has been collected enough evidence to support the low protein diet and VLDP. They significantly improve the nutritive status of the patient and they slow down the CKD progression. Also, keto and amino acids are very favorable to control these parameters and they slow down CKD progression too. Thank you so much, Paulina. Colleagues from Russia are asking me, what can I recommend to the patients with CKD so that they could stay as long as possible on the VLD and LPD and VLPD. Several things to mention here. First of all, the patient should analyze his nutrition habits and probably make the first choice of the acceptable food products. What matters a lot is to educate the patients. The patients should undergo special trainings to be able to clearly understand why it's important to restrict their protein consumption and why it's important to get keto and amino acids. It's very important for the members of the family to have a clear idea of this relevance of the low protein diet, and the friends as well. They need to respect it. We know that all our patients live in the society and very often they are prone to the opinions around. So it's important for a patient to be interested in the result, and because that will help him to follow the diet so that the patient feels that he's feeling better, so that the lab tests show that the figures are improving. In this way, dialysis can be started later. And indeed, I think for the patients, it's a very important thing. And it will retain the patient within these strict low protein diets. Thank you for your questions. Do we have more questions? If there are no more questions, then I would like to wrap up our session today. Thank you so much to all the speakers for dedicating their time. And thank you so much for taking part in our online symposium. Thank you very much to the audience for joining us at this hour, and many thanks for the wonderful meeting. Thank you and bye-bye. Well, dear colleagues, We have listened to 4 wonderful presentations. And once again, I made sure that brevity is the sister of talent, because in fact, the specialists have briefly outlined the problems and challenges related to the diets of CKD patients and the way the diet can slow down the progression of the disease and can delay the onset of dialysis. Professor Angela Wong, if I am to briefly describe the speakers, presented the most recent guidelines that were published in 2020, Kidoki and nutrition for the patients with CKD. And they, of course, are highlighting tailor-made approach to these patients and their management. And for the first time, there have been presented the guidelines regarding the very low protein diet plus keto. I'd like to mention 2 really important things here, 2 things to clarify. Number 1, there are 2 versions of the diet. First one is 0.55.6 grams of protein per kilo of weight. It's an LPD, and second one is tougher. It requires active work with the patient to specify all the details to him. Very low consumption of protein, 0.28, 0.43 grams per kilo of weight, plus keto, in particular castosyl. These are the guidelines, and this is the only original drug, by the way, the only keto drug, and all the studies were conducted with it. And a very low protein diet plus keto has advantages in nephroprotection, slowdown of progression, and something that wasn't mentioned here, this diet allows to also reduce the expression of metabolistic acidosis. It's a big challenge for CKD patients. One more thing to draw your attention to: the patients with diabetes and DKD, this tough of a diet is not recommended. The diet there should be 0.6-0.8 grams per kilo of weight, although I will later speak about the specifics presented by Professor Liliana. It was very interesting to listen to Professor Zahir Kalim from University of Harvard regarding protein carbamylation. Hemodynamics problem shows that urea causes hyperfiltration just like high protein diet does. And as we see, adding keto analogs of amino acids help to reduce carbamylation of proteins, and in this way to achieve cardiac and nephroprotection. There was a very interesting presentation from Professor Paulina from Thailand. She talked about meta-analysis, and she talked about the results of clinical studies and showed that keto analogs allow to, together with APF inhibitors and sartans, to achieve a better and positive result. And of course, Professor Liliana Garniata, we know her very well from Romania. She has a lot of works on low protein diet and diet in general for CKD patients. So she was talking about a large clinical study. I'd say this study, after the largest MDRD, everybody knows so well, it is one of the largest studies, longest studies, randomized control clinical studies, and this allowed and it managed to illustrate that this approach, restriction of protein consumption plus keto, ensures 5 times reduction of the need in dialysis. It's so relevant. The 4-fold reduction of 5-year mortality in CKD patients, and this is in comparison with standard protein diet. I'd like to draw your attention to something else. This diet helps to significantly reduce albuminuria, proteinuria, which is a marker of the intraglomerular hypertension we were talking about. And once again, it slightly goes beyond the framework of guidelines, but Professor Garniata showed that the patients with diabetic kidney disease at later stages with reduced glomerular filtration below 20 ml per minute, this diet with restricted protein consumption, very low protein consumption plus keto, helped to stop the process even at this very low level of glomerular infiltration. So in my opinion, we got very interesting data. I hope that the audience will use it in their practice, daily work. And if there are questions, we have several minutes.
Вопросы у меня почему-то в чате не появились они. Мне прислали коллеги, я сейчас зачитаю.
Well, I have questions in chat that I'm going to read out now. The question is, what kind of keto analogs do you use and what are your preferences of keto analogs? It's a question from Dr. Khokhlova, Lyudmila Khokhlova. I want to say immediately that all the clinical studies were conducted by using ketosteril. All the other analogs of ketosteril were not studied in controlled trials, so naturally, in my opinion, the response is obvious. Moreover, this drug is supplied free of charge to the patients who need it. Besides, the ketosteril production in Moscow has been set in Russia.
С какой скорости клубочковой фильтрации надо начинать?
What is the glomerular infiltration speed at which we need to start the very low diet plus ketosteril? It's a very good and important question. I always get angry when a patient who has protein traces and suddenly he's appointed ketosteril. I don't know what's the purpose. Ketosteril with restriction of protein consumption is recommended to administer in chronic kidney disease stage 3B, less than 45 ml per minute. And here I want to specifically highlight that if a low protein diet plus keto are administered, the total sum consumption of protein plus keto together should be 0.55, 0.6, not more. In that case, you can yield an effect. That's a question from Lyudmila Mikhailovna Yaskina. Well, as you can see, Professor Gandriata showed that there's a more profound effect when we have lower figures, 20 and below. So, if there are no more questions, I think this is it. I have no more questions. And yes, it's important to say that in the instruction it's written that in case glomerular infiltration speed is less than 20 ml per minute, Ketostriol is appointed then. But this is an outdated recommendation, and after the clinical guidelines on CKD were published, the recent ones, they lifted the threshold to 30 ml per minute. So if there are no more questions, dear friends, thank you so much. I do hope that it was a pleasure for you to listen to this session. Thank you very much. Dear colleagues, good afternoon. We go back live. We'll have a short break, 6-minute break, and after that we'll go to the final part of our conference, to the final series of symposia. Let me announce them. In Moscow Hall, we'll have the symposium of the Armenian Association of Therapists, and this symposium will dwell upon very important aspects on patient management for the patients with diabetes and osteoporosis. It will be expanded at this session, and the data will be provided in a broader way. There will be questions on cognitive violations, dementia, and progression of cognitive functions. And we will have an overview of important guidelines, oncology and COVID-19, what to do with the patients. In St. Petersburg Hall, we'll have a symposium on the extreme emergency medical aid working with COVID-19. All the speakers will share their experience on what to do. It will be interesting to our emergency care colleagues and those who provide resuscitation. And of course, we will speak about CT service, clinical picture of skin manifestations as a method of early diagnostics. In Perm Hall, we'll speak about brand new approaches in the diagnostics of cardiovascular disease. Well, cardiovascular diseases are the red line.
Встречаемость сердечно-сосудистых заболеваний доминирует над другими. И здесь очень важный момент. Что нового мы скажем? Мы коснемся вопроса СМАДа в оценке антигипертензивной терапии, дипер, нон-дипер, найт-пикер. Мы сталкиваемся с огромным числом вопросов в этой области. Будет совершенно уникальная лекция профессора Калинкина, посвященная сну. Я думаю, она будет интересна абсолютно всем слушателям, потому что мы будем говорить о методах нарушения дыхания во время сна, слип-апноэ, ранняя диагностика. Профессор Калинкин является лидером в вопросах анализа сна пациентов. И, наконец, будет вопрос, посвященный применению нестероидных противовоспалительных средств у пациентов с сердечной недостаточностью. Ведь мы должны задумываться о вовлечении функции почки в патологический процесс. Ну а на перерыв нам осталось всего 4 минуты. Увидимся через 4 минуты. Не отключайтесь. Уважаемые коллеги, мы возвращаемся в эфир для заключительной сессии симпозиумов.
Dear colleagues, welcome back. This is the final breakout sessions of our symposium here in Moscow, internal medicine, osteoporosis, diabetes mellitus, and COVID-19. A cancer patient with COVID-19 in St. Petersburg, the issues of emergency care, CT in conditions of pandemics, and of course, providing care at home. In PERM, SMART, the new diagnostics of hypertension, insomnia, an unprecedented presentation, and the presentation devoted to the administration of NSAIDs to patients with heart failure. Let's get down to our respective agendas, and I'd like to give the floor to the first presenter, to Professor Hamlet Ayrapetyyan from Yerevan, chronic heart failure and comorbid pathologies. Please, the floor is yours. Good afternoon, colleagues. On behalf of the Association of Cardiologists of Armenia, I'd like to welcome all the participants. I'd like to thank the organizers for the opportunity to speak in this respectful audience. The theme of my presentation is chronic heart failure and comorbidities. Chronic heart failure, as you know, is not just a medical problem, but also a social one. And it's a relevant issue. We have 21 million patients who suffer from heart failure. And of course, the financial burden for the government is very significant. In 2012, the burden was worth of $108 billion. The mortality rate is shown here. 50% of patients with heart failure die within the first 5 years after the diagnosis. Patients at the age of 65 and older usually have the main reason for hospitalization from heart failure. Most patients with heart failure have 3 or more concomitant diseases. Here you can see such diseases such as COPD, cardiovascular pathology, renal insufficiency, poor metabolism, neoplasm, etc. Comorbidities can have an impact on treatment of heart failure. That's the first thing. Second, drugs which are administered to treat comorbidities can worsen heart failure. There might be a drug-drug interaction. Many comorbidities also have poor outcome. Here you can see the updated ESC guidelines for management of patients with heart failure and different comorbidities. As it has already been mentioned, comorbidities worsen the diagnostics, worsen the quality of life, increase the risk of hospitalization and death in patients with heart failure. Right now, targeted therapy is being developed for specific comorbidities, but there are drawbacks in terms of lack of sufficient evidence. The evidence is not quite well. Many comorbidities are excluded from many multi-center randomized trials. Comorbidities worsen the symptoms and the quality of life. Comorbidities increase the risk of rehospitalization and have a negative impact on treatment of heart failure. For example, if ACE inhibitors are administered, they are not indicated in case of asthma or in case of renal insufficiency. COPD can lead to shortness of breath. Drugs administered to treating comorbidities can worsen the course of heart failure. For example, anti-tumor drugs or NSAIDs. Drug-drug interaction can lead to lower safety and efficacy, an increase in the number of adverse events. For example, beta blockers to treat the heart failure in patients with have REF or beta agonists to treat COPD or asthma. As it has already been mentioned, comorbidities worsen the quality of life in patients with heart failure. This slide shows the data from the Swedish Registry on Heart Failure. You can see that the manifestation of symptoms and limitations are on the rise in people with comorbidities as compared to people without comorbidities. Let's touch upon two comorbidities, such as diabetes mellitus. It's the first one. We know that the course of cardiovascular diseases is worsened in patients with diabetes type 2. Many studies have shown that the risk of death, overall mortality and cardiovascular death in patients with heart failure and diabetes mellitus is twice as much as compared to patients with heart failure without diabetes mellitus type 2. Diabetes mellitus is an independent risk factor for hospitalization of patients with heart failure. This slide shows the multi-center randomized paradigm trial. And here you can see that the risk of death and hospitalization for heart failure in such patients, it depends on the glycemic status. The higher the level of glycemia in a patient, the worse the prognosis is, the higher the risk of hospitalization, and the higher the risk of death. Here you can see the guidelines for treatment of heart failure in patients with diabetes mellitus. These are ESC recommendations, and you can see that all classes of drugs used to treat heart failure with the reduced ejection fraction are also used to treat diabetes mellitus with the same level of evidence. For example, ACA inhibitors, beta blockers, ICD, CRT, CRTD. Well, all these drugs are indicated for patients with diabetes mellitus. You can see the level of evidence is mostly 1A, as for drugs shown here. Well, you can see it's 1B level. And I'd like to talk about the new group of anti-diabetic drugs, that's SGLT2 inhibitors. And sodium glucose transporter 2 and SGLT2 leads to control of glucosuria, natriuresis, osmotic diuresis. SGLT2 inhibitors lower the level of the volume of circulating blood, but they also have the pleiotropic effect, and through that they can have a positive impact on remodeling of the left ventricle and hence the positive prognosis in terms of hospitalization, death, and the outcome. A number of studies conducted recently have shown that SGLT drug 2 inhibitors, empagliflozin, dapagliflozin, and others reduce the risk of rehospitalization for heart failure, reduce cardiovascular death, and overall mortality. Combined endpoints were much better in patients with diabetes mellitus type 2 and heart failure when these drugs were inhibited as compared to without the administration of SGLT2 inhibitors. Here you can see the guidelines for treatment. Well, SGLT2 inhibitors are the drugs of choice to treat diabetes mellitus type 2 in patients with heart failure in order to reduce the risk of hospitalization for heart failure class 1A. Moreover, at the recent European Congress of Cardiologists, the results were presented 2 months ago of DAPA-HF study, which indicated that SGLT2 inhibitors have a positive effect on the outcome of the disease in patients with heart failure, regardless of the presence of diabetes mellitus type 2. So SGLT2 inhibitors are not just anti-glycemic drugs, they can also be used for treatment of chronic heart failure, regardless of the presence of diabetes mellitus type 2. This slide shows the famous algorithm which was developed in 2016 when the guidelines were updated on the treatment of chronic heart failure. You can see all the classes of drugs used to treat heart failure with reduced ejection fraction. Well, but we think that next year, when updated guidelines on treatment of heart failure are published in 2021, I assume, and that's not just my assumption, next guidelines will include SGLT2 inhibitors, and I think SGLT2 inhibitors will be recommended for treatment of heart failure regardless of diabetes mellitus at all stages of therapy. Well, we will see at the next Congress. I'm sure there will be changes like this. As for insulin, insulin can be administered to patients with improved diastolic function. Insulin can increase the risk of death and hospitalization in patients with heart failure. You can see the results of the 4 studies. When patients were switched over to insulin, they had a higher risk of rehospitalization by 23% and overall mortality by 32% if patients had heart failure. Now let me say a few words about chronic kidney disease, CKD. In this case, the systolic function is reduced, and this leads to renal hyperperfusion, vasoconstriction, and tubular hypoxia, i.e. necrosis, and that's a vicious circle formed here. Well, CKD can be diagnosed on the basis of structural or functional impairment, or when eGFR is less than 60 milliliters per minute within 3 or 4 months, regardless of the nature. Here you can see the CKD classification, the staging of CKD depending on glomerular filtration rate. Patients with chronic kidney disease usually have a higher cardiovascular risk. The worsening of the renal function correlates with an increase of cardiovascular risk regardless of the standard risk factors. When eGFR is 45 to 59, well, the risk is higher by 30%. When it's less than 15, the risk is higher by 43%. The patients with CKD on hemodialysis, the cardiovascular death amounts to 52%. How does CKD affect the heart function and myocardial function. First of all, overload with pressure, overload with volume, and factors related to CKD, which do not have the hemodynamic effect. Patients with chronic heart failure has the higher risk of death. If the creatinine clearance is less than 30, the risk of death is 2.5 times higher. When creatinine clearance is 30 to 60, well, the risk of death is 1.57 times higher as compared to the normal creatinine levels. As for the treatment, well, the proper diet is recommended. Well, less calories, less liquids, less protein, less salt, less fats. As for medical treatment, well, renin-angiotensin testosterone inhibitors can be used with care in this disease, well, especially when there is aortal valve stenosis, well, and the creatinine is higher than 2.5 milligrams per deciliter. In case of hypoglycemia, 5.5 millimoles per liter, only half of the dose of ACE inhibitors will be administered, and the drug even can be cancelled. Well, as for other groups of patients, well, again, you can see that anemia control is of great importance, especially when we're talking about administration of erythropoietin and iron-containing drugs. Also, dialysis or ultrafiltration or inotropic drugs can be used. Thank you very much for your kind attention. Distinguished colleagues, let's move on. Please switch off the camera. We have limited time. We must move on. The next presenter is Yelena Agajanova. Today, we've had several presentations on diabetes mellitus, and there was a presentation on the problems of osteoporosis. Professor Agajanova will try to combine these two global problems into one presentation. In one patient, we understand it perfectly well that due to modern treatment regimens, patients with diabetes mellitus are getting older. There are more chances of osteoporosis, so we must be ready for this combination, for this kind of comorbidity. Professor Agajanova, the floor is yours. Good afternoon, distinguished colleagues. I'd like to welcome all of you here from Armenia right now. We have a difficult situation, but we will cope with it. And thank you for letting me speak online. Well, what's the link between these two serious metabolic diseases, such as diabetes mellitus and osteoporosis? Let me just make it full screen. These two diseases usually affect people over 50 in most cases. Both diseases are now epidemics. You can see the data of the number of adults with diabetes mellitus type 2, and we think that in reality the number should be multiplied by 2, and by 2030 there will be more than 700 million patients. As for osteoporosis, well, I should say that we have a lot of patients with osteoporotic fractures, more than 200 million. But we know that as for fractures and the number of new cases in countries where normal statistics are done exceeds the number of strokes, MIs, COPD, and also the most widespread cancers such as breast cancer and prostate cancer. While the density of the bone changes with age, the peak is by 30 years. Well, you can see that the bone is being remodeled. First of the mass is growing up to 20-25 years, then the process of stabilization of the bone, and then starting from 30 or 40 years of age, physiologically, the mineral density is becoming less. And as for the mineral exchange process and bone remodeling, they are characterized by different systemic factors. Factors stimulating the growth and cell differentiation, the synthesis of the bone matrix are such hormones as insulin, insulin-like growth factor, somatotropic hormone, androgens, estrogens, and of course vitamin D, and vice versa. Resorption is caused by rancor, well, prostaglandins, some cytokines, interleukin 1, 6, tumor necrosis factor, which produce rank ligands. Rank ligands stimulate the formation of ripe osteoclasts, which stimulates the process of bone resorption. The bone mass index is reduced, and there should be a balance between rank ligands and also the protein or osteoproteogerin, OPG. And you can see that in this case, if there is a link with rank ligand, there is the prevention of this process. There are data showing that the level of OPG in blood serum increases with patients with diabetes. And here you can see some data that the increased release of OPG in the blood serum is one of the characteristics of the early onset of diabetes. Increased OPG level can also be the response on bone resorption. The main determinant of osteoporosis is the peak of the bone mass and the speed of the reduction of the bone density. You can see also risk factors of osteoporosis, age and sex, hormonal factors, body constitution, heredity, physical activity, which is low in this case, poor diet, smoking and alcohol, and of course, hormonal factors contributing to the development of secondary osteoporosis. Here you can see that there might be endocrine diseases such as diabetes mellitus, which can contribute to the development of osteoporosis. The boundary between primary and secondary osteoporosis is not absolute. The disease causing secondary osteoporosis provokes primary osteoporosis and vice versa when there is the early stage of primary osteoporosis. When there is the emergence of the disease triggering secondary osteoporosis, it starts earlier and it is more severe. In case of diabetes mellitus, there might be different bone damages, such as diabetic osteoarthropathy, renal osteopathy, and osteoporosis, which as of today is considered by most experts as the underestimated complication of diabetes mellitus. The share of osteoporosis in case of diabetes mellitus in such patients can be from 6 to 10%. Naturally, first and foremost, this is linked to the diabetes mellitus impact on the lack of insulin effect. How does insulin affect the bone metabolism? It stimulates the synthesis of bone matrix and the cartilage. It has an impact on osteoblasts and on the increase in the number of collagen producing cells. Insulin also leads to the production of osteoblasts, and through the insulin receptor type 1 and 2 can stimulate the matrix, and due to the stimulation of the synthesis of protein, collagen hyaluron will be synthesized, as well as increasing the absorption of calcium in the stomach, hence more osteoblasts. Here you can see different pathogenetic mechanisms described in case of osteoporosis pathogenesis, but of course insulin deficiency is of paramount importance. A lack of anabolic effect of insulin due to low collagen synthesis and alkaline phosphatase, chronic hypoglycemia leads to change in metabolism, and this has an impact on bones. Hypoglycemia contributes to osmotic diuresis. It is accompanied by hypercalcemia, hydrophosphaturia, and leads to hypocalcemia. The number of active metabolites of vitamin D drops. Also, the absorption of calcium by the stomach drops, and as a result of it, there are more PTT, which stimulates osteoclasts, and there are data showing that the mineral bone density is being reduced in this case, and there will be a drop in the bone mass. As for hyperglycemia, regardless of the genesis, will change due to interleukin-6 production, which stimulates the bone resorption. Several studies were conducted, and the question was, is it possible that glycated hemoglobin could be a risk marker for the development of fractures? But at the same time, observational studies did not show this link between fractures and glycated hemoglobin. As for bone tissue density, other factors impact on it. And as for diabetes type 1, well, different polymorphism genes were associated with the lower bone marrow density. Also, the studies have shown that polymorphism of the vitamin D receptor has an impact on the mineral bone density. Different studies have shown that a shortage of vitamin D often occurs in patients with diabetes than in the population of the whole. And there were several mechanisms defined of the shortage of vitamin D. First of all, genetic predisposition. First, we're talking about diabetes mellitus type 1, increased BMI, that's typical for diabetes mellitus type 2, also concomitant albuminuria, the high excretion by kidneys of vitamin D in case of both types of diabetes. There are also studies saying that the BNT signals are using the signaling paths, and that's very important for the bone resorption. The induction of VNT signals, if it's proper, leads to the formation of the bone. If it doesn't happen, it leads to osteoporosis. And there was a missense mutation described to the low density lipoproteins, as you can see it here, and also that led to the development of osteoporosis in patients with diabetes mellitus and in patients with coronary diseases. In case of diabetes mellitus without fractures, mineral bone density will change, and again, there is a normal micro architectonics of bones. Bones are prone to fractures. It's due to the shortage of insulin, especially in teenagers, and there might be the lower peak bone mass data. Well, this also happens when diabetes mellitus begins to develop. In case of other autoimmune diseases, such as autoimmune hypothyroidism, this may be an additional risk factor of osteoporosis development. It's secondary osteoporosis, and there is a higher risk of fractures in diabetes mellitus type 2. But in case of adequate glycemia compensation, the reduced mineral bone density does not lead to fractures. As for diabetes type 2, patients with obesity usually have a higher pressure on bones. This might lead to hyperinsulinemia, well, and this strengthens the bone formation, as you can see it here, and there may be a concentration of sex steroid bound binding globulin. The studies have shown that the risk of fractures increases with the longer duration of diabetes. Well, there is a link between diabetes and hip fracture, both in men and women. Patients with diabetes type 2 had a higher risk of low energy fractures, especially hip fractures, as compared to patients without diabetes. And diabetes mellitus type 2 doesn't reduce the mineral bone density, but the quality of bones has a higher level of fractures. As for a link between obesity and body mass index, most patients with diabetes type 2 have obesity. BMI is also an important predictor of mineral bone index. A low BMI is linked to the higher development of osteoporosis and vice versa. If it's higher, then there might be other factors involved, such as insulins, estrogens, etc. Recently, the GLOW data were published, and this study showed that there is a risk between fractures, height, and weight, depending on the localization of the fracture. There is the reverse linear connection between BMI and wrist fractures. The positive linear link between BMI and spinal fracture, but there were no link detected in other cases. Well, to sum up, what are the risk factors of osteoporotic fractures in case of diabetes mellitus? Well, complications caused by diabetes proper, such as nephropathy, and nephropathy is an important risk factor because electrolytes are being washed out in this case, and also vitamin D is low, neuropathy, diabetic diarrhea. Well, several studies have been conducted showing that diabetes mellitus can be an independent risk factors for fractures. Such diseases as diabetic diarrhea, as I have just mentioned, leads to the syndrome of malabsorption and the washing of electrolytes. As a result, leads to neuropathy. Also, diseases related to diabetes type 1, like Graves' disease and autoimmune disease, also stomach diseases resulting in malabsorption, amenorrhea, when there is the peak bone mass. In this case, children have a shortage of sex hormones, and that's also a risk factor, as well as GI problems. There are also a lot of data showing that people with diabetes mellitus are more prone to falls, and falls may lead to a large number of osteoporotic fractures with diabetes. This is due to hyperglycemia. Mostly we're talking about insulin and nocturia, when people just go to the bathroom at night and they stumble, and also poor eyesight due to retinopathy or cataract, orthostatic hypertension due to neuropathy, well, poor small finger motions or the joint motions due to arthropathy. Of course, such patients with diabetes mellitus and of older age should get special memos what to do in order to reduce the risk of fall. What are the main principles of treatment of osteoporosis in patients with diabetes mellitus? All patients with diabetes must be informed about the risk of osteoporosis and the risk of fractures by the diabetologist. Such patients get anti-diabetic drugs well on time, and these drugs have an impact on bones. But that's a totally different topic. But what should we avoid here? Well, first of all, we should avoid the administration of such drugs who have a poor glycemic profile. We must reduce the number of episodes of hyperglycemia to a minimum. We should also prevent chronic complications, especially renal impairment. We should prevent the risk of fall. We should administer calcium supplements with vitamin D, and patients should get anti-porothic specific drugs. Thank you so much. And this is a very famous character from Russian folk tales. She's a spellcaster, and she has both osteoporosis, and this witch also has diabetes. No one helps her. That is why she looks like a real witch.
Елена Михайловна, огромное спасибо за ваше сообщение.
Thank you so much for your presentation, Professor Agajanova. Let's move on. Questions will be at the end. The next presenter is Samson Khachaturian, neurological complications due to COVID-19. COVID-19 has been raised during all presentations, so we cannot talk about comorbid pathologies and just pass around the COVID-19. We can see that the Eurasian Association of Therapists has prepared the agenda, including all complications, including COVID-19. It's a great honor for me to give the floor to Professor Samson Khachaturian, neurological complications due to COVID-19. Good afternoon, distinguished colleagues. Thank you so much for the opportunity to speak on this subject. Yes, we can see that we continue to gain more knowledge in this or that field of medicine, and as for neurology and COVID-19, the association between these two conditions is one of such examples. Today, we'll be talking about the different manifestations. Well, at the very start of the pandemic, experts asked the question, should we expect neurological symptoms in the COVID-19 epidemic all too often? However, well, the data we obtained, especially the scientific publications, showed that indeed some neurological symptoms are rather spread among patients with COVID-19. And of course, the question was to what extent SARS-CoV-2 is neurotropic or not. As for the symptoms, they can be divided into three categories: symptoms and complications leading to the dysfunction of the nervous system, but within the systemic infection. They may be non-specific. The second group are neurological impairments as a result of the impact of the virus on the central nervous system or peripheral nervous system, also post-infection neurological complications. That's one of the first article about patients from China, 214 patients from China, and here you can see neurologic manifestations in 36% of hospitalized patients with coronavirus disease. Patients with the severe infection had higher chances of neurological impairments. You can see different symptoms, nervous symptoms. Again, you can see there is a difference between symptoms and complications, and you can see 35% had manifestations from the central nervous system, headache, ataxia, also peripheral nervous system involvement. One of the recent publications in this field, a large number of patients, 1,760 COVID-19 patients in Italy, and you can see that they had about 8% of neurological complications. Recently, I urged you to draw a line between symptoms and complications. Symptoms may be the manifestation of effects, but not the involvement of the nervous system. And in this study, there was a thorough analysis and the examination of patients, plus the necessary tests done, and 8% of patients in this cohort had neurological complications. Of them, 40% are cerebrovascular complications, such as ischemic stroke, hemorrhagic stroke, and TMI, and also Guillain-Barré syndrome, neuropathy, and the involvement of central nervous system, encephalitis, for example, and other impairments. As for the symptoms, the most widespread are headache, olfactory problems, visual problems, also vertigo. As for associated complications, they can be divided into central nervous system complications and peripheral nervous system complications, which I have already mentioned: the cerebrovascular pathology, meningitis, encephalitis, also Guillain-Barré syndrome, etc. Here is an example of the involvement of the central nervous system. You can see the ischemic stroke in patients with COVID-19. Here, there is nothing surprising because a lot has been said about the vascular pathology as the main comorbidity in case of COVID-19 and as the complicating prognostic factors or ischemic complications can occur in the brain. There are also cases of encephalitis and meningitis. These are the first clinical cases described in Japan and China. Well, in case of meningitis, well, you can see MRI made in Japan, and here you can see the well manifested involvement in the temporal lobe. Here you can see that patients with epilepsy, even controlled one, can have complications due to COVID-19, as in this case shown here. Also, there were de novo epileptic seizures, and so they well developed in patients who never had it, but had it after COVID-19. As for the peripheral nervous system, over the last several months, we have a lot of experience in Armenia as well as in Russia. Guillain-Barre syndrome is quite widespread, and what is interesting, together with COVID-19, it might be a rare option of Guillain-Barre syndrome, as you can see it here. There are also mononeuropathy, such as the Bell's palsy, and well, the olfactory system is also involved in this process when patients with COVID-19 lose taste or smell. Well, you can see the disease which is accompanied by anosmia, but after several days, everything goes back to normal. Well, again, as for the olfactory system, well, they can be the gateway for the direct damage to the central nervous system, as it has been shown here. Besides, the olfactory syndrome involved the basal areas of the brain were affected, and 28 days after the first manifestation of symptoms, well, the situation changed. Is the virus neurotropic? We already had a chance to study COV229E, SARS-CoV, MERS, SARS-CoV-2. They're also getting into the nervous system. There might be olfactory epithelium, cellular infection, passage through the blood-brain barrier. All these things are very well demonstrated on this graph, where you can see the passage of the virus through olfactory epithelium, and here you can see it goes through the blood-brain barrier by way of macrophages, and I should also note the peripheral mechanism for the virus to get from sensory receptors, peripheral receptors, which are located in the respiratory tract, through the steps to the prolonged brain. You can see the areas of brain which have the high concentration of ACE2 receptors, which are the main gateways of the virus, and the nervous cells that have these receptors. An interesting observation of our colleagues showing that the neuroinvasive potential of SARS-CoV-2 may play a role in the respiratory failure of COVID-19 patients. When the sensory receptors are involved, this may have negative effects such as respiratory arrest. Here you can see different types or groups of involvement of the nervous system. It can be systemic involvement, direct invasion of the nervous system, also hyperinflammation, multi-organ failure, hypercoagulation state, which might lead to encephalitis, also direct invasion of the nervous system, when strokes can occur, and encephalitis can happen. Also olfactory problems, and the post-infectious neurological complications such as Guillain-Barré syndrome, encephalitis, and encephalomyelitis. In conclusion, we can say that there is a probability of the fact that the virus is a neurotropic. This is the subject of heated debate. The neurological symptoms and complications occur quite often, as you have seen, and the involvement of the nervous system can explain the worsening of respiratory conditions and poor outcome in patients with COVID-19. I hope I did not exceed my time limit, and thank you for your attention.
Самсон Габриэлович, огромное спасибо за ваше сообщение. Я хочу подчеркнуть
Well,
особую важность этого доклада, потому
Professor
что с моей
Hachetran,
точки зрения
thank
это
you for
первый
your
доклад, посвященный
presentation.
неврологическим
This
нарушениям при
presentation was very
COVID-19,
important. It's the
всеобъемлющий,
first
охватывающий
presentation
все
devoted to
аспекты. Поэтому
neurological
еще раз отдельная
impairment in
благодарность.
case of
Ну, а мы движемся дальше по
COVID-19,
программе. И следующий
all-encompassing
спикер Омара
questions. So
Султана,
let's
который
move on,
поговорит,
and
продолжая
the next
неврологическую тему о
speaker
вторичных когнитивных
is
нарушениях в практике
Lamar
врача-терапевта.
Manukan,
Ламара, что-то у нас
secondary
затронет,
cognitive
наверное,
impairments
проблемы. Ведь
in
мы знаем очень
general
хорошо, что
practitioner
существуют
practice.
проблемы снижения
We
качества
know
жизни этих
that
больных, и многие
there
коллеги
are
возражают и
problems
говорят, что
of the
больного с
reduction of the
прогрессирующим
quality of
когнитивным
life of
нарушением
such
уже нет
patients.
никаких проблем.
Many colleagues
Проблемы
say
у
that
всех,
the
кто его
patient
окружает. К
with
сожалению, это действительно так.
impairment
Поэтому наша
has
задача
no
работать
problems.
с
The
когнитивными
problems
нарушениями
occur
пациента,
in
работать
those
для
people who
повышения качества
surround
жизни не
the
только самого
patient. So
больного,
we
но
need
и
to improve
близких,
the
которые
quality
его
of life for
окружают.
this
И я передаю
patient, and not
слово
just
Ламаре
the
Шотману.
patient himself, but also his relatives. Please, now the floor is yours, Professor Manukian. Good afternoon, distinguished colleagues. Alexander Grigorievich, thank you so much for the opportunity to speak here. Yes, for us, it's a difficult period, but nevertheless, we have this symposium, and I'd like to present a serious topic: secondary cognitive impairment in the general practitioner practice. Well, of course, today we're talking about the secondary cognitive impairment, especially non-debilitating that occur in at the primary health care in particular, and of course, general practitioners, therapists, and subspecialists, and all primary healthcare physicians. Well, the problem of cognitive impairment in patients with somatic diseases is a very relevant problem, because we must know that right now this is the problem which is very widespread, and it affects the brain, and the early detection of potentially reversible cognitive disorders is a must for an endocrinologist, for a cardiologist, because people come to them often first, and if primary healthcare physicians do not know how to detect the dementia, this is very important. Well, early correction, early control of dementia is important to reduce the manifestation of cognitive disorders and to reduce the degree of development of dementia. Dear colleagues, the problem of cognitive disorders is important for several reasons. The first reason is the quick progression of the disease in such patients, hence poor quality of life, the inability to work, and in many cases to disability, and the full dependence on people around the patient. The second problem is the low coverage with subspecialists who could prevent the progression of cognitive disorders. The third problem is the lack of real knowledge and skills about the early diagnosis of such people, especially at the primary healthcare level, and those subspecialists who see the patient first, they monitor the patient for a long time before severe dementia develops. Dear colleagues, there is another problem existing here. Often therapists, cardiologists do not understand the importance of early intervention and the early diagnosis of cognitive dysfunction. That is why, dear colleagues, I'd like to convey the main message. Early detection and early control of cognitive disorders at the primary care level leads to a better prognosis and a better quality of life. It slows down the development of dementia. We can help a patient do it. Dear colleagues, as for cognitive functions, we mean complex functions of the brain which are responsible for rational knowledge of the world, also help an individual correlate with the world around him. Well, of course, psychotic functions are involved here. You're all aware about the different cognitive functions. I'm not going to touch upon them due to the lack of time. Issues related to perception, hearing, speaking, etc. Memory loss can be the result of the cognitive disorder issues related to low IQ. Also, memory loss is a serious problem. First, you do not remember the events that occur now, then the events that occurred many years ago. Also, attention deficit disorder, aphasia, apraxia, and also the motor activity becomes very poor. You don't recognize several things, and of course, dear colleagues, cognitive disorders are multifaceted, and I should say that there are different reasons for that. The cognitive disorders often occur in older age. That is why it is important to pay attention to changes occurring with age and changes in the neurotransmitter system. Such changes in the older age can cause mild disorders, but they may lead later to severe disorders. Metabolic disorders is another reason. They may lead to decompensation of cardiovascular diseases, endocrine diseases, deficiency of B12, folic acid, renal insufficiency, hepatic insufficiency, respiratory problems, exogenic intoxication by drugs, by medicines, all that has an impact on the development of the cognitive function. And of course, at the primary care, you can control that psychogenic problems due to depression can also be a serious problem, well, plus organic diseases of the brain, such as neurogenetic diseases, cerebrovascular disease of the brain, brain injuries, and the brain tumors. Well, dear colleagues, you all know about the regulation of cognitive functions, cholinergic regulation, which is responsible for memory, dopaminergic regulation of short-term memory, well, the space orientation should be taken into consideration here. Noradrenergic regulation, serotonergic regulation, and also glutamate and GABA, gamma amino acid that regulates the system per se. Dear colleagues, let's look at the pathophysiological chain of different disorders. So first of all, the brain arteries will be damaged. There is ischemia. The white substance, the basal ganglia will be affected in this case, and the disorders develop. Pathochemical and molecular basis for the development of cognitive disorders are shown here. Acetylcholine level is changed in this case. As for the prevalence rate of cognitive disorders, you can see patients under 60 and older, well, the incidence rate is 12 to 15%, and I should say that up to 70% of patients of older age who come to a neurologist for this or that reason have this or that degree of cognitive impairment, 44% intermediate disorders that can be reversible. Dear colleagues, moderate cognitive impairments increases the risk of the risk of death from somatic diseases. You can see over 6-year follow-up period, 1/3 of patients died from somatic diseases such as cardiovascular diseases, endocrine diseases, etc. Cognitive decisions in 10 to 15% of cases can progress, and of course, within a 5-year period, we can see that 55 to 70% of such diagnosis is made over this period of time. The most widespread reason for dementia is Alzheimer's disease. Yes, it occurs in 60% of cases of severe cognitive disorders. Patients with intermediate impairment, this disease can be diagnosed in 17% of cases, but as for cerebrovascular diseases, in 60% of cases can have intermediate cognitive disorders. Well, we think that cerebrovascular diseases affect people of older age, and often we do not diagnose cognitive disorder in younger patients who already have signs of chronic brain ischemia. We do not pay attention to this, and this leads to the quicker progression of dementia. As for cerebrovascular diseases, I'd like to say that we have the character or the nature of cognitive defect related to the dysfunction of lobes, and we can have a post-stroke disease. Half of the patients who had stroke have cognitive deficiency. Well, moderate cognitive deficiency occurs in case of chronic brain ischemia when small brain vessels are affected, and also there might be problems related to the main vessels due to emboli, microthrombi, and these patients are usually detected by chance when we use different instrumental methods. Dear colleagues, we know that there is a connection between the blood pressure and the development of cognitive dysfunction. Antihypertensive drugs can delay the onset of cognitive dysfunction. There is a correlation between manifested cognitive dysfunction and the systolic pressure and age. 73% of patients have cognitive dysfunction and hypertension. Patients with a stroke who could not, well, usually have mild impairments. Patients with arterial hypertension also have emotional disorders. They occur in 62% of cases. Patients with emotional disorders often complain about poor memory as compared to patients with moderate emotional complications. The problem of weight or obesity is another serious thing, especially in patients with atrial fibrillations. D-dimers, are affected, and you can see cognitive disorders in patients with atrial fibrillation occur in 14% of cases, in 43% of cases, and with the sinus rhythm in 14% of cases. And the development of dementia is increased by a factor of 2. Atrial fibrillation increases the risk of dementia in patients who usually had the normal cognitive level. You can see the post-stroke cognitive deficiency up to 70% are patients who had stroke. This leads to poor compliance to treatment and ineffectiveness of secondary prevention. After that, repeat strokes occur with the more serious manifestation. Well, as for atrial fibrillation, I should say that those who had myocardial infarction had dementia developed 5 times as much as compared to moderate cognitive impairments. In this case, that have more myocardial infarction. People with heart failure have a higher chance of Alzheimer's disease. In case of respiratory diseases, well, for example, mild or immediate COPD, in 30% of cases, there will be moderate cognitive problems. Patients with the COP have a 4-fold increase of the risk of cognitive impairments. Diabetes mellitus, well, again, elevated glycated hemoglobin by 7% can lead to a higher percentage of the risk of the development of mild cognitive impairments. In case of diabetes mellitus type 2, 20% of men and 18% of women older than 60 have cognitive impairments, and only 36% with diabetes mellitus type 2 have such disorders. Diabetes mellitus type 2 reduces the risk of Alzheimer's disease by a factor of 2. People who are 45 or over, 5.5 years later, have the risk of the development of Alzheimer's disease at the level of 65%. Renal insufficiency, I have already mentioned it. 87% of patients on hemodialysis have moderate cognitive impairment. Reduction of glomerular filtration rate to more than 60 milliliters per minute increases the risk of development of cognitive impairment by 37%. Less than 60, these are patients in the first stage of renal insufficiency. So in this case, it can develop even further. Alcoholism, well, the frequency of dementia is 10 to 20%. Well, alcohol dementia accounts for sometimes 50% of all cases of dementia. At 60, 65, the reason for dementia in 22% of cases is alcohol. Dear colleagues, vitamin B12 and folic acid. We know the shortage of the substances that might lead to neurodynamic disorders, attention, concentration wanders, memory becomes poor, you have problems with learning, etc. So drug-induced cognitive disorders. You can see a list of drugs that can lead to cognitive dysfunction. As a therapist, I'd like to pay attention to diuretics, statins, and digoxin. Statins do not cause a cognitive impairment, especially if you use the hydrophilic statin. But as for diuretics, hyperdiabetes, in case of high dose of diuretics, there might be 30% or more cases of clinical disorders as compared to other drugs. Post-operative cognitive dysfunction occurs in 25% of cases. It is persistent in almost 10% of patients after 3 months following the surgery. There might be other factors taken into consideration, previous disorders, issues related to anesthetics, modulation of blood circulation, and protective drugs. So here you can see the classification of cognitive disorders: mild, intermediate, and severe. Mild means the mild reduction of cognitive abilities as compared to pre-morbid level. And of course, the standards remain the same. Patients have a lot of complaints in this situation in case of cognitive disorder. And this reduces the quality of life.
Мы сильно задерживаемся.
Хорошо.
Well, intermediate, moderate, and severe cognitive disorders, we know that they lead to a memory loss. Sometimes you don't remember current events than events that occurred much earlier, events such as a poor memory for names, issues related to a loss of the sense of time, difficulties in budgeting your time. Colleagues, I'd like to show you the criteria of moderate cognitive disorders. As you can see them here, well, of course, you should pay attention to what the patient tells you. Also, neuropsychological tests that should be done in this time. A recent reduction of the cognitive function as compared to the previous level, a less of proper everyday activities and dementia. This is the Peterson classification. It is self-explanatory. I don't have time for this. And moderate cognitive impairments with the violation of space functions, speech functions, and combined cognitive disorders. How should we diagnose cognitive disorders? Look at patient's complaints and maybe patient relatives' complaints. Next is neuropsychological tests. I'm going to present several tests and whether the patient can care for himself. That's another question. Does he have problems in the daily life, in his profession, or he needs the assistance of people around him? So, dear colleagues, you can see mini cog test that doctors use. It's very simple, and we offer primary care physician. We offer it to primary care physicians. Patients with moderate cognitive disorders do this test very well. So we cannot make a proper diagnosis if this test is used for a moderate cognitive disorder. This is a mini mental state examination. This scale should be used by all therapists. You can see 20 23 points pre-dementia, and the most sensitive score is the Montreal scale. As you can see it here, 7 tests to assess moderate cognitive disorders. Dear colleagues, besides this, we must also use instrumental diagnostics, MRI, duplex scanning can get very good results, and of course lab tests to detect the different deficiencies and changes in biochemistry. The principles of treatment of cognitive disorders, early diagnostics and early therapy. Naturally, patients should be thoroughly examined to exclude potentially irreversible disorders. Also, we should pay attention to diabetes mellitus in this case, and of course, a neurotransmitter therapy. You can see the drugs, which are very well known to you. They improve the cognitive function, and of course, they have an impact on neuromediator systems. Unfortunately, not all these drugs are used in primary health care system, but as for drugs improving the microcirculation, they can be used easily at the primary care level in order to slow down the negative progression of the cognitive function. And of course, cognitive trainings can be of great use. Avoid stresses, have a normal sleep, different physical activities, social activities, communicating with your friends, walking in the fresh air, balanced food. Protein should be in your nutrition, and naturally, I'm sorry, we have to finish because we are lagging behind 15 minutes. I'm sorry about that. Well, thank you very much for your attention. Okay, now we have the next presenter, Bagrat Lalayan from the United States. The COVID-19 guidelines in oncology is the theme of this presentation. At the very beginning of the pandemic, we thought there would be a lot of patients with COVID-19 and cancer. In fact, it was not exactly so, but the management of such patients is a serious problem. Bagrat Lalayan, the floor is yours. Thank you very much to the organizers of this conference to speak today. I'd like to welcome all participants in the conference, as well as my distinguished colleagues with interesting presentations. I'll try to be as brief as possible because we're already exceeded our time limit. As for my presentation, it is devoted to modern recommendations which exist in the United States on management, screening, and diagnostics of patients, cancer patients, bring to bear the COVID-19 pandemic. I think these recommendations will be interesting for other countries because I think they are basically the same, and they would be good for therapists. So what are the major challenges today? The major challenges today are that the number of visits to oncologists has dropped. Later, I'll talk more about this. This is not due to the fact that oncologists reduce the number of visits, but patients, because of the fear of contracting COVID-19, try to reduce the number of visits to healthcare facilities. Also, delays in cancer screening leads to significant declines in patients with newly identified cancers. But in the future, unfortunately, we have more patients, advanced cancers, metastatic cancers. Also, there are postponed surgeries or cancellations, and physical distancing in the office leads to the psychological component, and the use of telemedicine, virtual technologies for communicating with doctors. Well, even in the US, although they're very widely spread, not everyone can have access to them. What are the measures that we should use to protect people? We should think not just of patients, but also doctors. Patients must answer a number of questions on the phone before going to a healthcare facility. They should answer such questions as whether they had someone with whom they talked or communicated and they had COVID-19. So you should ask patients when making appointments if they have experienced COVID-19 systems or were tested for COVID-19 or have been in contact with anyone with COVID-19. Well, universal masking is another aspect. Wearing masks leads to poor communication with patients, and that's important for patients with cancer. So telemedicine should be used instead of it because in this case, when doctors have to wear masks, there will be no emotional contact. Physical distancing, again, there should be special methods of caution used, like more time between appointments, special rooms for interventions, etc. Naturally, we know that there are limiting factors in terms of recommendations for surgery and chemotherapy. Of course, every person scheduled for surgery requires COVID-19 screening prior to it. If COVID-19 is diagnosed, well, all interventions should be postponed, especially when we're talking about targeted therapy or immunomodulators. These drugs can enhance the symptoms of COVID-19 because their immune system is in a very difficult condition. And thanks to because of the previous immunotherapy, also there is a need to reduce hospital stays, and more time should be placed on telemedicine. Telemedicine is now the main factor of providing constant contacts between oncologists and patients. Also, the number of visitors should be reduced. Patients should come alone to healthcare facilities without their relatives or family members, but it's not very convenient for patients because it's important for such patients to come to a healthcare facility with their relatives, with their spouses. They provide psychological support. Well, right now, we can put relatives to neighboring rooms, and again, we should use all methods of caution. Despite all the talks that surgeries should be postponed, that chemotherapy should be put off, as well as radiation therapy, and this, as many say, will lead to a reduction in the number of COVID-19 cases, but this hasn't been confirmed. Right now, there has been no single study showing that if we postpone visits to oncologists, this can reduce the risk of contracting the coronavirus. Once again, all recommendations say that patients, especially those who are in the high-risk group, must have treatment according to the plan. Of course, all cases of chemotherapy should be discussed on a case-by-case basis. Patients on palliative therapy or supportive therapy, again, this therapy is not a priority in this case because it does not preserve the vital functions, does not lead to the extension of life expectancy. So this therapy can be conducted at home. And again, treatment delays may lead to worsening symptoms, especially when we're talking about radiation therapy and poor prognosis of treatment. A study was conducted with the involvement of nearly 600 patients who presented their experience of treatment in the pandemic. 83% lived in the United States, 42% were on active treatment, and most patients reduced the number of visits, and you can see they did it on their own. There were no delays on the part of healthcare facilities, but there were delays with screening programs, routine mammograms, with radiation therapy, hormonal therapy, chemotherapy. About 30% of patients reported no delays due to the pandemic. And about 11% of patients reported that COVID-19 had affected their desire or ability to get a second opinion. In the United States, it's very popular when patients can come to different healthcare facilities to get a second, even a third opinion. Here you can see the priorities in treatment of breast cancer. You can see patients can be divided into three groups: high priority, medium priority, and low priority. High priority patients have conditions that are immediately life-threatening or need urgent treatment. They are post-operatively unstable, so they should get treatment regardless of the risk of contracting COVID-19 or other diseases. Medium risk patients are newly diagnosed patients, so they should start treatment right away. Also, patients with new comorbidities, patients who received neoadjuvant therapy, and the patients in remission, patients who are fighting for their survival, and for them, routine visits can be replaced by the lesser frequency of visits, maybe not once in 3 months, but once in 4 or 5 months. Right now, in the US and in the United Kingdom, home care services are becoming more popular. That's chemotherapy or palliative care. Well, but for that, patients should be more or less stable to get home care. Also, all hygienic conditions should be observed. There should be a separate room for patients so that he could not contact with other people, as well as other sanitary standards reducing the risk. The use of chemotherapy is done due to intravenous injection of drugs. Also, oral forms are more preferable, as well as those drugs which have a lesser number of side effects and better tolerability. In conclusion of my presentation, you can see the ASCO recommendations, American Association of Clinical Oncologists. Again, we prefer drugs which can be taken orally, and again, chemotherapy schedules may be modified to reduce clinical visits, for example, using a 3-weekly dosing interval. As you can see it here, attention must also be paid to managing adverse events such as neutropenia. Dexamethasone can lead to immunosuppression, especially in the case of the pandemic. All these recommendations were developed on the basis of clinical trials. They are in progress in the United States, but with a lot of delays because patients included in clinical trials had been on different treatment before that. Patients with metastatic diseases with a poor prognosis. And of course, here, all measures should be taken to prevent the contraction of COVID-19. And despite that, studies continue, although with some delays. And following these recommendations, we can achieve a success and provide our patients with new drugs. Thank you for your attention. I wish you peace and every success in your endeavors. Thank you. Thank you, Bagrat Karanovich, for your interesting presentation. That's really a serious problem. We have a lot of difficulties in managing such patients. Well, as for the Q&A session, it will be very short because we exceeded the time limit. Samson Gabrielovich, if you are still with us, please turn on your screen. You got like a dozen questions devoted to anosmia, and that's the first question. And the second question is, can these neurological conditions be mild? Well, so a loss of taste, what you should do here in this case. Some of my colleagues, by the way, who had the COVID-19 several months ago, still have a lack of taste. Thank you so much. As for the first question concerning the lack of taste duration, well, there are several studies showing that it can persist, this symptom can persist for a long time. But nevertheless, we should expect that sooner or later your taste will come back. Right now, it's hard to say that you will restore fully, but even after several months, as data have shown, this problem may be resolved. And as for the second question, as far as I remember, relates to whether neurological complications can develop in case of the mild COVID-19 case. Yes, it's quite possible. Some studies have shown, for example, the peripheral involvement, especially Guillain-Barré syndrome, occurs in patients with more respiratory manifestation of the disease. As for the central nervous system involvement and the brain involvement, well, this can also happen when patients are asymptomatic. So this question is still open. Thank you. Thank you very much. Unfortunately, we have to wrap up this Q&A session and close this breakout symposium. Colleagues, thank you for your time. Thank you for sharing your experience. We hope to have more sessions like this. And now we move on to the closing ceremony of the conference. This is an unprecedented conference. I can boast the statistics to those who are still here, because right now, during the first 2 days, more than 65,000 people watched this broadcast. Right now, today, we had 15,000 people, 25 countries participated in the conference. The conference is conducted in English and Russian. To those who had a vested interest in these issues, the format is a bit unusual, but we covered the most key topics. That's how science moves forward. Of course, COVID-19, you can't escape it now, and during those 3 days, the topic of COVID-19 emerged in different discussions. Targeted organs rehabilitation, kidney insufficiency. Well, yesterday there was a big red breakout session devoted to anticoagulants, where everything is changing. Anticoagulants can now be used in case of coronary heart disease. Today's speed session devoted to diabetes is CHF and CKD. Here, some studies have been completed and the results were presented. Endocrinology, osteoporosis, diabetes mellitus, experts shared opinions in case of differential diagnosis of different rheumatological diseases. We discussed antibacterial therapy and the antibiotics resistance, which is an important factor as far as these questions are concerned. We discussed different aspects of neurology. We had experts from Thailand, the US. We tried to bring together the most new, the most shining, the best scientific minds, and this was done in a new educational format. That's the Future Forum, the Speed Session, and the online format. And you had the chance to talk to our presenters in Zoom rooms. I'd like to thank those 75,000 people who listened to us, doctors from different countries. I'd like to thank you for your hard work in these difficult conditions. I just mean not just working in the red zone, but also those specialists who work harder due to COVID-19. Thank you for your perseverance. Thank you for asking questions, for the participation in the discussion. Without questions, without a discussion, we cannot share opinions in the healthcare field. I'd like to thank all our speakers. More than 100 speakers participated in this conference. I'd like to thank the moderators in this halls, Vladimir Salk, St. Petersburg, and Natalia Kozola from Perm. They contributed a lot to the development of the educational factor in the healthcare system. I'd like to say in conclusion, stay well, continue to learn more even at this difficult time for the system of education. It is through our concerted efforts we save the lives of hundreds and millions of people. Remember about that. We should share our experiences all the time. Stay well and see you next time.
Труд в медицине, поверь, не мед. Славы в ней нету и нет банкнот. Только готовность помочь всегда. Нас вспоминают, когда беда, беда. Снова работаем, снова с заботою, снова идем к нашим больным. В красную зону держать оборону. День простоим, ночь простоим. Сутки без роздыха, и нету воздуха, давят очки. И рот пересох, но ты же знаешь, зато тебе с небес улыбается Бог. Слились работа и сон в свой круг. Слились работа и сон в свой круг. Редко проводим с семьей досуг. Редко проводим с семьей досуг. Но тяжелеет больной. И вот тяжелеет его. Вот долг наш врачебный опять зовет. Снова работаем, снова с заботою, снова идем к нашим больным. В красную зону держать оборону. День простоим, ночь простоим. Сутки без роздыха, и нету воздуха, давят очки. И рот пересох, но мы же знаем с тобой, что нам с небес улыбается Бог. Всюду со смертью идет война. В каждой победе своя цена. В наших сражениях всего трудней. Что мы теряем коллег, друзей. И снова кажется, что смерть куражится, вырвав опять кого-то из нас. Но свой вспомнив, он вдруг по наклонной тихо угас, тихо угас. Горе прибавится, что нам останется лишь третий тост. На тягостный вздох мы точно знаем, что им там в небесах улыбается Бог. Мы точно знаем, что им там в небесах улыбается